Welcome to the City of Eight Lakes.
Every day is the chance to do better. Namaste.
A warm good morning to the Excellencies, distinguished guests, participants, ladies and gentlemen.
We are very happy to receive you on the 10th Annual Conference of Nepalese Society of Neurosurgeons 2022 in this beautiful city of Pokhara. Myself, Dr. Navraz Karki,
And Dr. Asha Jalas are honored to be your host for the day. We wish each one of you a pleasant and fruitful stay in the city of Pokhara.
over these 2 days, the event will provide us plenty of opportunities and discuss policies and procedures, share knowledge and insights.
We're so glad this year we're joined by esteemed dignitaries and promising neurosurgeons amidst a scenic with an ever so rainy morning in Pokhara, the first time outside the capital of Kathmandu.
Today, we'll have glorious opportunity to mix and mingle with our fellow delegates from all over Nepal and abroad over scientific sessions, dinner, and entertainment.
This conference will provide us with a great opportunity for prospective participants to show their recent theoretical knowledge, research findings, experience on the field of neuroscience, a very promising field at present and future.
Hence, with best hopes that we make pleasant memories and fruitful achievements, we would like to kickstart the day by inviting the President of NESON, Dr. Pravin Shrestha, to formally welcome you to this grand annual event. He is a senior consultant neurosurgeon and neurospinal surgeon based at B&B Hospital and Novik International Hospital, Kathmandu. Please welcome him with a huge round of applause.
Respected seniors and colleagues, good morning and namaste. Well, I don't know whether we should start it or not, because many of our participants are yet to come. Anyway, it's already more than 10 past 8 a.m. today, so I think we have to start it. We should go with our schedule. Anyway, I'm Pravin Shrestha, currently serving as President of Nepalese Society of Neurosurgeons, NESON. And on this very occasion, I would like to extend my greetings and namaste to all of you as an organizing president of this conference on my own behalf, on behalf of the organizing committee, and on behalf of the current executive committee of NESON. At this moment, I would also like to take this opportunity to welcome you all to this mega event of neurosurgery of Nepal. This was the very day that we are waiting for since almost 1 year. And we have been making this preparation for last more than several months. And finally, the day has come, and it started yesterday. It will go on till tomorrow. This is the 10th annual conference of NESON since the inception of NESON in 2007. So it's been already 15 years that NESON was established, and every time NESON is getting matured. And I believe by now, NESON is fully matured. Well, so far, NESON has organized, hosted, and carried out many national and international events so far in last 15 years of its history. And this time, it's again another step in the milestone of NESON. So this time we have made the theme, dissemination of neurosurgical service in Nepal. And that's why today we are in Kathmandu, out of Kathmandu. We are in this beautiful city of Pokhara, trying to disseminate these neurosurgical activities throughout the country. I believe this conference will help broaden the horizon of our neurosurgical knowledge, experience, and also to widen the arena of neurosurgical practice in our career in near future. I fully believe you will enjoy this conference thoroughly, and also I anticipate you will fully and actively participate in this conference. Well, before I finish, I would like to inform you that, or probably you might have already known, that next year, 2023 September, we are going to host and organize South Asian Neurosurgical Congress, which is going to be the 8th one, and which is going to be the 3rd one in Nepal. So for that also, I would like to request you for your kind support and participation. So once again, welcome to this 10th annual conference, and welcome to this beautiful city of Pokhara. Thank you very much for your invaluable support. Thank you.
Thank you, sir. It's an honor to have you here with us today. Now, joining all the way from Japan is Professor Yoko Kato, President of the Asian Congress of Neurological Surgeons, Professor and Chair of the Department of Neurosurgery at Fujita Health University, and the first lady in Japan to be promoted to full Professor of Neurosurgery. Professor, it's an honor to have you with us here today, and we'd love to hear from you.
Hi, good morning, everyone. So thank you very much for the kind invitation. So I congratulate the 10th annual conference of the Nepalese Society of the Neurosurgeon, and this is already the 10th. So I appreciate the great effort to make the number is already 10th. And also this time is some topics is our theme is the dissemination of the neurosurgical service in Nepal. So I think in the future, of course, the medical student or resident or the young neurosurgeon who is taking over the Nepalese Neurosurgical Society, I think it's minimally invasive or less invasive for the patients. And that is one of the big concepts, how you can treat for the patients. So that means is, of course, I think endoscopic treatment or maybe the direct surgery, I think bypass surgery can be.
Professor, my apologies for interrupting you, but due to technical difficulties, we were unable to hear you. Could you please unmute your mic?
So you cannot hear my voice. Hello? Hello, can you hear my voice? Hello? Hello? Hello?
Yeah, ma'am, I can hear you now. Yeah, thanks for
Can
unmuting,
you hear? Should I continue?
ma'am. Just
なんか
begin.
ちょっとうまくいってないみたいなんだけど。してくれますか? So can you hear my voice? So Junaid?
Kato sensei, 聞こえますか?
I can hear your voice. Can you hear my voice?
はい、もう一度すみませんが、先生。
Hey, can you hear my voice?
Yes, yes, please go ahead, please.
From the beginning or maybe in the middle? Maybe I think anyway, I congratulate the Pravin that you are the president of the 10th National Congress. I think I want to give some short message to especially the young medical student or resident or YNS of Nepal. I think you will be taking over the next the Nepalese Neurosurgical Society. I think you should always keep in mind the minimally invasive or less invasive for the patient. That's a concept is very important. And in that means, I think endoscope and also such kind of the bypass surgery or exoscope. So those the new devices will be, I think, very, very important for the next generation. So I think all of you, you will learn so many the topics in the next 2 days. So you can learn many, many things from the conference. And of course, we are all Asian, the neurosurgeon, we can support your country. And maybe time to time we can visit your country, and of course the demonstrative the surgery and also the hands-on workshop together with your society. Wish you very successful the Congress, and also please feedback, especially for the young generation. Praveen, thank you very much for making such a wonderful Congress. I think we can continue our collaboration in between the Asian Congress and also the Nepalese society. In the future, maybe I think that you can have an Asian Congress in your future. Thank you very much for the occasion. All the best.
Thank you very much, Professor Kato Sensei, for your message, and thank you very much for your support to us from the right beginning till now, and definitely we'll be hoping your support in the days to come as well. Thank you very much, madam. Thank you very much.
Thank you very much.
Thank you so much, Professor Kato, for your inspiring words. Now, may I request the organizing coordinator, Dr. Bal Gopal Karmacharya, to welcome you all with his kind words. Dr. Karmacharya is the Chief of Neurosurgery Unit at Manipal Teaching Hospital and President of Brain and Spine Foundation, Nepal. Thank you.
Hello. Namaste. Good morning. First of all, I'd like to thank the executive of the nation for allowing us to host this national conference, first time outside of Kathmandu. And we are really honored and grateful to the executive for having trust in us. As I understand, the Pokhara is the first city outside of Kathmandu to have the neurosurgical facilities. As per my knowledge, Professor Pawan Sharma and Dr. Basant Panta used to come here and see the neurosurgical patients. And later, Dr. Panta and his team started to provide the operative surgery in the Western Regional Hospital. And later, Dr. Cherian joined Manipal Teaching Hospital, where I'm working now. So in last 10-15 years, the neurosurgical services has taken a great leap in Nepal, but there is a lot more to do, and I hope with the support of the national and international faculties, seniors, to guide the young neurosurgeons, we can achieve great things in the future. And I think this conference is one of the steps in that direction. I thank you all for taking your busy schedule to come to this city and attend this and participate in this conference. Thank you very much.
Thank you very much, sir. I would now like to invite the President of NESON, Dr. Praveen Shrestha, and the General Secretary of NESON, Dr. Sudan Dakal, to introduce a featured speaker for the day, Professor Dinesh Rajbuju.
Once again, namaste and good morning. Well, in this conference, we have added a small new thing. Slightly we changed. Actually, we tried to imitate the things that they do in India and abroad. So this time, copying something good is really good. as Samsung told when they copied iPhone. The new thing is that we have introduced this session of featured speaker, in which we invite somebody who is highly qualified, who is honored in the society, and who has contributed significantly in society for the sake of benefit of the people. So this time, we are really delighted to invite Professor Dinesh Raj Bhuju from Kathmandu as a guest speaker or featured speaker in this session. So before I invite him for his talk, I would like to give a brief presentation. Regarding Professor Dinesh Bhuju, he is a research scientist, he is a teacher, and he is a crusader of voice for science. That means he advocates science, he promotes science, he talks science, he does everything the way science does. So he's a strong and strict follower of the science. That's why he's also known as science communicator. At the moment, he is involved in NAST. Previously, it used to be called RONAST, Nepal Academy of Science and Technology, as an academician. He is a PhD in ecology in 1998 from Japan. He's also honorary professor in the Midwest University. He gives lectures about environment, science development, and philosophy in different universities in Nepal and abroad. He pioneered ecological studies of Chure Hills and climate impacts on tree lines in Nepal, Himalaya. And recently, he also coordinated drafting of Nepal's national policy of science. This is the brief, formal, and professional introduction of Professor Bhuju. But the way I knew him is something different. So I want to take probably 1 more minute of your time to introduce him more informally and I shouldn't say non-professionally, but it is also part of his profession. I'm sorry if I speak in Nepalese. धेरै लामो समयको कुरा हो, 35 वर्ष जति अगाडिको होला, when I was studying at the grade of 9 or 10. It was almost 35 years back. त्यति बेला Radio Nepal used to be the only source of infotainment for us. Probably that time there was already Nepal television as well, but Radio Nepal used to be very, very popular. Unlike this time, there was no FM and no other things of infotainment. त्यति बेला रेडियो सुन्न भनेपछि हामी सानो 9-10 क्लासको बच्चालाई पनि रमाइलो लाग्थ्यो र स्पेशली शनिबारको दिन आएपछि हामी रेडियो अगाडि झुमिहाल्थ्यौँ। यस्तै हामी 9-10 क्लास पढ्ने अथवा सानो ठुलो हाम्रो दाजुभाइ दिदी र झुमिन्थ्यौँ। प्रोबाब्ली हामी सबैजना त्यस्तै नै थियौँ। त्यति बेलाको कार्यक्रममा शनिबार भयो कि अझै विशेष हुन्थ्यो। विभिन्न कार्यक्रममा चाहिँ सबैलाई थाहै छ, यो म्युजिकको कार्यक्रम आउँथ्यो, नाटक आउँथ्यो, विभिन्न आउँथ्यो। त्यस्तै एउटा कार्यक्रम बिहान 9-10 बजेतिर आउने गर्थ्यो। त्यो कार्यक्रम थियो विज्ञान र प्रविधिको कार्यक्रम। अनि त्यति बेला the program was about science and technology, and that program was used to be sponsored by RONAST. That time it was RONAST. अनि त्यति बेला अघि मैले भनेको जस्तै हामी जस्तो सानो सानो 9-10 क्लास पढ्ने बच्चाहरूको लागि पनि सो इन्ट्रेस्टिङली त्यो कार्यक्रम प्रस्तुत हुन्थ्यो। यति मिठो स्वरमा यति राम्रो प्रस्तुति हुन्थ्यो कि हामी जहिले पनि every time when the Saturday comes, we used to be in front of the radio, tuning it on and looking forward to hear that program of science and technology. त्यति बेला मलाई अझै याद छ त्यो स्वर जसको गुन्जिन्थ्यो त्यो मान्छेलाई भेट्न पाए हुन्थ्यो। कस्तो होला उहाँ, कति मिठो स्वर छ, कस्तो प्रस्तुति छ भनेर म अझै पनि सम्झिन्छु। मैले कुनै यो बढाइ चढाइ, I am not exaggerating, in fact. This is what I used to feel that time. Probably same with you as well. And fortunately, आज भन्दा 15 वर्ष अगाडि, 15 years back, I happened to meet him. उहाँसँग मेरो भेट भयो। उहाँ पनि जापानको ग्रेजुएट हुनुहुन्छ, सिनियर हुनुहुन्छ। त्यस अर्थमा हाम्रो भेट भयो र त्यसपछि उहाँसँग धेरै कुराहरू भयो। त्यो मिठो स्वरको धनी र त्यो मिठो प्रस्तुतिको धनी उहाँ नै हुनुहुन्छ प्रोफेसर दिनेश राज भुजु, जसले त्यो कार्यक्रम हामी बच्चाहरूको लागि पनि रमाइलो तरिकाले उहाँले प्रस्तुत गर्नुहुन्थ्यो। Okay, so now without further wasting time, now I would like to request Professor Dinesh Raj Bhuju. Sir, please take the podium and please go ahead with the presentation. Thank you.
this point, we have taken almost 10 minutes in introduction. Okay, that was my introduction. Ready? Who prepared this introduction? One point was the missing point was that I was real. I grew up in this city. Very close, just a stone from distance, is an official residence of government staff. And my father was a government staff. We lived on the bank of the river. And I had an uncle. They used to get me to fishing that way. How did I enjoy this wilderness story that capturing the small fish? And one of the stories told me that say which time good. Why something like that? What was the point? It was a English like in the United States. More than that. Ukraine and our respective senior Neurosurgeons. What is neurosurgery? Well and good, if not, please. There is my position. My lecture at so that would be one reason why I was invited to this all this gatherings of Neurosurgeons. Otherwise, it's not a piece of my day. The title of my presentation that I propose is Scientific Culture and Philosophy. Does it sound interesting? Not sure. But the good news is that I do not have PowerPoint slide. And bad news? No. Because science is not the cultural backyard. It is a good business of good people like Neurosurgeons who say life. Can you tell me how many people you have still? I hope you have the numbers down. Every time you come to such a video. If not, please start keeping the number recorded. Without numbers, science is just a philosophy. This is to tell you that I have numbers in my talk to put you all on your toes. Now, please allow me, Dr. Praveen, to begin my talk. Chair of the session, participants, especially the past president of NESON, Dr. Pawan Sultania, Dr. B.P. Singh, and invited participants from India and many others, and participating all Neurosurgeons. Ladies and gentlemen, we are in the year of 2022. From the year 1 AD, that is 2021 years ago, to 1800 AD, that is 200 years. That means for 1800 years, the world GDP per capita was merely 600 US dollar. And it was running for 18 years, almost flat. In 1980, the GDP per capita doubled to 1,200. In 2000, that is 22 years ago, it increased by 10-fold, 10 gunale. Today, as projected by IFM, the world GDP per capita is 12,833. Story next. The demographic research suggests that at the beginning of the 19th century, that is 200 years ago, the world had a life expectancy of approximately 35 years. Today, the United Nations have estimated that our life expectancy for the world is close to 73 years. More than double, isn't it? So if this hullabaloo, this astounding economic growth and enhanced human life expectancy sound miraculous, just give a thought, what could be that magic wand? Like that of Harry Potter. For the economic growth and human prosperity, the intellectual world like you, I'm sure without any hesitation, credits to the Industrial Revolution, which reminds us the steam engine of James Watt. And it was a period of major innovations that started in Great Britain and spread around the world during 1700 and 1800 AD. The Industrial Revolution transformed economies that had been based on agriculture and handicraft into economies based on large-scale industry, mechanized manufacturing, and factory system. And the new machines, new energy sources, and new ways of organizing work made existing industries more productive and efficient. In 1928, penicillin was discovered by Dr. Alexander Fleming. It was nearly 7 decades since the germ theory was published, postulated, and science had established a link between germs and diseases. In 1945, the World War II ended with estimated loss of 75 million people. What about the penicillin? How many people saved it? Well, it is impossible for us to know how many lives this penicillin, this antibiotic, prepared from a modest mold to see. Saved, it is estimated still, it saved around 80 million to 200 million human lives, long time back. See the miracle of science. Besides steam engines, antibiotics, many more wonders were invented. Was the necessity a mother of those inventions? I'm not sure, but I disagree. Had it been so, had it been necessity is the mother of inventions. Humanity did not have to wait for millennia to get rid of hunger, to get rid of poverty, to get rid of pandemic and disasters. Then what is inventions? For me, the inventions were or are or will be a scientific way of thinking and scientific method. Only scientific thinking and scientific method help you invent new discoveries. Science helps us understand the natural laws that leads to new discoveries, which ultimately transform the human society. For example, in a steam engine, steam shooting out through the holes creates an action force that is accompanied by an equal reaction force, but in opposite direction. The principle is, as you know, Newton's third law of motion, postulated in 1686. 12 years after this Newton's law, a steam engine was developed and patented. And next example is the scientific method of verification. Louis Pasteur developed germ theory in 1860s and stipulated that bacteria cause infection and disease. But hardly few scientists of his time trusted him. And to convince the adamant contemporary scientist, Pasteur developed a standard format of IMRAD, introduction, methodology, research, and discussion of scientific reporting, so that one can repeat the experiments and challenge for verification. So the scientific thinking and methods together make foundation of science culture. Then what is science? A general perception is that science is a body of knowledge amassed through systematic methods. Some view it as a course curriculum you have in the school. Many of us also think that science is an advanced tool used in modern society, like the mobile you have in your pocket. However, science is not only a body of knowledge. It is not only a school curriculum. It is not only the technological tools. Science is far more bigger and greater than that. For nearly 2,000 years, the world accepted a geocentric model of the planets, which placed Earth at the center of the universe, with all celestial bodies revolving around it. Then who instilled Nicholas Copernicus a courage to go against the world and propose the heliocentric model? Simply the fact it was the culture of science, because science is a way of thinking. In the words of Carl Sagan, a champion of science communications and promotion, science is a way of skeptically interrogating the universe with a fine understanding of human fallibility. Human make error. Science find them and correct. Originality, independence of thought, and dissent are characteristics of scientific culture, and therefore a challenge to establish cultural values.
Science culture is a set of norms and practices and ethos of honesty, openness, and continuous reflection, including how research quality is judged. It influences the conscious and unconscious thinking process of decision makers, including you, and methods they use to make decisions. You are also decision makers when you are on the OT table. You have to decide very quickly what to do and how to do. And that time, the science culture plays the most important role. It is mentioned that science is among various cultures that seeks to describe natural phenomena. Then why scientific culture is important? The most important function of scientific culture is to transform primitive thinking into logical thinking and then into scientific thinking. Is science and technology a culture? You may have a question in your mind. In one sense, culture is a collective mode of thinking that distinguishes one group from another. Science and technology together, being a social phenomena based on collective effort, must necessarily be included as forms of the social organization of culture. So together you, neurosurgeons, make scientific culture of neurosurgeons. In the last decades, scientific culture has become a theme much discussed at all levels of public discourse. All scientific and technological policies developed in the last few years in OECD countries have included scientific culture as one of their aims, principles, and objectives. Despite the ubiquity of the term scientific or science culture, which varies across the countries, across the groups and individuals, yet what we all agree is that science and technology together, being a social phenomena based on collective effort, must necessarily be included as forms of the social organization of culture. And there are many reasons why we should value the scientific culture. Some experts emphasize its value in terms of citizens' cultural development. Some see scientific culture as a prerequisite for economic development and innovation, while others emphasize the social aspect of scientific culture, which enable people to understand the scientific basis of modern society. So they play an active role in social debates. But regardless of the various culture and civilizations that have influenced science, what is common to all scientists is that they study natural phenomena with an appropriate set of rules to make generalizations and predictions about nature. So the mission of science was to discover laws of nature and thereby explain all natural phenomena. This faith in science rise into the philosophical movement which we call positivism or scienticism, which led to widespread trust in science and technology and influenced the social theory. The faith in the possibilities offered by scientific progress still shapes the belief and actions of the people today from all walks of life. In fact, expressions such as "this has been scientifically demonstrated" are often used to cut short your discussion and debate, you must have realized. Generally, scientific culture is a value system about scientific values, spirits, beliefs, conventions, attitudes, and methods within the scientific community after institutionalization and customization of society. Scientific culture is also a catalyst to make traditional culture continuously updating and modernizing. Scientific culture emerged and developed based on a certain cultural background, and at the same time had become a very important element to affect the changes and evolution of different culture. Now, at the end, what is professionalism, which is another part of my talk? Professionalism in science denotes a pattern of behavior identified with scientific integrity. Elements of professionalism include intellectual honesty, excellence in thinking and doing, collegiality and openness, and responsibility of self-regulation. Some of the most significant policy response to cases of fraudulent and questionable conduct by scientists have been to strengthen professionalism among scientists. Science is not simply a tool to practice in research laboratory or on operation table. It is to integrate your thought process and translate in disposition, in your temperament, and in your attitude. For a science professional, what I emphasize is that adherence to scientific culture is more important. It is to have faith on science, and also it is equally important to be sincere to science and scientific methods, but not simply practicing scientific method for the purposes other than scientific research and values. Individual researchers and research institutions have the responsibility for developing scientific culture. Thus, I see a huge role of conferences, such as this 10th Conference of Nepalese Society of Neurosurgeons, in enhancing the scientific culture and professionalism. I appreciate your endeavors. Francis Bacon, the philosopher of science in 16th century, said, "Reading makes a man full, conferences a man ready." So you are making these neurosurgeons ready to accept the scientific culture and professionalism. Finally, I committed to tell you after this talk, what is Seto Shaligram? Shaligram is black. All of us know it very well. And it is found in Kali Gandaki, which is a twin sister of Seti Gandaki, which is there in Pokhara. And many people worship it. Many people have it in their temples, at home also. Seto Shaligram, white Shaligram, is a name coined to eggs, unda, which they savor and eat. In adopting scientific culture, do we need to coin new words like Seto Shaligram by Gopal Rajpant? It is up to you. Thank you so much.
Thank you so much, sir. And on behalf of organizing committee, we'd like to thank you for taking out time to enlighten us about the science. And we have realized the fact that we have been studying science for a long time and we have still not understood so many things. Thank you, sir, for providing, enlightening us on how the science is bridging to its practical aspect. Since this is a featured speaker session, there is no question and answer, and we'd like to conclude by saying this. Thank you so much, sir. Thank you.
Thank you, gentlemen. Thank you, Professor. It's an honor to have you here with us today. Now we shall move to the plenary session of the day. I would like to invite Dr. Mohan Sharma, consultant neurosurgeon and cerebrovascular surgeon, and Dr. Krishna Sharma, associate professor at Nepal Medical College and Teaching Hospital, to kindly moderate the session and introduce the first speaker, Dr. Basant Pant. Thank you.
Thank you. Thank you for giving us the opportunity to chair the session. Yeah, noted, Amit. So I think we are delayed by about 10 minutes. So without wasting much time, we'd like to start the session right away. And it's my pleasure to invite Professor Aditya Gupta to give the talk. No, Aditya Gupta. Dr. Gupta, are you there?
Good morning. Good morning.
Good morning.
It's a
Pleased
pleasure
to have you here, even on
Yes.
online.
Yes, it's a pleasure to be here. My apologies for not being able to make it in person. And I thank NESON for this very kind invitation. I'll just start presenting my talk. I hope my slide is visible. Is my slide visible?
It is, sir.
Okay. So again, heartfelt thanks for this invitation to present. And it would have been much more lovelier to be there with all of you and to be in Pokhara. So I will take you through a very quick overview of the new frontiers in DBS. Basically, as we know, DBS is nothing really which is very new. And in fact, it has a long history behind it, both in terms of animal and human work. And it was really a chance discovery by Professor Benabid, which brought upon DBS to clinical use in the beginning of the 90s. Now, DBS itself, we look upon it as a very uniformly followed procedure, but really there are these variabilities which I have marked in question marks. And really the world is somewhat time, we will be moving away to frameless DBS without microelectrode recording and really even without awake test stimulation, which currently seems to be the norm, at least in most of the institutions. Now, starting with movement disorders, all of us are well aware of the commonest indication for DBS, which is Parkinson's disease. And the indication for DBS is Parkinson's disease is really the patients who have advanced Parkinson's disease and dyskinesias, and they have a very frequent on-off fluctuation which hampers the quality of life. The first point I would like to highlight when we talk about pushing new frontiers is that I think there is an urgent need for DBS to be done earlier. On the average, we find that DBS is being done at least 11 to 13 years after the onset of disease, by which time the professional activity and the social activities are already severely impaired. So there is definite need to do it on an earlier basis. And all of us are aware of this early STEM study, which highlighted the great value add of early DBS, by which what we mean is at least a disease duration of 4 years, but the motor fluctuations or dyskinesias should not have been on for more than 3 years. So in fact, younger colleagues who are doing DBS, I would recommend all of us should be well aware of these criteria. And the paper clearly showed a great value add in terms of, if you compare with the best medical management, the quality of life and the cognition, communication, mobility, etc., was all very favorably impacted. Now, the next thing which I would like to emphasize is that currently there is almost a complete shift from indirect targeting to direct targeting. And the slide depicts one paper which has highlighted the huge variability in the subthalamic nucleus size and position between individuals. And therefore, I think in most of the institutions, what we practice now is a direct targeting, which actually puts us in touch with the patient-specific anatomy, which is a move happening worldwide, not only in stereotaxy, but even in spine surgery. Now we talk about patient-specific anatomy, directed surgical approaches. Now, which target is another interesting frontier, which is also being gradually pushed. Subthalamic nucleus, as we know, is the favored target for Parkinson's disease, which is the commonest indication for DBS. But really, a lot of groups are exploring the use of globus pallidus for Parkinson's disease DBS, specifically when it comes to patients with neuropsychiatric disturbances, and when dyskinesia seems to be the only sort of predominant clinical symptom. At the same time, even in Parkinson's disease, the other interesting targets which are emerging are the posterior subthalamic area and the caudal zona incerta. Now, globus pallidus continues to be the workhorse for dystonia management, and thalamus, specifically the VIM nucleus, continues to be the workhorse for tremor management along with VOA and VOP. Now, the next question is the need for microelectrode recording. And there are groups now which have moved away from the need for microelectrode recording, and they basically practice a purely image and target directed DBS, which seems to be the way to go for patients that are unwilling for an awake procedure. And there are certain value adds, of course, of this philosophy as well. Now, intraoperative assessment, still to my mind, continues to be a very, very important step which provides instant and accurate feedback. And this is the information which cannot be available to us in a sleep DBS. Now, in a sleep DBS wherein you don't use a paralyzing agent, potentially you can still use a macro stimulation and elicit adverse effects, but really you will not be able to elicit any beneficial effects in a sleep patient. Now, the DBS is surrounded by several important critical neural structures, and what happens is in intraop stimulation is that you're able to clinically evaluate the result of stimulation as it will happen after the procedure is over. And if there are any adverse effects today with the use of directional electrodes, there is a possibility of steering the current in a particular direction. So this is what we follow. On the left-hand side, you will see the pre-stimulation, very, very slow movements, bradykinesia in a patient who is on the table. And on the right side, post-op, almost immediate improvement in the bradykinesia. So this kind of a clinical response assures us that we are in the correct position for placing a lead. Now, whether we do an awake or an asleep DBS, checking the position of the implanted lead is, I think, is a very, very important step. So we are fortunate to have an O-arm, which we can fuse the images with our pre-op planning, and we can be sure that we have implanted the electrode in the correct position. In institutions which do not have that, I would encourage that after placing the leads, the patient can be sent for a conventional CT, and the images can be fused to the pre-op planning to give us an idea of whether we are actually at the correct position or not. Now, the sixth point I would like to highlight is young onset Parkinson's disease as a special group when we talk about expanding the frontiers of DBS. So in fact, this is a lady from Nepal who was a young onset Parkinson's disease. She started having Parkinson in her early 40s, and she is having this typical short shuffling gait. And this is on the day of DBS with the stereotactic frame on. And this is the same lady on day one following DBS. In fact, the interesting thing was that this patient did not need medications for almost a month following surgery. And even at now a 2-year follow-up, she continues to need a very, very low dose of stimulation. Again, a finding which assures us that we have put the lead at the correct position. Now, coming to newer indications in movement disorders, there are certain rare indications which are being explored, of which I think Tourette syndrome, which has tics and psychiatric manifestations, seems to be a very, very strong contender for benefit from DBS. Among the other newer indication, we have basically the established indications, which are epilepsy and psychiatric disorders. So epilepsy is something which for which DBS is in fact quite well established. Again, with a long duration of work done in this particular field. And all of us know about the Sante trial, which established very clearly the long-term efficacy. So this is the 5-year results from the Sante trial. And the interesting thing was that the response rate increases every year from 43% to 68%. And really all kinds of epilepsy can be benefited with this, whether prior VNS or not, whether it's temporal, frontal, or any other location. And the value add is also that it has a specific effect on the most severe seizures that the patient is having. Now, this is our first case, in fact, which I did in the previous institution I was in. And this was a post-encephalitic lady with 6 generalized seizures per day. And this was our first case. The targeting was very challenging because there was a lot of atrophy and ex-vacuum dilatation of the ventricles. So in epilepsy DBS, we don't need to do any MER and there is no really EEG monitoring. And there is EEG monitoring which is placed on the scalp, and we put the lead through the cannula to avoid the CSF leakage, in which in this case you notice that the ventricles were very large. Now, once you place the lead, the important thing is to push the lead 5 millimeters beyond your planned target so that the lead is well anchored and does not float away into the ventricle later. And this is a driving response which you elicit through an external stimulation of the lead at 5 Hertz. And you see a synchronization of the EEG with this low amplitude stimulation. So this is the post-op MRI of the same patient showing both the leads well implanted into the anterior nucleus of the thalamus. A recent case done 1 year ago showed us a very striking response in which from almost 10 to 15 seizures per day, from day 3, we saw a very, very good benefit of doing a DBS in the putting in the leads in the anterior nucleus of the thalamus. So on one side, we had to come in from the lateral side, and on the other side, we had to follow the usual conventional medial approach to the anterior nucleus of thalamus, because there was a very large vein near the foramen of Monro on the right side. So this is the post-op O-arm showing the implantation of the lead. And this is the patient on day 10 after surgery. And the mother is basically saying that the child has had a very, very striking response to this DBS procedure. Now, DBS in psychiatric disorder, there is presently no FDA approval for treatment refractory depression, but there is a very, very good approval for obsessive compulsive disease. And these are these guidelines which one has to follow. And these are the clinical criteria which enable us to select the correct patient. Now for OCD, again, there is a lot of targets which have been studied with anecdotal experience in all of these targets. But we had the possibility of carrying out OCD DBS a year ago. And this was an Australian lady who came to us all the way from Australia with a refractory OCD. We actually got her evaluated in detail. In fact, she spent almost 3 months in India. We said, we cannot take you up until you give us the full evaluation, and at least 2 psychiatrists have to document that you are indeed a case of refractory OCD. So this is her on the table, and immediate post-stimulation, she reported an elevation of the mood. On the left side, if you pay attention, you will see the lead in the bed nucleus of the stria terminalis. And if you pay attention to the lead, you will see how it is coming out along the anterior limb of the internal capsule. So which is very, very important, so that the 4 contact points, they should be in the BNST, and the top 2 contacts should be in the anterior limb of the internal capsule. I'll skip the O-arm. So this is again post-op 2 weeks, and again she's basically reporting an elevated mood, and the Y-box improved dramatically within 2 weeks from 38 to 12. So for treatment refractory depression is a very, very promising indication. Tourette syndrome, I already mentioned, is a very promising indication. Chronic pain, there is a definite body of literature which points to a very good effect of DBS, but these are really very, very carefully selected cases. Persistent vegetative state is an investigational use with few reports targeting the central interlaminar zone of the thalamus. And Alzheimer's disease is another investigational use of DBS, in which there is some trials going on. There are some modest beneficial effects which have been seen in the older age group of the patients who have Alzheimer's disease. Now, the exciting other investigational uses are for eating disorders. Again, a lot of this work has been done in China, and also for heroin addiction. So that is something which seems to be catching a lot of traction. And in fact, there are a lot of studies happening in the United States and Canada at the present time. So this is probably the single largest paper on the use of DBS for anorexia. And this is, again, a promising use for these patients for whom really there are very, very few options available. So this is my personal experience. The reason why the newer indications are so few is specifically in the psychiatric uses. I think it's very, very difficult to build a good sort of a collaboration with the psychiatrist, but hopefully that will change in time. So my last 2-3 slides, the new frontiers which we already are living in are the new technical advances of the DBS hardware. So directional electrode and closed loop stimulation are something which are currently already launched, and we will hopefully see the beneficial effects in the coming few years. So to summarize, and this is my last slide, I think basically what we need to understand is that there is a definite need to first expand the current established indications to more deserving patients. I think that is the most important current need. Emerging indications are very interesting. This shows us that neuromodulation is for exciting times ahead. But really the new sort of uses for DBS should be selective, careful, and justifiable, because specifically in India and Nepal, we are dealing with relatively low socioeconomic conditions. And when you implant an expensive device, one must really satisfy oneself that one is doing the correct thing for the correct patient. Thank you.
Thank you, Dr. Aditya. I think we'll allow one question from the audience. If any, of course. Any question? Dr. Panta would like to comment?
Thank you very much. Most of the thing I do agree, but in our center for dystonia, almost all cases are being done just listening on GPI, and also for task-specific dystonia, tremors, we are more for listening rather than stimulating, because I believe that DBS is a misnomer. Deep brain stimulation, but there's nothing you stimulate. You actually depress the brain. That reason you dysfunction that part of the brain. So there's nothing you are stimulating. But if you say deep brain suppressor, nobody is going to use it. So it's a misnomer. So otherwise, I really, congratulate you for wonderful talk. Thank you.
Yeah, thank you, Dr. Pant. I think you're absolutely right. For hemidystonias, certainly I would always choose lesioning. In generalized dystonias, which happens to be actually the commonest dystonia that we see in our clinical practice, I think DBS still continues to be the procedure of choice. For a patient who cannot afford, I would certainly try staged lesionings 6 months apart. So I completely agree with what Dr. Pant is saying.
Thank you, Dr. Aditya. Thank you for the
Thank you so much. It was a pleasure.
Thank you so much. So we'll move on to the next one. The next speaker is Dr. Basanta Panta, please. And he will be speaking on epilepsy surgery, ensuring good outcome. The floor is yours, sir.
Well, while they are while they are setting up the slides, I think my lecture would be, I'll try to make it as simple as possible about epilepsy surgery, because trying to complicate things, our younger generation will not have enough courage to start epilepsy surgery, because they will think it's a very, very complicated surgery. It's not that complicated. And you should start. And to start this, we can help you if there's any way that our institute can help. And slide. Yeah. I also like to thank Dr. Dinesh Buju for, making me nostalgic by remembering my father. And I also spent my young age in Pokhara. I did my schooling here. So I would like to talk about epilepsy surgery, as we have said. Now, very simple definition is that if you use more than 2 drugs for more than 2 years and it doesn't work, then these are called intractable seizures. And in intractable seizure, the 3 things, the semiology, the EEG, and the MRI should be concordant. It should show a same point. But now I have added ECOG in this test because it's very, very important, and we are tailoring. Every time we operate, we tailor our surgery depending on what is the ECOG finding. And this is the data of Nepal. If you think 1% of Nepalese population have epilepsy, 25% are intractable, and out of that, 50% are surgical candidates. So we already have 37,000 people who are candidate epilepsy surgery. And as you can see, ECOG directly studies on the surface of the brain, where the EEG has a span, so it is covering about in terms of centimeter. And at times we also go and do some depth electrode study. So first of all, when we think about epilepsy surgery, we should know 2 things. One is, where is the ictus coming from, which is called ictal onset zone, or just like tsunami, starting tsunami. And that is only seen by video EEG. So when you see a seizure coming and you can see an uprising of the seizure from one point, then that is the point where the ictus onset has started. But that is not enough. To have more information, you should have an epileptogenic zone, which is the interictal spikes that you see. That is the epileptogenic. So these 2 has to be addressed. And there are lesions which may not correspond with the ictal onset zone, symptomatic zone, and so on. And the second thing you need to know is which is the pathway that the epileptic is propagating from one place to another. So you need to know the pathways. And if you cannot remove the ictal onset zone or epileptic zone, then you can disrupt the pathway. So these are the 2 things that you do in epilepsy surgery. We are doing mostly anterior temporal lobectomy, selective amygdala hippocampectomy. I stopped it because there was some failure here. Initially, I was doing selective surgery, lesionectomy, corpus callosotomy, MST, lesioning for epilepsy. We have done 3 cases, and we just started VNS, and I'll talk about DBS for epilepsy and responsive neurostimulator in the later part. So this is hypothalamic hamartoma, 3 cases we have where we did a stereotactic targeting on the margin of the tumor with the normal brain, and then burn that margin out so that the epileptic activity do not propagate to the whole of the brain. And all 3 children did extremely well after surgery. Classical anterior temporal lobectomy is like in this case is a left-sided temporal lobectomy. I have got a video presentation of how I do it tomorrow, I think, or today. And on the left side, we take 4 centimeter of temporal lobe. You can do selective amygdala hippocampectomy if you are really sure that amygdala is the only one which is firing, but most of the time that is not possible. So it's better that you remove the temporal lobe. And on left side, we generally leave the superior temporal gyrus and middle and inferior temporal gyrus with amygdala, hippocampus, and parahippocampal gyrus and oncus. Everything is removed. And this is a case of a MR negative. So, you know, I don't have information of the MRI in this case. Another case where the child, 4 years, who was having a complex partial seizure with generalized tonic-clonic seizure, came from another hospital in a status epilepticus state. And he was having continuous seizure for 4 days. And the MRI looks not very clear. Maybe there's some right side, you know, involvement. So here we would do one side EEG and the other side ECOG. So first we do EEG like this, and then we remove, and then we do the ECOG, and then the other side is still we are doing EEG. Why we are doing this is sometimes we add corpus callosotomy during lesionectomy to lateralize, you know, which side is when there is a mirroring effect, when there is both sides is firing. And this boy needed a very big, almost 9 centimeters of the frontal lobe needed to be removed just by, you know, following the ECOG. And he became completely seizure-free after surgery. And another case where you can see that in the MRI, you can see on the left frontal and parietal area, there's some, you know, abnormality there. I'm not sure what it is. And he was having, again, continuous seizure for almost 14 days. So we did a long exposure of the both side, and then did an ECOG and also a depth electrode, which is shown in the middle, and removed 2 of those parts which were firing the most, and try to disconnect these 2 connections, because that is the place where you have the longitudinal fascicles is going, superior longitudinal fascicles. So we disrupted that part also. But the child continued to have seizure. Even next day, another 2 days, he was having seizure. So after 2 days, we added, you know, another on that disconnection was not enough. So we had to remove that part of the brain, and then only he became seizure-free after that. So, another case of encephalitis at the age of 8, and she was having post-encephalitic seizure for 18 years, GTCS and right focal seizure. And that is the look of the MRI, where you can see that it's an extensive lesion which is coming from the left side temporal base and coming all the way into the occipital lobe. And fortunately, this lady had a bilateral speech representation. So we are a little bit, you know, we could go a little bit aggressive in this case. And so in such cases, we actually entered from the temporal lobe and went all the way by doing ECOG and tailoring our surgery and up to the occipital lobe. And that is the extent of the resection that we did. Another case where MRI is questionable again, a patient is having a focal generalized seizure, and EEG is not very confirmatory, video EEG, where you can see that, you know, both left and right is firing at the same time synchronously. So it's a mirroring effect. We don't know which side is the culprit. So our plan was to do a partial corpus callosotomy, 2/3 anterior, 2/3, and then we think that it will lateralize intraoperatively and then take out the lesion from that side. But surprisingly, this patient was having a thick membrane on left side, but there was, you know, nothing on right side, but that side was firing. So as you can see, we have opened both sides and we're ready to do a corpus callosotomy if needed. So the epileptogenic focus was from the normal looking brain, actually. And you can see that there are some, you know, infective, probably past infection, which you can see aragonoditis there. So when we are doing ECOG, we make marking of red, yellow, and green. Red is the most firing place. And yellow is, if you remove red, the yellow becomes silent. And green, you just leave behind, So this is our strategy, and this is how we demarcate, and then remove that part of the brain, and then the the patient becomes seizure. Can you play the video both? So dope attack is something which is very, very effective by doing corpus callosotomy. These childs were having multiple fall, almost 30 to 40 falls a day, and multiple injuries in their brain. And so you can see that the mother has stopped taking the child to the hospital because the child is having, fall all the time, broken teeth, and then open wounds. So it looks horrible to see, the family in this state. And these cases can be taken to OR straight away and do a complete corpus callosotomy in one go. And what you do is you make a small incision in the vortex and then go into hemispheric, identify the pericallosal artery, and then remove whole of the corpus callosum from splenium to genome. So next. So like this, once you reach the corpus callosum between the two pericallosal, then you just go straight in the center. And you can actually, you don't even need to go into the ventricle. You can go through the septum pellucidum, because there's a potential space where you can split it. Generally, I go anterior first and then cut the whole of the genu, and then come back to the quadrigeminal part and then split the whole off. Now you can see that the ventricles are, I have not exposed the ventricle. And that is the, the veins that you see in the quadrigeminal cistern. So I am in many centers, they are doing first anterior 2/3, and then if that doesn't work, they add another, the rest of the 1/3 is done. But in our center, we are doing complete corpus callosotomy in all our cases. And we have not encountered any disconnection problem, except for one thing. 2 to 3 months post-surgery, these children will not speak much because the speech initiation is from right side and the speech is being conducted from left side. So they don't speak much unless you speak to them, If you speak to them, they will speak, but they will not spontaneously speak. And this is I think last case, long-term intractable seizure with hemiatrophy. I actually suggested him for hemispherotomy, but somehow they didn't go for it. And he came to me with 4 days of status epilepticus, GTCS. This is the only case where we have done emergency corpus callosotomy. And we, monitored both ECOG on both sides and did a complete corpus callosotomy. And then his status epilepticus stopped. But as you can see from the MRI that the patient had, can you go back? Back. Yeah. As you have seen, this patient actually needed further surgery by doing a hemispherotomy, but they denied. So I had to put a VNS in this patient. Now he has a VNS inserted. This is the case, and VNS surgery is pretty, simple, straightforward. But the decision to put VNS is very, very big. Surgical technique is very simple, but the decision is very important, and also it is very, very costly. But the VNS do not work immediately. Just remember, as the previous speaker was also showing, it takes time for VNS to work for many, many years. Gradually, it will decrease the seizure frequency. Now, talking about anterior thalamus stimulation, which I'm very interested, and I am looking at this. But if you look at the Professor Lozano's paper here, he has done 5 cases of anterior thalamus stimulation on intractable epilepsy. Those 5 patients are there. And if you look at the left, then there is a seizure reduction after DBS insertion only. So he has called this a microlesioning effect. And then once the DBS is started, there is no much change or there is not much improvement. Then he took them and double blinded this by switching off the device. And then again, you can see that there's not much change. So again, coming back to what I've just said, that, most of the time this stimulation is a misnomer and you are actually suppressing that part of the brain. So we are looking into the possibility of making a lesion in the anterior thalamus for intractable seizure, since this is the final pathway. So these are the cases that we have done till now, and these are the cases, 77 cases operated, and we're fortunate to have a very, very good result, because we are not touching difficult cases. I tell you, I must be very honest. We don't touch difficult cases. We only want to do cases where we are going to have good result. But now, since we have pretty much of experience, now probably we can go and go into more difficult cases as well. So Angel 1, Angel 2 combined almost 89%, and Angel 3 is 11%. There is one mortality in the early stage of my career. I don't know, after 3 days, the patient died. So, we should not give mortality in a functional neurosurgery cases. So this is something that always haunts. So in conclusion, our results in epilepsy surgery is encouraging, both in terms of surgical outcome, morbidity, mortality. And we found that ECOG is very, very simple. You just take the same EEG machine, just have some leads, and then use it once you open the brain. And if any institute is interested, we can support you with that. And also at times we put depth electrode. Sometimes we put depth electrode on both hippocampus when we are confused, and leave it overnight. Stereotactically we put and then leave it overnight and remove on the next day. But we do not do a chronic EEG study for many, many days, as done in many of the Western countries. And the motto of our institute is learn from the best. I'm fortunate to have learned this from my teacher, Professor Arita. And we are improving on what we have learned, because whatever we learn in the West or advanced country do not apply to our setting. So we must improve on what we have learned. And then it's our work to hand it over to next generation. Dr. Rizu, who is in the audience, is doing PhD in epilepsy surgery in Nara University and will be back in Nepal next year. And my son is doing, animal study on epilepsy surgery. He's making hippocampal and insular models in Prague. Thank you very much.
Thank you, sir. I think we'll allow one question. Yes, sir.
And I think you rightly mentioned that people think epilepsy surgery is difficult. It's not difficult. You have to choose your patients properly, and you can have excellent results. And I went and sort of learned epilepsy surgery from Pete Engen. That was when I started in '94. My training period was 3 weeks. And what I learned was his concept of surgically remediable epilepsy, which is very, very applicable to India, Nepal, our whole subcontinent. So there are cases which we know are going to be inherently resistant to anti-epileptic medications. These are the cases we have to pick up. And there are so many of them. MTS, infantile hemiplegia syndromes, and simple MRI, clinical semiometry, coordinate, if fit, go ahead and do the surgery. So thank you for popularizing this. And I think the message has to go across. It's not difficult. Any good microsurgeon can do epilepsy surgery, and don't just depend on your neurologist. If they are not supportive, they are very easy to assess. Have a good electrophysiologist to support you. Surgery is not difficult. Thank you, sir.
Thank you very much.
Thank you, sir. Now, can we move on to the next talk? is Dr. Mohan Sharma. He'll be talking on neurosurgeons as researchers, challenges and opportunities. Sir, it's yours.
Thank you, sir. Amit, to slide change. Slide change. Thank you. Thank you. First of all, my topic will be slightly different compared to what Dr. Panta just described and what my successive speakers are going to talk. Recently, my advocacy has changed a little bit from hardcore neurosurgery to advocacy for research. I haven't given up operating though. I'll talk about how I do AVM the following tomorrow. So the topic of my presentation today I have chosen is neurosurgeon as researcher. What are the opportunities and challenges? And what is the brief history of neurosurgical research in Nepal? And I have made my presentation luckily in such a way that Professor Vijaya Panta and Professor Bhuju will also hopefully enjoy my presentation. So on behalf of the Department of Neurosurgery at the Institute of Medicine and the Department of Research at the Institute of Medicine, I bring warm greetings to all of you. This is my disclaimer. I truly believe in this statement by Thomas Sowell, that it takes considerable knowledge just to realize the extent of your own ignorance. Over the last 25 years, I have practiced neurosurgery. I have progressively known how ignorant I am in many areas of my life, including research. And whatever thing I say will be limited to my limited investigation. Let's briefly talk about research. Research is basically there are many ways you can get new knowledge, and the commonly described approaches are by your experience, by reasoning, and by doing the research. And arguably the most accepted way of getting a new information in a short span of time is by doing research. And it is the most scientific way. It has broadly two components. It has to go on through a systematic process, because if you do something haphazardly, you cannot consider it as a research. And next component of it being a research, it has to be generalizable. If you do a research in one place, it has to be generalizable to a similar place in other areas also. But what is the definition of research in low and middle income country? The word racism is just like ketchup. It can be put on practically anything, and demanding evidence makes you racist. Same thing applies in research. Even smallest hospital or center in town, they say this institute or hospital and research center, and practically no research has been done there. So this has been, it is research word is sprinkled on every, speech is made or every hospital signboard, but no actual research is being carried out there. Let me take you to a couple of practical questions. Does doing research make you rich and famous? Anybody? You know these two people? Right away identify. You identify this gentleman? Anybody? I also only recently identified. He is the guy with the highest number of citations in the world. He is the one who has written the articles which are cited the most. He has got H index of 316 and citations in thousands, but we hardly know him. So doing research doesn't necessarily make you rich and famous. Citing is a issue. Now we work in academic center and we train resident. Does supervising your resident make you rich and famous, Vijaya ma'am? You supervise a lot of residents. Does supervising your resident or PhD students make you famous? Okay, let's go with few data. Professor Sam Wu, a professor both at the University of Michigan and University of Wisconsin, holds the record of supervising highest number of PhDs, 113 PhDs in his life. And many of his residents ended up being a famous researcher. This gentleman, he's a Nobel laureate himself. By 75, he guided them through 75 of his residents obtained PhD, and 4 of them went on getting the Nobel Prize, but would hardly know them. But we know Michael Jackson and Aishwarya Rai like anything. So there is, you cannot become famous, but still we need to do research because our forefathers have entrusted us to put this science forward. And our younger generation, we need to inspire the younger generation. That's why we need to do research. You know this gentleman? Parag Agrawal, he's the CEO of Twitter. If you see his Wikipedia, at least who supervised his PhD thesis is mentioned there. So you get little bit of recognition, little bit, but still you get little bit of recognition because he says that. Okay, he did his PhD from Stanford University and under the guidance of Jennifer Wisdom. So you get little bit of, little bit of publicity, but not like Michael Jackson or Aishwarya Rai. So let me go through a couple of slides from Professor Grotenius from Netherlands. He has put a question: what happens when we all concentrate only on performing surgeries and seeing patients, not participating in research? This is what he says. We'll become better and better in those surgeries that we perform more often, obviously. Patients and ward staff will admire you for your great surgical skill. The faster you finish the case, the happier they will be. You will earn money, of course. The more surgery you perform, tendencies you earn more money, and colleagues will envy you. Your results seem to be excellent, and their result is maybe 5% mortality. So there seem to be all the advantages. Then why not only concentrate on surgery? But the second side would tell you, it is not great. It is not. It will take us back to the Middle Ages of barber surgeon. Dr. Robert Lister, maybe you have heard his name. His fastest, his record time of finishing amputation was 2.5 minutes. He was that fast, that couple of times he chopped the, finger of his assistant holding the limb. And at another time, he cut the testicle of the patient because he wanted to be fast in doing the amputation. So doing fast will make you a good technician, but not a good surgeon, good scientist. And we'll need other people with knowledge to tell us what to do because we are not doing any research. So we will just depend on others' data to do what we do. So we should not be doing this. So we should also do the research. This I took from the World Journal of Orthopedics. If the spine surgeons do not want poor quality study to dictate and limit their clinical decision, the responsibility rests with this group of practitioners to design high quality study to justify certain treatment modalities. If you advocate some treatment, then you have to do research here and then apply it here. We just cannot implicate the results of the papers done in other places. The ethics of belief, this was published way back in 1876. It is wrong always, everywhere, and for everyone to believe anything upon insufficient evidence. And we are in the 21st century. We are in the fourth stage of fourth revolution. How can we believe something with insufficient evidence? That's why to get the evidence, we need to do research. Brief, sorry, this takes me back to, now I go to briefly. This time should be added to me, because a lot of glitch here. Back here. Okay, so let's get back to the brief history of health research in Nepal. First research in Nepal is recorded in 1951 in the form of malaria survey, and you can see on the slide that more and more, surgeries were done afterwards. The first recorded publication from Nepal was by Dr. Mirgendra Raj Pandey. He published a paper in Indian Heart Journal in 1957. So writing article has started back in 1957, but that time we did not have our own journal. Then in 1963, Journal of Nepal Medical Association was born, and then the Nepalese doctors had the opportunity to publish their research work in their own journal. Then after 15 years or so, Institute of Medicine started to have its own journal, and the JIM Nepal is the second journal of Nepal, though it is still not PubMed Index. It is one of the oldest journals. Then in 2004, we started to have one neurosurgeon, though number of neurosurgeons that time was total in 6. We had so much enthusiasm. We started Journal of Neuroscience. The first issue didn't have the word Nepal there. See, the one on the right is the Journal of Neuroscience. Then we got a lot of feedback that Nepal should be included for the identity. And from the second issue onward, we started to put Nepal as the Journal of Neuroscience. But getting the good quality article is always an issue. We used to ask the authors directly, emailing them to send the article. And one of the, I wrote directly to Brian Zinet to send the article for Glasgow Coma Scale. And he so kindly wrote the article and sent back to us. And we put the first version of the real Glasgow Coma Scale chart he had used in Glasgow. He sent that picture and we published that in our cover page. Then Journal of Society of Surgeons of Nepal also came, and we as a part of the surgery, we also send article there. Then, Eastern Green Neurosurgery was brought into the scene by our colleagues working in the eastern part of Nepal, which was dedicated to publication of neuroscience. Another journal from Pokhara, Dr. Bal Gopal. So Journal of Brain and Spine Foundation of Nepal is there. And we have another journal, Annapurna Journal of Health Sciences. So this is a multi-specialty journal, but this the birth of this journal was given by nobody but our neurosurgeon. So already we have 3 journals dedicated to 4 journal from the neurosurgeon and 2 journal from one from neurosurgeon, attracting other articles also. One GSS, and we can also publish neurosurgery journal. So we last year we reviewed how many journals are there in health science in Nepal, and as of June 2021, there were already 68 journals, healthcare journal in Nepal. In my opinion, there are too many journals. Then we get the good quality article. Just manufacturing more journal is not the answer. Getting the good quality article is the answer, in my opinion, and that I'll talk about this. This is a bibliometric research from published in 2014 by Pitambar Gautam, and see the number of articles published from Nepal. The real momentum took place around 1994, and another momentum in 2005, and right after the mega earthquake, it has really gone up. The things have really improved in Nepal. This was for the total number of scientific, Professor Dinesh Bhuju's arena, but part of this also contains medicine and geology, and medicine and geology were the one with the highest number of publications. What were the triggers for the accelerated growth? Of course, one was in 2005, many medical colleges were opened in Nepal, and that they have the mandatory point of having thesis as a postgraduate residence, so that also triggered. Another was the 2015 earthquake that triggered a lot of articles, paper on trauma. And of course, 2020 COVID-19 stimulated a lot of guys to write, to do research and publish. So these are the real triggers. Let's concentrate on neurosurgical research. This is the first paper in the series of neurosurgery in Nepal. Total 5 articles, neurosurgery in Nepal, have been published 8. The last one was by Sabal Sapota in World Neurosurgery, but this was the first by Professor Gongul, published in 1980 in Red Journal. The title was Prospective Neurosurgical Training and Research, Prospective in International Neurosurgery and Neurosurgery in Nepal. That time, Dr. Gongul had already thought about research, and what he has written is, we have not yet begun any research. He was so humble then. He had that research in mind, but he clearly said that. And in the text, What he says is, if a neurosurgical center is organized, there can be a good program of clinical research. He had envisioned that back in 1980, and I don't think, I'm not sure how much we have done, we have carried out his dream, but we have done our genuine try. Okay, in 1991, this picture was given to me by Dr. Pravesh, and Dr. Devkota, when he came to Nepal, he organized this first German Nepal neuroscience, mental health, and orthopedic conference. You can imagine, there are so few neurosurgeons, you have to amalgamate whoever are like-minded people. And at that time, it was organized 4 days conference from 19th to 22nd. And that was the beginning of holding the conference directed to neurosurgeon or neuroscience, and we should give great credit to him for starting this. And that time he presented 2 papers. This is from these abstract neurosurgery in Nepal. He presented that. And another he presented was the surgery for ruptured intracranial aneurysm. And this series consists of 7 aneurysm only. This is equivalent to 700 aneurysm today, because that time doing 7 aneurysm also in a very resource constrained environment was a huge challenge. And this famous, very mega conference in 1999, he was the South Asian Neurosurgical Congress first, and he was the organizer, courtesy of Professor Sultania. It was inaugurated by King. I was so young back then, I missed my doing this. I was just a trainee that time. It was a very big mega event, and many international participants came and presented, and that really gave all of us the forum for presentation. And this time, first nation conference was held back in 2009. Now we had the society in 2008, and we were, in one way, we were confident enough to hold a conference. That time, Professor Devkota was the chairperson, Professor Basanta Pant was secretary, and Peter Black was invited, and he was that time the WFNS president, I believe. We wanted to have a WFNS affiliation, and he was kind enough to come here, and we had a big welcome. And that time, the Nepal Journal of Neuroscience was run by the Teaching Hospital Neurosurgery. And that time we thought that one department cannot run a journal. So we handed that journal's official ownership to Nepalese Society of Neurosurgery. And because WFNS had a criteria that you have to have a journal before you can be, given the membership. Okay, this is, and this was the meeting, everybody, all big shots here, the, official dialogue between the WFNS and the Nepalese Society. And we were formally, introduced into the WFNS as a legitimate member society. So now where do we stand in terms of research? 2 days ago, I searched this, randomized control trial in Nepal, and we got 457 hit, and 10 were related to neuroscience, but none in pure neurosurgery, except in crash trial as a collaborator. I am very pleased to show my colleagues' name there as a collaborator, but there are many randomized control trial in allied field, in neurology and in physical therapy, a lot of trial in leprosy. But as neurosurgeon, we have not yet done a proper randomized control trial from here that could be potentially published in international journal. So there are a couple of reasons why we have not done that. And this was a quite old paper published in 2004. And this was the recent paper published in 2021. And the gist of that is, and which I also share, is there are certain barriers and solutions where we have not been. Insufficient research capacity is the one, we have been improving. Inadequate research enthusiasm, I still blame this also. We have to have some degree of enthusiasm to get research and to get our Nepal in the map of the research doing high quality research countries. Lack of expertise can also be addressed. Lack of funding and brain drain can also be addressed, with collaboration and competition of good article. This we can address. If we have too many journals, we'll be competing for the articles and we won't be able to sustain our journal. That is another issue. I think I have come to my last slide somehow. So this is my conclusion slide. We have not much incentive in doing things. This was said by the King James. What he said that if the scratch is, the sensation of scratch is so delightful, only the kings and princes should have the itch. Nobody else should have the itch. Same thing here. We don't have much incentive by doing research, but still we should have that itch of doing research. Because once the research is completed, it will be very delightful, just like the itch. Thank you so much for the patient hearing.
Thank you so much. I think we have the most appropriate person to comment on your topic. Dr. Bhuji, please.
Well, it was a wonderful presentation, which I really enjoyed. Why research is so important, rather than we should ask why research is so interesting. This, it was well explained now. I am very delighted. And talking about Nepal's contribution to international arena, as we have seen, especially when we have disasters like earthquake and recently the pandemic, COVID, we found the number of publications shooting up. But it doesn't mean that we invite the disaster frequently. What we urge is, as doctor has mentioned, professor mentioned, you must have the urge to do research, because knowledge is the light that helps you do your surgery successfully. Thank you so much, Professor, for your kind presentation.
Good morning.
Nice, less well talk on this topic on research, sir. And I am Bipin Chaurasia from Birgans, and I'm a consultant neurosurgeon. I am well impressed by your topics, research. What do you think? Why we are not interested in research in Nepal? What are the primary barrier of that? And you also talked about the H index of researcher in Nepal. I don't think that any of the neurosurgeons has H index of 20 in any of the research in Nepal. I don't think so. And many of the research paper published by us in Nepal are they are less well talked, and they can't reach up to the good journal in the world ranking. And since 2 years I am also publishing some research, and I have found that the main barrier is the sponsors. We need a sponsor to publish, because not all journals are free journals.
Yes.
So if we have researchers and that can be helped by nations or some other and in that case, if we get the sponsor, our research numbers will increase, and probably the citations and H index of we neurosurgeons will also increase. So what do you think? What are the main barrier in your view?
Got your point. Thank you so much for a very relevant question. I invite Professor P. Singh also to comment on this. There are a couple of ways we can address this. There are many open access PubMed in this good quality journal which are completely free of charge. We have to really hunt for that. Asian Journal of Neurosurgery, Neurology India, 2 examples I give, they don't charge for any submission, and they are widely circulated journal. Third is we can apply for the waiver. Just this week we submitted to BMJ Open and they gave us waiver. So there are ways we can get around. And the fourth thing is there are many organizations. NAST is one of them. UGC is another one. Nepal Health Research Council another. They will support you for publication. If you publish one article in SIMAGO rated journal, which is almost equivalent to this PubMed, they give you $500. It is supporting publication support. So there are ways we can get, and some institutions also have some mechanism of supporting you for publication also. Unless we get that money, two ways. One, we can do a collaborative publication. We have an international as a collaborator. We do that a lot of time. I really admire you for putting Nepal in the world map. And another is you push your institution. You have to push hard to get the things moving. Research 20 years ago, I almost cried when I read that article by Dr. Gangul. He had thought about really research, but he was the only one doing, not even the fully qualified neurosurgeon, and he still had envision. And we have a long way now. Full presentation given to research in the plenary session itself is we have moved forward.
Thank you so much. Can I call upon Dr. VP Singh for his talk? He will be talking on large supratentorial tumors in children. Sir.
Namaste to everybody. At the onset, I must thank the Nepalese Society of Neurosurgeons for inviting me and having me here in this beautiful city of Pokhara. It's a pleasure to be here and meet old friends and be with you all. I bring you greetings from India and from the Neurological Society of India. We've been partners for a long time. We've been friends for a long time. And I do sincerely hope this friendship and camaraderie continues. We always have a good Nepalese contingent at our annual meetings, and we hope to see you again in Agra this year, this December. So I'm going to be talking about pediatric supratentorial tumors, tips and tricks. Pediatric brain tumors are the most common solid tumors, 20% of all childhood cancers. Most of them are infratentorial, and we keep talking about them. So I'm going to be talking about the supratentorial ones. In the children is gliomas and ependymomas predominantly, infants, teratomas, and malignant tumors. They commonly present with raised pressure, focal deficits, hormonal changes. And if the child is very young, they may present with an enlarging head, just irritable child, failure to thrive, and unexplained vomiting and constipation. As in adult gliomas, the aim is gross total removal. There is a lot of literature now available to say that the quality, that the outcomes, the longevity depends on the degree of removal. In today's world, even for malignant tumors, the aim is to have a gross total removal. But while doing that, you have to preserve function. So there are a variety of adjuncts which are available, which are useful to achieve this purpose. And 5-ANA is a radiotracer, a dye which is used. The patient ingests this 3 to 4 hours prior to the surgery. And during surgery, this dye goes and gets attached to the tumor. And during surgery, using a fluorescent microscope, you can actually see the tumor glowing. So that's the tumor. Is there a pointer here? And you can see the pinkish glow on the other side. Another patient where the tumor luminescence is there. So it's not difficult. You have the same microscope with a fluorescent option, the blue light, and under the blue light, you can see the fluorescence. Initially, it was used only in adults, but in children also, it is effective. It works very well. Where it does not work is low-grade gliomas. This is very useful for high-grade gliomas, and using this, you can have more complete resections. But the negative is it's very expensive. Cost over 1.25 lakhs Indian rupees to do it. Obviously, a lot of our patients can't afford it. So there is another option, not as good, but works pretty well, is fluorescein. The same fluorescein with which you do the fluorescent angiography of the eye. And that costs about 125 rupees. You can use that and get a yellow fluorescence. And this is, you can see the tumor We resected the tumor. There is some area on the top corner which we thought is tumor. When we did the fluorescence, it was proven to be tumor. We excised that, and then you could see, we thought we'd done a complete excision, but there's a tiny bit of green which you see just over the vessel there. So this would have been missed. The previous one would not have been missed by an experienced surgeon, but this would have been missed. And therefore, using the fluorescence, you were able to do a further removal. The second thing is the intraoperative MRI. Again, an expensive proposition. We are lucky at Medanta to have it right next to us, to our operation theater. But instead of there are various moderns. There is a modern in which the MRI is in the theater. And the other modern like this one is where the MRI is in an adjacent room. So the problem is the costing is not justified by just the intraoperative use. So we use the MRI for routine cases also while the surgeries are going on. And then once the surgery is done, you have this big tumor going across the midline. We thought we'd done a good removal, but in the top two sections, you see there is a rim of tumor left, which is just going across. So a further resection was done and a gross total excision could be achieved. Another tumor, which is partly multifocal, small nodules going ahead. So when you take out, we often end up taking out the larger tumors and the small parts may be left. So this is what happened. The intraoperative MRI showed some resident tumor, and the last section you can see where the complete excision was taken. Now, in our interest and wanting to take out the whole tumor, we should not be left with a functional loss. Of course, any surgeon can take out the tumor, but we have to preserve function. So proper preoperative planning based on DTI and now connectomics has come in. Good surgical technique is required. If you don't have a high-end place, no issues, awake craniotomy, very easy to do. It's just a mental block we people have. You can operate on the tumor. We know the brain itself does not have any pain-sensitive structures. The moment you've done the bony work and open the dura, there is no pain. You can make the patient wake up. You can take the tumor out and keep checking his language and motor function. Navigation and intraoperative monitoring. So the navigation helps you to go directly to the tumor without damaging the surrounding brain. And this is a simple strip electrode which you can put over the cortex and stimulate periphery. And you will see this phase reversal in the first and the second one. Where the phase reversal comes, that is the point in between that two leads is the central strip. In front is the motor strip, behind is this sensory. So just a simple technique. If you can do ECOG, you can easily do this. This is very easy. All you need is this electrode, one strip electrode, which you're using for your epilepsy surgeries. You can use the same thing to just do the recording with a peripheral stimulation. This is the cortical stimulator. And using that, you do the EMG of different parts of the body on the opposite side. You stimulate the cortical surface and you know when this is, you are there in the hand area. After the cortical incision, you can use a subcortical stimulator. So this is an ordinary suction with a lead attached, and the tip, if you see, is sort of a stimulator. So while doing your suction, if you find that you're getting a response from the stimulation, there's a continuous stimulation which is going on. So the moment you get your EMG picks up some activity, you know you're near a functional area. Now, Dr. Buju was discussing last night about AI and neurosurgery. And this is where it has come in connectomics. You see, DTI, we all know. You do the imaging, DTI imaging, and you get beautiful fiber tracks. The problem is the brain is full of fiber tracks, so you don't really know which one is important, which is not. All the white matter is fiber tracks. So what has been done using big data approach is that you do an advanced DTI and you get thousands and not thousands, billions of tracks, and you have to see where they are connected from, which tracks are firing together and which are connected together. And using data analytics, machine learning, artificial intelligence, cloud computing, the human connectomic project is been done with which the brain is now parcinated not into the Brodmann 40 areas, but 180 units on each side. And this gives us an insight into different networks which are involved. As neurosurgeons, we were happy if a patient did not have a speech deficit or a hemiparesis or a vision defect. But now things have gone far beyond. You would preserve these functions, and yet the family would come back and tell you the patient is not quite right. He doesn't have the initiative. Doesn't have, the activities of doing anything important. There's a change in his personality. And now we have realized there are many other networks which we are totally not cognizant of. So there's a central executive network. There's the default mode network, which keeps the brain active. So there are a number of networks, 5 or 7 of them are extremely important to maintain the personality, the cognition, and the thinking of the person. And I just show you on a case, this is a deep-seated tumor in the thalamus, which had dead, a cavernoma, which needed excision. Now the thing is, where do we approach it from? So we do the connectomics. The top cut is the language system. You're seeing the arcuate fasciculus going around the tumor, and the sort of solid things that you're seeing, these are the parsinations. Below is the corticospinal tract. So obviously you cannot go from above the lesion. And this is the IFOF, which is going just beneath the inferior part of the lesion. So it limits your approach from below also. And then there are these other tracts, salience and frontal aslan. And then you can combine all of these together to find which are the areas you cannot go through. And you can find that there is a corridor from the temporal lobe through which you can approach the tumor, but you have to be careful you don't go above, and you have to be careful you don't go a little bit below so that the IFOF is not damaged. So using this, you can actually try to find the surgical corridor and avoid the deficits. And this is the patient post-operative scan done in the intraoperative MRI immediately after the surgery, a complete excision of the tumor. The small hyperdense areas you're seeing are actually the surgery said with blood, and the patient was so coming to the pediatric brain tumors, this was applicable both to adults and children. In children, one is the head fixation problems. If the child is very small, you cannot put a Mayfield. No problems. Put him on a horseshoe and operate. Not a different problem. The other consideration in children are the low blood volume. So you have to be very meticulous in your surgery as to avoid any excessive blood loss, hypothermia. In children, often the tumors are large. They don't present early, and therefore they pose a challenge. But there is advantages of brain plasticity. So even if a tumor is near an eloquent area, recovery could occur. So I'm just going to take you through a series of cases to illustrate these points. Young girl, initially operated in Iraq, the cyst was aspirated. Expectedly, patient worsened again. Large tumor, but the solid component was more inferiorly. So a complete excision was done, total blood loss 150 ml, biopsy was an ependymoma. And this is the patient immediately post-op, complete tumor removal, a subdural was there. Now, this is a problem with a large cystic tumor in a child. Often the skull is enlarged, and once the cystic tumor is removed, the brain collapses and bleeding can occur in the subdural space. And subdural hygromas are also common. So subdural hygromas, be careful, you don't need to treat all of them, especially in a large child and a small child. Another patient with headache for 3 months, seizures, left hemiparesis, and a large tumor going across the midline to the opposite side. So how do you approach this? What is the principle? Draw the long axis of the tumor and extend it to the surface to decide the skull opening and the surgical trajectory. And this helps you to reach the deepest part of the tumor and excise it. The only caveat is, if where it is extending is the eloquent area, obviously you have to change your track. So this is the long axis of the tumor, and that is the point in the cortex where the corticectomy should be done. So again, this turned out to be an epidermoid. 150 ml blood loss, the complete tumor removal post-operative. Patient is doing well. At 1 year post-op, no residue. Another case, headache, vomiting, diplopia, right hemiparesis, and you see this nasty looking tumor in the front. And the approach is not difficult, but this was a highly vascular tumor, 600 ml blood loss. It was a high-grade lymphoma. Post-op scan, good result. PET scan, and we had MRI 2 months, showed no tumor. Patient is on chemotherapy. So how do you manage this blood loss in such tumors? You have to preempt blood loss. You have to try to control the fetus aggressively. You should not rush in for a decompression without devascularizing the tumor. So the technique is to do as much surface coagulation as possible and keep going on the sides as much as possible without too much retraction of the brain. And once you reach a limit and you find that further coagulation on the surface would need more sort of aggressive removal, you would then decompress partly and then go in again. So you go in from the top, keep coagulating it. Once you reach the limit, decompress, gives you more space, then keep going around it. Another patient with vomiting, left hemiparesis, and you have this large tumor. It's a nasty looking tumor, aggressive tumor. It was a ATRT, 450 ml blood loss. Post-operatively, she worsened a bit, had wound infection, but gradually improved. This is the post-operative scan, complete tumor removal. This is at 1 month post-op. 4 months, there's a subdural present. 8 months, the subdural is the same size. Patient is doing well. So remember, in children, subdurals are fairly common, especially with large tumors. And we don't have to be aggressive with them. They often remain there. They are not symptomatic and they don't need compared to an adult. Another patient with seizures. This was a large tumor with a bleed in it. That's the tumor. Again, go in for a complete tumor removal, be aggressive, take it out. This patient was bad preoperatively. It was a grade 4. This patient did not do well. Although we did a complete tumor removal, the patient expired within 3 weeks. He was too sick. Another patient with a large tumor in the occipital region, a massive tumor. It turned out to be a PNET. This was in 2012, we'd operated. Post-operative scan at 3 months, no tumor. Followed up for 5 years, no tumor, and the patient is doing well. So gross total removal is possible even in large tumors. This is a patient with a large tumor on the right side, a young child. This is a solid and a cystic component, which we had to operate. Operated in 2008. Post-op, we found there was some residual enhancement. And we were concerned. It was a low-grade glioma. We thought whether we should go in again and take it out. But we decided to keep a watch on it. And 1 year later, we found that the enhancement had reduced. So it was obviously not a tumor. And that's the child, a happy child. We followed it up. 2 years later, the enhancement increased. At this stage, we offered the patient surgery, but the family was very reluctant. Another year later, to our surprise, it had not increased. It had been static. 2 years later, still static after the recurrence. And this is the child, has grown up a bit 3 years later, but still doing well. And then suddenly after 3-4 years, it again started increasing. And now the patient was waiting for surgery and we reoperated. It was again a low-grade tumor. The patient did well. The post-operative scan was normal. And we followed it up and he is now grown up and the patient is doing well. So the lesson to be learned is all post-op enhancing areas are not tumors. And it could be a post-operative change. And whenever there is a doubt, follow up the patient. Don't be in a hurry to go in again. And that will help us know the nature of the lesion. And delayed enhancing areas could be radiation change. Now that we do scans routinely, prospectively, don't wait for patients to deteriorate. A large number of post-operative scans. I think I'll stop here. I've finished my time. So just to briefly tell you, thalamic tumors can be operated. You have to do tractography to find out where is the corridor. Obviously, you can't come from front. You have to go from back here. Small tumors, just a stereotactic biopsy. A tumor going into the ventricle, a transcondosal ipsilateral. The medium-sized tumor, again, can be operated on the same side, transcondosal. But a large tumor, where the lateral margin of the tumor is very lateral. If you try to do this ipsilateral, you're going to have to retract a lot of brain retraction. So going from the opposite side is a long surgery. You need long instruments, but you don't damage the brain. Some tumors, thalamic tumors, don't come up to the ventricle. There you have to go transtemporal. It's a partial excision here, but the patient is well. The posterior thalamic tumors, the supracerebellar approach works. And such a deep-seated lesion, you can see the post-op scan below with a complete removal. So the lessons learned are large pediatric brain tumors should be managed by aggressive surgical approach. And the aim is gross total or near total excision. But you have to control the bleeding. You have to have advanced DTI and now connectomics to choose the safest corridor. Use intraoperative neuromonitoring techniques to have good results. And neuronal plasticity also helps. Thank you for your attention.
Thank you, sir. Thank you, sir, for a nice presentation. Excellent results. I have a question for you. How many cases have you seen the grade 1 and grade 2 transforming into grade 3 or 4 later in the years in pediatric glioma?
In pediatrics, it's not so common, but adults certainly it occurs. If you leave a tumor in and some people say, just say, sir, come with a tumor with a couple of seizures, and you see us on the image, you see a tumor, which is not very big, not causing mass effect. Often the family says, why do you want to operate on me? I'm doing well. My seizures are controlled on anti-epileptics. Why should I get operated? And the reason is this, because after 8 to 10 years, malignant transformation to a secondary glioblastoma is very well described. And that's a natural course of the history. So the reason to operate these patients and reduce it and completely remove it aggressively to get a complete tumor removal is because you prevent the potential of going on into grade translocation.
Thank you. Any other question? Maybe we can allow one more question. Sir, thank you so much. Okay. Now it's my opportunity to invite Professor Gopal Raman Sharma to present his topic on the experience of brain AVMs, surgery complication and complication avoidance and management.
Hello.
Thank you, sir.
Good morning, everybody. I would like to thank the organizing committee for giving me this wonderful opportunity to share my experience on AVM surgery. And thank you very much for your kind hospitality. The cerebral AVM is one of the very rare neurovascular condition. The incidence is about 1 in 100,000 population, and the prevalence is about 18 per 100,000 population. It's so rare that I hardly see 5-6 cases per year. But the management of this AVM is a challenge for all neurosurgeons. It's very difficult to treat. Okay. So I will only deal with the surgery. The other part of the treatment will be dealt by the other people. So surgery is the best option, and cure rate is more than 95%. And it is clear from the previous experiences and previous literature that if an AVM is not suitable for surgery, then it's also not suitable for the radiosurgery and embolization. So the surgery is the still best one. I don't know what happens tomorrow. So the aim of the cerebral AVM surgery is to have complete excision of AVM and preserving the normal vascular anatomy, preserving the normal brain parenchyma, and having less or no brain metastasis. So these are the operative armamentarium and ABM surgery. This, hello. This you see this tractography, which Professor Singh said, is one of the very important. You see the imaging to prevent this deficit post-operatively. It will show you all the tracks, and it will also show the relation between the tracks and the lesions. And neurophysiological monitoring. This is one of the best. You see the intraoperative gadget. And intraoperative fluorescence is good for the superficial ABM. Transcranial Doppler sometimes can be helpful to rule out the feeders and the draining vein. And neuronavigation, if it's small and you see the deep seated, this neuronavigation can be useful. So these are some of the steps for the ABM surgery. It's better to do most of the time as an elective, but in case of if the patient had big hematoma with the compromised GCS, then we can do it as an emergency procedures. We need wide exposure, wide craniotomy to see all the anatomy of the ABM. And while opening the dura, we should be very careful. In many occasions, the inner surface of the dura is adherent to the nidus or the draining vein or the feeders. So we should be very careful. Otherwise, the bleeding starts before opening the dura. And then you identify the major feeders, draining vein, and the nidus, doing this ICG. Then you start arachnoid and pile dissection, identify the feeders, and then you start occluding the feeders, main feeders, superficial feeders, and then gradually you start circumferential excision of the nidus. And while you go in, you will encounter many feeders and the perforators, which are very notorious. They tend to bleed very easily. They are fragile and they are sticky. So you have to be very careful. And after you see the circumferential dissection, lastly, finally, we do the occlusion of the draining veins. And then after that, we do the ICG to see if there is any residual ABM. So these are the main complications. Intraoperative complication in supratentorial and infratentorial are the same. Hemorrhage and brain edema. These are the most two common and the serious intraoperative complications. And postoperatively, again, hemorrhage and the brain edema are two most common complications, and followed by these neurological deficits. So I'm just going through the small video clips. This is 16 years female. The 16 years female who presented with the right-sided occipital hematoma. Our GCS on arrival was 13. So we did it as an emergency procedures. So after this corticectomy, I went in and just started doing the circumferential excision. Here I like to show this. I don't know whether you are seeing it or this is the perforator. We have to be very careful, and we have patience to deal with it. It's very friable and it's easily get retracted. So you take time to coagulate it. So next is this 35 years right-handed gentleman who presented with the uncontrolled focal seizure with secondary generalization. The CT MRI shows right frontoparietal large mass with calcification. The angiogram showed, you see the grade 4 AVM fed by the right MCA branches and the pericallosal. So, video please. So you see this is a very nasty big AVM. You see the feeders and the draining veins. There are two draining veins. So after you see the arachnoid and pile dissection, you start clipping these feeders
clip it, coagulate it, and cut it. So you just go it around the nidus. So this, yes, you just put the clip. This is the, you see the subcortical dissection. We just go around. This is some of the small feeders. So now finally, after the occlusion of the feeders, this is the draining vein. And then you just cut it. And this is another draining vein, which is draining the superior sagittal sinus. The last one was draining into the transverse sinus. And this is the last. And post-operatively, this gentleman, after 1 week, he developed hematoma. Probably it's due to either high blood pressure or maybe perfusion, normal pressure, perfusion breakthrough. But we did just the, you see the, this is some residual left behind. So we just take out the some residual parts of the AVM, which was left behind. We did the ICG and found out that residual one. So we did the decompressive craniotomy and we didn't take out the hematoma because it was near the motor strip. So post-operatively, after 3 months, he had mild deficit, but he was to walk independently. Esco. So next one is 35 years female who presented with the left frontal ICS. Her GCS was 15, so we did add an elective case. The grade was spatial margin grade 5. And this is huge left frontal AVM fed by the pericallosal and callosomarginal arteries. This one. Yeah, this is the DSA, high flow AVM. So we did the, you see the surgery. It took us about 18 hours to finish it. And luckily, the lady survived. Yeah. So post-operatively, she had pseudomeningocele with the bone defect. And after 3 months, the pseudomeningocele resolved and we did the cranioplasty. And so like that, we just first, this is the pre-dissection, this angiography. The nidus is inside the cortex. So these are the feeders and the draining vein. So we just did the, you see the circumferential excision. So over the last 10 years, we did about 50 cases. And the male were 2 times more than the female. The mean age was 35 years. Most of 85% of them presented with the hemorrhage. The size was the size was 3 to 6 centimeter was in 64%, and we had 11 patients having size more than 6 centimeter. And regarding spatial Martin grade, we had 30 patients had spatial Martin grade 3, 18 had grade 4, and we had a spatial Martin grade 2 in 2 patients. And mean supplementary grade was 5. And 74% of the ABM were in allocant area. 64% of the draining vein were deep. So I would like to say the passion and the passage are the keys of success for neurovascular surgery. Age, comorbidities, grade of AVM, and surgeon's experience are some of the important complications and outcome predictors. Complications of AVM surgery can be minimized by selecting suitable candidates, utilizing modern technology, and performed by the experienced hand. Thank you so much indeed.
Thank you, sir. Thank you, sir, for showing us a very complicated surgery. I have a question. Was that lady with a grade 5 ABM? How do you decide that she needs surgery?
She came with the bleeding.
Okay.
She was 25 years old. She had money.
Okay. Okay.
They couldn't. So I told multiple embolization. They just want to do it in one go.
Okay.
So I told them that you see the complication is very high. Maybe she died on the table, 25% mortality. So her husband said, okay, do it. So I did it.
But we have very young, residents here also. They should not be distracted by this fact that he is a very experienced surgeon. He attacked grade 5 doesn't mean that we should also attack grade 5. Be very careful. Classical teaching, grade 4 and grade 5, you do not recommend surgery as a first step.
Yes.
Unless there is a recurrent bleed or patient has a neurological worsening. So I just.
Yes, that's true. The bone sign is basilar. You see they introduced the 3-tier grading system, A, B, C. In grade 1 means Spezler Martin grade 1 and 2, which is suitable for surgery. B, Spezler Martin grade 3, multimodality treatment. And grade C means grade 4 and grade 5. They said they are not the candidate for the treatment. But if a patient comes with the massive bleed, what will you do?
Okay.
You have to do something. You have to do something. There is no choice. That's
Hello, Anwar, you have any opinion on this topic? You want to say something? You attack grade 5 IBM?
We go according to the classic books, special matter grading system.
Okay. So any other opinion? Anything you want to add? Any, please.
Fives are generally not suitable, so to say, but you have to do something as.
Yeah.
Yeah.
If the family asks for
What I
something.
would do is we generally sort of try to see if some part can be embolized.
No, they are financially, they are not able to go for that. Yeah.
First day was welcome.
But in an ideal situation, one would like to embolize as far as possible.
Yeah.
And then do radio.
Yeah.
This radio surgery could be volume stage or dose stage. And preference the dose is supposed to be inferior to volume stage. So you identify, break up the AVM into 2 or 3 parts, each of about 10 cc each, and then give radiation, radio surgery to one part. And after 3 to 6 months, give it here. So the results are not perfect, but the outcomes are reasonably good without death.
Yes, sir, but you are telling about the asymptomatic AVM. What will do for the AVM with bleed? That's the problem.
Thank you, sir. Ali, you will have the opportunity to ask in the next session because I have been instructed by the organizer. We are running behind by 40 minutes. Thank you so much, sir. Thank you so much. Ali, you will have the opportunity. Now, I'd like to invite the last presentation of this session. Professor Krishna Sharma is going to talk on the topic current concept of spinal fusion.
Good afternoon. I'll be putting my thoughts on the current concept of spinal fusion. Can I have the slides, please? Next. Yeah, spinal fusion is a surgery that joins selected bones together so that motion no longer occurs between the 2 bones and becomes stable. This concept was initially started in Port Spine almost more than a century ago. And the fusion is one of the most commonly performed yet incompletely understood procedure in spine. So there is a lot of research going on to make this fusion a more effective, safe, and less complicated procedure. So fusion is a natural process of healing in trauma, in infection, in inflammation, and in some of the degenerative procedure, but usually they are inadequate and inappropriate. And there is no natural fusion or stabilization in malignancy and congenital anomalies. The fusion occurs in 4 phases: neovascularization, soft callus formation, reapproximation, and a mature bony callus formation, and they take around 3 to 6 months. The indication for spinal fusion is the first one, the instability, which can be caused by trauma, degeneration, iatrogenic like surgeries, neoplasm, congenital anomalies. When there is persistent pain, as well as when there is a progressive deformity, the fusion is warranted. Now, fusion is also not indicated, this one we have to know, when the stable segment is there with osteophytes, which is a natural form of stabilization. When enterolesthesis is less than 3 millimeter on static and dynamic imaging, and there's significant loss of disc space less than 2 millimeter with no movement, again, which is a natural way of seeing there's a spinal fusion. And in geriatrics, even grade 1 and grade 2 listhesis may be seen normally. And if we try to intervene in this, there will be more problem. The studies has shown 80% of these cases require a resurgery if you try to manipulate them. When to fuse, Kulkarni has developed a scoring system. And in this one, he has divided into clinical, radiological, and technical factors, and given different scores. When the score is more than 5.5, they indicate that they benefit by fusion. There are many factors influencing the fusion. So when you consider fusion in any cases, we have to consider all these things and try to correct as much as possible before you embark on this procedure. I'll not go into detail because of lack of time. Now, bone graft is a very important component of spinal fusion, which facilitates, enhances, and helps bone fusion, and which makes a bridge between these two segments. The properties of the bone graft is defined by this osteogenesis, osteoinduction, osteoconduction, and osteointegration factors. Now, the natural bone graft we all know is the autologous bone graft, which is the gold standard, and a lot of us we're still practicing that. They talk about a lot of donor side morbidity. So the allograft has come up, but I don't think it is much available in Nepal. So we are still dependent on the autograft in most of our centers. The graft could be onlay or inlay. The gold standard, the iliac crest bone graft is there. So now there are many methods that have come up to enhance and augment the fusion by grafts, instrumentation. There are biological substances that enhance the fusion, and there are many pharmacological agents we have to consider that also enhances fusion. Now, the bone grafts are very extensively searched and researched, and they investigate the material that can either replace or reduce the amount of autograft required to achieve adequate bone healing after spinal surgery. And these are judged by their biomechanical properties, biodegradability, microscale architecture, and surgical handling properties. And these are broadly divided into either a bone graft enhancer or a bone graft extenders. These bone graft enhancers are the natural component taken out from the various natural substances from the body, and they are used along with the bone grafts. And they produce a lot of bone growth factors, which I have enumerated here. And the common ones, which is most used, is the bone morphogenic proteins, though there are many others which are not that popular. The Okay, the bone graft extenders are just the scaffold actually through which the bone grows in. But it is very important to give a immediate stability. And in combination with the autograft materials or the bone graft enhancers, this autologous bone graft or bone marrow aspirate, the fusion rate is almost 86%. The commonly used are the ceramic compounds, bioactive glasses. They are not exactly glasses. These are the metallic oxide material with the main component of silicon dioxide. They are hard and these are non-porous, but nowadays they have modified into porous ones so that the bone can grow into these small pores and make the fusion a very good one, almost 71 to 100%. Now the bone graft extenders, the one we commonly use are the polymethyl methacrylate. And these are, I think, most of us use in our surgeries in cervical spine and in the other spines. Now, these bone graft substitutes are the substitutes that are the cages, or they can be used with or without bone grafts. The most commonly used before was stainless steel. I think now it is no longer used. Nowadays, the most commonly used are the titanium, PEEK cages, ceramic, polymethyl methacrylate, hydroxyapatite, and tricalcium phosphate. These increase the strength and with immediate strength, and the long-term one, they have a short operative time, maintain intervertebral disc height, and there's no subsidence, they don't collapse. So they reestablish the lordotic angle, reduce the bone donor site, and achieves a comparable fusion. There are many growth factors that are coming up. There is a new technology, mitosis, which is grow into the bones later on, and recombinant human bone morphogenic protein and other transforming factors. The other additions are the bone fusion is further enhanced by bone stimulators and even low intensity pulse ultrasound accelerated bone. They look very attractive, but I don't think it is practiced widely. Now, fusion also has got limitation. There's no immediate stability unless you use some stabilization technique. There is pseudo-arthrosis or non-fusion. There's post-operative prolonged use of external arthrosis if you don't support inside. Graft displacement, subsidence, donor site complication, loss of motion, resulting into sagittal imbalance, disturbed biomechanics, and adjacent segment diseases. Now, instrumented fusion has come to overcome most of these limitations. And in the last 50 years, this instrumented fusion is done so much and so much and so much. Rather, it has made us forget what really fusion is. So most of us are only doing fusion, but not, instrumentation, but not fusion. This is what we have to be careful about. Of course, the instrumented fusion enhances and accelerates the solid fusion. It maintains the anatomical alignment immediately until a solid fusion occurs, and reduces callus formation because there is solid less of a movement, and there's least chance of pseudoarthrosis. It prevents graft displacement and maintains a curvature of biomagnetic spine and corrects deformities or misalignment if it is already there. Now, these are the few ways we're doing plate screws, pedicle screws, lateral marshes that have been used. As I just talked about, now the concept of no fusion or the dynamic fusion is coming, where the physiological movement is allowed. And this is done by disc arthroplasty, and even posterior dynamic rod fixation have come. The instrumented fusion are indicated when there is more than a 3 millimeter listhesis. These are almost the reverse of what we talked about earlier. So I will skip most of them, but I would like to emphasize that osteoporosis, which is a very common phenomenon which most of us are missing, needs instrumentation, which has to be investigated before we do a major fusion procedures, because it is bound to fail if we don't do that. And malignancy, of course, it needs instrumented fusion, and congenital instability, they will never fuse if you don't instrument them. Limitation of course, instrument fusion is loss of motion again. There's extensive surgery, we all know that. There's a hardware failure, the construction subsidence is there, and injury to the neurovascular structures. A lot of us has experience with the pedicle screw injuring the roots. The addition is the nanotechnology in instrumentation. What it really means is that we, on the surface of these pedicle screws and the cages, we put substances like antibiotic to reduce the infection. We put growth factors to enhance fusions. And we even put nanocrystalline synthetic bones so that the fusion is very, very strong and immediate. And this is has not come into the practice, but it is an intervertebral disc spacer, which immediately gives a very stable construct. But as the bone grows inside, it gets absorbed. So finally, what we have is only the natural bone that has fused. Now, there are a lot of this, even the peak bones, everything is now becoming porous, so that the fusion is emphasized so much. Through this porous, either the bone growth grows in, or they have bone growth factors that have been installed. So the fusion is very, very important. So, but the validity of fusion is questioned nowadays because, again, there's a loss of mobility. So to reduce that, there are only instrumentation is being done, especially in minimally invasive spine surgery. So we have to be careful what we're dealing with. What we are not told in minimally invasive spine surgery is that those screws we put where percutaneously are also actually has to be with the bone growth factors, because they also need fusion. Otherwise, they will loosen ultimately. So others one are disc arthroplasty, mobile fixation, and polymethyl methacrylate spacers are being used in our institution most probably and giving a very good result. And of course, the absorbable instruments are also coming up. Sorry, reverse. Sorry. Right. Reverse curses. Sorry. So the future direction is that now we have got a 3D printed composite materials like in cranioplasty we see. So we already planned for a surgery where through the 3D printing, we already have a graft that fits right into that one, and which is porous, where either we let the natural bone to grow in, or we put a bone growth factors, so the bone grows into it. So all it trying to emphasize is the fusion has to be there ultimately. So points to consider, I think, is the correcting and controlling other associated medical condition is also necessary. Please do not rush into the surgery itself, like a nutritional status, and supervised physiotherapy is very, very important. The fusion has become an integral part of spine surgery, especially when instability is present. Fusion should only be done in a properly indicated patients. There will be a lot of technological instrumentation and development that we'll read in journal clubs and in the journals. But please don't rush into using them in your institute unless we have a very solid proof that it really works. Otherwise, like this lady, we'll burn our lips. Let the froth settle down. Let the things be proven. And please mind you, latest may not be the best. What you're doing now could be still the best under your circumstances. We have to consider that. So many things, many things are influence your decision to do a spine surgery. One more point I would like to put is that there is no prophylactic surgery in spine. It's only therapeutic. You can't expect something to become unstable after 5 years and fuse it right now. That prophylactic surgery is not really a scientific approach in spine surgery. So all these factors which we have talked about all this little time had to be undergo a group discussion and planning, and we have to do one procedure and one particular patient. We may be talking about different theories, but when we're dealing with a patient, then we have to decide on one way of doing it. So putting all these factors together, discussing among ourselves, then we come to a solution. What are we going to do in this particular patient? Thank you very much.
Thank you. Thank you, Krishna sir. We agree with you totally, especially last two slides. So because we have been instructed not to entertain any question because of lack of time. Thank you, sir. Thank you. Please come. On behalf of my co-chair, Dr. Krishna Sharma, and myself, officially conclude this plenary session today because we are already running behind time. Thank you so much for the opportunity, organizers.
Thank you, gentlemen. Thank you, gentlemen. That was quite an informative session. Recently, we have been saddened by the news of the demise of late Dr. Kumar Shanshir Rana, and I would like to respectfully request everyone to rise from their seats to observe a minute of silence in his loving memory. Thank you. Moving on to the next session of the day, I would like to cordially invite the past president of NESONCON, Professor Dr. Pavan Kumar Saltania, and President-elect of NESON, Dr. Yam Badar Roka, on stage. I would like to invite the Scientific Committee Chair of NESON, Professor Dr. Amit Thapa, to introduce the orator of the session.
Thank you. May I have the slide, please? Ladies and gentlemen, it's my privilege and honor to introduce to you the oration, Professor Dr. Pavan Kumar Sultania oration. Well, this is a very distinguished oration which has been introduced this year with the generous contribution by none other than Professor Sultania himself. And this is to honor the expertise of one specialist all over the world. And this is to bring his specialty to the crowd here so that we can be honored as well as learn from their experience. So to introduce the Professor Pavan Kumar Sultania, well, he does not need any introduction to this crowd, but just to highlight his illustrious career to complete the proceeding, he had been the second president of our Nepalese Society of Neurosurgeons, and he has led the department of NAMS as well as Nepal Medical College, and had been working in Om Hospital and Research Center. And in year 2001, he had been decorated with Birendra Aishwarya Service Medal for his illustrious career. Born to Mr. Sultania and Mrs. Sultania in 1953, he has 5 brothers and 2 sisters, married to Dr. Sheila Burma, and he has 2 kids, Luna and Akeem. He had a very illustrious career as well as academic perseverance, and he had been the president of South Asian Neurosurgical Society from year 2012 to 15, and also the president of our NESON from 2010 to 13. Well, to introduce the orator, Professor Shashank Sharat Kale, he is an HOD of Neurosurgery, AIMS New Delhi, a world-class neurosurgeon, my teacher, He specializes in complex cervical, occipitocervical, thoracic, lumbar, and sacral pathologies, tumor infusion and fixation. And he has the largest series in developmental CVJ anomalies and spine tuberculosis. He is presently working on training facilities for spine, and he looks forward training the new neurosurgeons, new generations of neurosurgeons in spine care. He was born in 23rd of May, 1963, and he graduated from MAMC, and he did his neurosurgical residency from AIMS 1996. Yeah, well, this slide I think is old. It has been replaced by the newer one, but then this has not been uploaded, it seems. Well, it says that the genius runs in families, and he is being, his son Amaya and his daughter are carrying this MBBS education, and we hope to see them in long run. So, ladies and gentlemen, I bring to you the orator, Professor Saril Sakshar Kale, to you. Dr. Kale, sir.
Namaste, everybody. Can you all see me? Am I audible?
Yes, sir, we can hear you.
Okay. So should I share my screen?
Yes, sir, please do.
Okay. Namaste and good morning to everybody in the audience, as well as the dignitaries on the dais. I feel so honored to be invited to start this series of Pavan Sultania orations, which I'm sure are going to carry on for years and decades, and bring neurosurgeons from all over the world together to share their thoughts with the Nepalese society in future. My association with Dr. Pavan goes back to the mid-90s, when I was a resident in neurosurgery in All India Institute of Medical Sciences, and Dr. Pavan Sultania came as an overseas fellow to train with Professor V.S. Mehta. And I used to watch him and wonder, people come from, that was my first experience to see somebody who has come from different country to train. And that's when we got to know each other. And it's almost 25 years, it's 2.5 decades since we have known each other. And we developed a very good friendship over the last 2.5 decades. And I feel so proud to be here today to give this oration, and the first one of this, I'm sure, which is going to be a magnificent series over the next few years and decades. My thanks to the organizers. My thanks to Dr. Amit for saying these kind words as my introduction. Let me get down to the talk straight away. I'm going to talk today on the evolution of surgical approaches to the CV junction. A few years ago, I saw this movie, which the title of that movie was Back to the Future. I was set me wondering, Back to the Future, it's kind of self-referential and it doesn't sound too correct. But then now I realize that it can have different meanings. And for me, in the context of CV junction surgery, it has an entirely different meaning. And over the next few minutes, I'm going to try and see how this unique title fits to the evolution of surgical approaches to the CV junction. Now, we all know that the joints at the CV junction are unique in the body. They're highly mobile, but still they are stable and gives a Y-shaped spinal support. And there are critical neurovascular structures which run through this. I will not go into the details. I'm sure all of us are well versed with this. So the problems which can occur with this is instability. Instability because of facetal malalignment and ligamentous problems, high mobility of the joint. So whenever the joints are very mobile, it is difficult to achieve adequate fixation. And if you do that, then you restrict the motion completely. And, saying yes or saying no is what differentiates us from other mammals. And if you restrict that ability of nodding your head or shaking your head, it does restrict life. Apart from that, the surgical exposures and the risk of critical neurovascular structures, injury to the vertebral artery, to the C2 ganglion, the blood loss over there because of the venous plexus around the vertebral artery, and of course, neural injury if you happen to misdirect instruments inside the spinal canal. So dealing with CV junction pathologies has always been a challenge. On top of that, it is not just the bone, but it's also the soft tissue inside which causes problems. For example, Chiari malformation or syringomyelia or syringobulbia. And many times these bony and the soft tissue problems exist side by side. And we have to deal with both of them, the bony as well as the soft tissue problems. And that adds a new dimension to the management of these patients. So let me first establish some terminology or revise some terminologies all over again. You know, what is atlantoaxial dislocation? What is basilar invagination? What is cranial settling? What's the difference between cranial settling and basilar invagination? What is occipitalization of atlas? And these are some of the morphometric lines at the CV junction, namely the important ones being the Chamberlain line, the McGregor line, and the McRae line. And these lines drawn on an X-ray or a CT scan will tell us exactly what is happening in the alignment of the upper part of the cervical spine or the craniovertebral junction. Another important concept which we look at is any patient who comes with a CV junction problem, we first try and find out whether it is reducible or whether the problem is fixed or the atlantoaxial dislocation is fixed. Now, the example on the left of the slide is a reducible atlantoaxial dislocation. If you see, I hope you can see my pointer, there is dislocation when the patient flexes, and when the patient extends his neck, the dislocation reduces completely. So this is what is meant by reducible. While here on the right, it is fixed. It doesn't move much with flexion and extension of the neck. So in dealing with these problems, how has the philosophy changed over the years? The earliest approach was to fix the CVJ. You know, whatever happens, go from the back, fix the upper cervical spine to the occiput. Whether it is reducible, irreducible, whatever it is, fix it. That was one of the earliest approaches to the CV junction. The second was the offending bone, which usually lies anterior. Usually it's the C2 body or the odontoid process. Direct decompression of this offending pathological bone. So you go anterior. You go anterior, remove the bone, and then go from the back and fix it. So that was the next step of evolution. And I happened to start doing CV junction cases when this direct decompress and fixation was the therapy in vogue for CV junction problems. So we must have done hundreds and hundreds of transoral surgeries, all kinds of transoral surgeries where we had to remove the clivus, some part of the clivus to the C3, and we managed to remove all of them through the anterior approach, either sometimes using even Lee-Ford approaches to swing the maxilla or to split the mandible and the tongue, you know, big surgeries, gross surgeries, but somehow get direct decompression and remove the offending bone anteriorly and then go from the back and stabilize. And over the last few years, new ideas have been developed. One is an indirect decompress and fix. So you go only from the back, the approaches as advised by Professor Goel, Professor Atul Goel in Mumbai, and from Germany, that you go from the back. You go only from the back. You manipulate the joint, you distract, you do, and then you fix it in that position. And once you do that, the decompression is achieved. Another idea which got developed was you manipulate the joint. You know, you go from the back, but you somehow reform the joints. You may have to drill, you may have to reshape the joint, make the surface flat so that you can have your spacers over there. And I think the next step which is going to come is somehow we are going to develop a technique to change the joint completely. like a knee replacement or a hip replacement. I think that is what we are looking at in the future. So let us see how this philosophy has evolved over the years. Mixter and Osgood, 1910, they first used braided sutures to tie the occiput and the cervical spine together. Then came around Galley's fixation, C1, C2 laminar wiring. These were all posterior only, and they were semi-rigid construct. By semi-rigid, I mean there is no screw going into the bone and making a rigid construct. So unless you have screws going into bone and holding bones together, all other constructs are regarded as semi-rigid. It could be wires, it could be clamps, it could be any one of these, Galley fixation, we place a bone graft, but you have sublaminar wires around the C1 arch or the C2 arch or fixed to the C2 spinous process. All kinds of these H-shaped graft or two grafts, one on each side. There were different modifications developed to achieve stability between C1 and C2 joint. Then Brooke came along in 1978 and said that, okay, I have a superior idea where it's biomechanically better. Especially it prevents rotation because you have a wire sublaminar under the C1 and C2 arches on either side of the midline. So it is much better than having a wire which fixes to the midline of the C2 spinous process. And the fusion rates increased. They became as high as 93%. Then the Sontag had another modification, Dickman and Sontag. So they said, well, passing a C2 sublaminar wire can be tricky. C1 is easy. There is a lot of space under the C1 lamina, but sometimes passing it under C2 is tricky. So avoid that. Avoid passing a second sublaminar wire. And they advised this kind of a fixation. Then came Halifax clamps. The clamp, the upper claw sits above the C1 arch. The lower claw sits below the C2 lamina. And the screw holds these two clamps together. And you kind of hold the C1 and C2 together with these two claw clamps. This also gives a stability, but the pseudoarthrosis used to occur. There was always some loosening and the stability issues were still there with these. Then Professor Jain from SGPGI, he has done some seminal work with Professor Bihari, and they developed a new technique. They said there is no need, if there is C1 is fused to the occiput, there is no need to do anything but create an artificial C1, drill away part of the lower part of the occiput so that you have a kind of a C1 posterior arch developed in the occipital bone. And then you fuse the C2 to this artificial C1 arch. And this technique was popularized by the SGPGI team, and it gained traction for a few years. It was easier in the sense that you had to remove some bone of the occiput to make an artificial C1 arch. And then the C2, you already had a big spinous process. So you could wedge a graft between this artificially created C1 and the spinous process of C2. So all these posterior semi-rigid constructs have some caveats. You require an intact lamina, and there are high failure rates. In spite of all these innovations, clamps and etc., there still were high failure rate. And there were certain contraindications. If suppose the posterior elements are absent, he has undergone some surgery before, or there are congenital malformations where the posterior elements are absent, you can't do all these surgeries. Or if there is cervical canal stenosis at that level, with a narrow canal diameter, so passing a sublaminar wire is dangerous. And 5 to 7% of these cases, if you see the series published in the last 2 or 3 decades, 7% of cases developed quadriparesis in all these posterior semi-rigid constructs. Of course, in the end, suppose nothing goes wrong and everything is fine, you can always have a breakage of wire or slippage of the claw, implant slippage, or the graft may slip from behind the wires. So all these problems were there, which led to failure of these posterior semi-rigid constructs. Then came along Professor Magel, and he said, why don't we put a transarticular screw? You start from the C2, you go through the joint and put it in the lateral mass of C1, make sure it doesn't project too much anteriorly. And this gives a very stable, because you have 2 points of fixation on either side of the midline. And if you add a galleys construct in the midline, which this picture shows over here, then you have a 3-point stabilization, which is supposed to be the gold standard in biomechanics. If you have a 3-legged stool is one of the most stable structures, much better than a two-legged chair or a stool doesn't work, while a 3-legged stool or a chair will work. And so this method was also popularized. However, there was a learning curve involved in guiding that screw from C2 to C1, and there was always a risk of injuring the vertebral artery, which you see, which traverses through this foramen and generally lies near the C1, C2 joint. So there were some instances of injury to the vertebral artery because of this technique. There was some issues there as well. We did a lot of these cases, some of the pictures from here from our series. Even if you don't put a wire and you put a big bone graft between the C1 and C2, as you can see in this picture over here, it goes on to fuse into a solid mass and gives excellent stability. You have 3 points of support, one on either side of the midline and a midline galleys fusion, and it gives a very nice. And our fusion rates at All India Institute were between 85 to 98% when we analyzed different surgeons and all kinds of age groups, especially the elderly, where we generally hesitate to do all these complicated surgeries, but even they tolerated it very well. So this became popular and was continued till we realized that, okay, the vertebral artery does get injured. So when does it get injured? Then we realized the dimensions of the pedicle are important. And you have to see the size of the pedicle as this arrow points. And this notch which you see is actually the vertebral artery notch. And if it's a high riding vertebral artery, then your transarticular screw can lead to damage. This is still okay. There you have 4 or 5 millimeters. But if it is a high riding vertebral artery, then your direction of the screw may actually injure it. Or you may go medially, too much medial, you may enter the spinal cord, or anteriorly, if your projection is too much, you may pick up the hypoglossal nerve with the tip of the screw. So all these complications were there. Now came the anterior approach, which became very popular in the late 90s and the early part of the 2000s, where there is ventral decompression. And Dr. Menezes, it was first started by Canavel long time ago, but Dr. Menezes is the one who actually popularized it all over the world. Ventral decompression is necessary. Either you go transoral, transpharyngeal, somehow you enter anteriorly, decompress the offending bone, and then follow it up with a posterior fixation. So for that, there were 2 or 3 caveats. You needed to have an approach where by depressing the tongue, you are able to reach the offending bone. If you're not able to reach by opening the mouth, then you have to go for more extensive surgeries like the maxillotomies or the mandibulotomies or the glossotomies, and then put it back together. So there were some of them were very big surgeries, and we have done some of these surgeries in All India Institute, and try to reduce it first by putting traction. If it doesn't reduce, if it doesn't go below that line which you see, then you have to go in for these big surgeries. And sometimes the patient may have other problems where the mouth doesn't open. What I used to follow was, if you can put 3 fingers between the upper and lower incisors, you can do a safe transoral surgery. But if the mouth opening is less than 3 fingers, it is going to be a problem. So not all cases were amenable to this transoral odontoidectomy. And sometimes it led to either abandoning the surgery because couldn't open the mouth, or changing it to a big surgery where the mandible or the maxilla had to be removed or open. So the odontoidectomy technique was pretty simple. You identify the C1 tubercle anteriorly, you retract. Here are some pictures. The danger was of inadvertent dural puncture because there is very little space to actually repair the dura. And I'm talking about an era when these tissue glue, etc. were not there. And I've had some disasters where I had to try and stitch the dura anteriorly, or somehow put some fat graft or put some, it wouldn't stay. And ultimately, we had to restrict the patient's oral intake, put him on a lumbar drain and wait. And most of the times it stopped, but sometimes it led to meningitis. And meningitis is a horrible thing to happen after surgery. some pictures. I'm sure we can skip all that. Basically, the technique was the same. You open the mouth, reach the C1 tubercle, as you can see in the upper right picture. And once you have removed the C1, then you can approach the odontoid process, which is going inside the foramen magnum. And once you remove this offending bone, then all you have to do is come from the back and fix it. People have tried different innovations. They have done endoscopic odontoidectomies through the nose, etc., etc. But unfortunately or fortunately, I've never had the opportunity of doing an endoscopic odontoidectomy, but it has been done. This procedure, odontoidectomy, was not without complications. All these complications, Benzel and all reviewed all the literature published, and they came up with these. The transoral and transnasal have these complication rates. And if you see, more than 10% of the patients needed a tracheostomy after this procedure. Arterial injury, CSF leak, 30-day mortality was 2.9%. So it was not an easy operation. And in our series, I remember when we started in the 90s or in the early 90s to now, the mortality, we have steadily brought it down. And I think the last time we analyzed, our mortality rates were as good as or as bad as this publication from Dr. Benzel. We were down to 2%. And when we started out, the mortality rates for this CV junction surgery was about 11% the first time we analyzed it. That was when we published that paper with a series of 600 odd cases of CV junction problems. And the posterior fixations were developed were rigid fixation, occipito-cervical, either standalone or after a transoral surgery. You have some screws and a plate fixed to the occiput. You have some screws in the cervical spine, either in the lateral masses or in the pedicles. Now, Dr. Goel gave a new idea. He said, use the C1 lateral mass and the C2 pedicle screw and plate. That was his idea, original idea from 1989. And Harms propounded on this, explained it further. He said, you have a tulip head screw, and so you can put a rod over it. There is no need to put a plate. In the Dr. Goel's paper in 89, he actually said you put a small plate and fix that plate with two screws, one in C1 and one in C2. And Harms' technique was screws and a rod. The basic idea was the same. And that is why this procedure goes by the name of Goel-Harms procedure, and recognizing Dr. Goel's contribution earlier than Dr. Harms. Or at least we in India call it Goel-Harms procedure. I don't know whether the world accepts this or not. But here too, precise preoperative reduction of AAD is not a prerequisite. So it was, you could do it in almost any case. Vertebral artery injury was 4%, 2%, malpositioned screws, and all the complications related to navigating a screw in that small area or small bony area, if I may say so. Not without complications. Again, some learning curve was involved. This was Dr. Goel's original paper, which was published in 1989. Screw in C1, a small screw in C2, and a plate which fixes the joint. And Dr. Harms' procedure was this, the modification by Dr. Harms. You put a screw in C1 lateral mass, which has a tulip head. You put another screw in C2, and then there is a rod connecting all. You can even put it in the occipital. This OC1 joint can also be fixed with this kind of a technique. You can put the screw in the occipital part, condyle. So here you can see a condylar screw, an occipital C1 screw, and a C2 par screw, which holds this technique together. Disadvantage was the disruption of the posterior ligamentous complex. C2 root, sometimes you had to sacrifice C2 root. Many people, including Dr. Goel, believe that, oh, nothing happens, you can cut the C2 root. But then if you can avoid cutting any normal nerve, why shouldn't you? You should take all efforts to preserve as much neurology as possible. Anyhow, this technique became very popular, Harms technique. So if you have a problem in putting the screw in C2 inside the lateral masses, you can use the lamina. Here is a picture showing the lamina screws, and these two crossed screws can be used to fix it to the C1 screws which are above. So even this works very well. Then came the technique of joint manipulation. You know, Wang in 2006 said, you do an anterior capsulotomy of C1, C2 joint, you go anteriorly. You go anteriorly, do a capsulotomy, and you manipulate the joint. You distract or you put bone graft or you fuse it anterior. And if need be, you can again go posterior. You can have a C1, C2 joint reduction, realignment, and an occipital cervical fixation. And in Pune, Dr. Patkar has done a lot of work with this anterior C1, C2 joint surgery. And he always says that I prefer to go anteriorly, and it works very well in his hands. Unfortunately, not many takers for this anterior C1, C2 fixation procedure, and it hasn't become as popular as the posterior approach. Then came Dr. Sharad in my department, in our department in AIMS, and he developed this technique. Everything you can do posteriorly. You can reduce, you can distract, you can compress, and if you add that with extension, you can get a beautiful reduction. Essentially, one step forward in defining Dr. Goel and Harm's technique. That's how I look at this. The advantages, even if the atlas is occipitalized, you can still do it. You use spacers for distraction, and then you can compress the bones over the spacers to make a solid fusion, and it results in extension and reduction. And so you can avoid anterior surgery. That is what the thought is behind this technique. DCR. Okay, so he developed these joint indices, how to decide whether you can do it successfully or not. These are some of the new indices described from AIMS, and which help you in deciding whether DCR can be done successfully or you need to go, or sometimes you still need to go anterior. I won't take much time. All this is well published and you can refer. And these are some of the results of the posterior only technique. If you see this vertically, it seems to have brought it down. It has got it out of the foramen magnum. But the atlantoaxial dislocation, I'm still, this part is still there. But however, since you go and decompress from the back, there is enough space for the cord so that little amount of atlantoaxial dislocation doesn't matter. Then the PGI team from Chandigarh developed this idea of reshaping the joint. Sometimes the joint is vertical. For example, here, if you see the picture here, the C1, C2 joint is almost vertical. So how are we going to approach it? And how is the spacer going to stay there? And how are the two screws going to be fixed? You can't do it because they'll be projecting inside the occiput. So then he said, well, okay, why can't we drill away some part of the bone and make the surface flat so that the screws can go in straight and the spacer can rest on a flat surface? So they called it a facetal drilling or a joint remodeling procedure. So to decrease this sagittal inclination, to make it more flat and have the spacer lodge comfortably and stay there, you have to take off all this bone, all these corners of the bone and make it flat so that the spacer can fit there nicely. So, and the goal of all this was to decrease the sagittal inclination. But the problem with these techniques are they are technically challenging. Joint remodeling, drilling, spacer, you have the vertebral artery there, you have the C2 root. And whenever you drill away the cortical bone, I am very scared what is going to happen, that your cage is going to sink into the cancellous bone because you have drilled away the thick cortical bone. So I feel really scared about, reshaping the joint. If you remove the cortical bone, it makes me really stop. Don't drill away cortical bone. It always helps in fusion. It is very important to provide stability. However, the results published are very good, and I suppose it does stay there. But the risk remains. And you need all kinds of neuromonitoring to manipulate these critical neurovascular structures over there. So MEP, SSEP monitoring becomes important. These are the difficulties. Anterior joint manipulation, we have already discussed. There are many publications, including Dr. Patkar from Pune, who have said, well, there is no need. If posterior is so difficult, why go posterior? Just do it anteriorly. It is so simple. But I have seen some, the GB Pant team used to do that, and I have seen some complications where the anterior pharyngeal wall gives way, and you can actually see when the patient opens his mouth, you can see the plate. I've seen that. So it's not easy. Getting the mucosal flap or the muscle flap over these anteriorly is not easy. Then a side technique was developed where you go from the submandibular region, approach the joint, but then to get both joints from one side is again difficult. So it's not that these techniques don't have problems. Every technique has some problem or the other. So you saw how this things or the philosophy developed over the years. So what is the crux of the current strategies? You have to correct the facetal malalignment. You have to get the facets aligned properly. You need an arthrodesis with a stable bony fusion, and to keep the bony fusion intact till it fuses solid, you need some kind of a fixation. And the success depends upon the adequate reduction and decompression of neural structures, and of course your fixation techniques. If your screw becomes loose before the bone fuses, then it's going to fall apart. So the technique becomes important if you want to achieve all these goals and have a good, solid, stable CV junction surgery. What is the future? Well, people are trying to develop a universal CVJ reduction device. You know, you just fit it on the occiput, you put it on the cervical spine, and then it gives you 360-degree movement possible. You move this lever, you bring the head back. You move that lever, you push the C1 in front. You move this, the C2 comes up, etc., etc. So the research work is going on. They are trying to develop this universal CVJ reduction device. I hope we are around by the time this comes into, from the bench, it comes to the clinic. But let us see. Let us see. Another thing which has happened, especially with the lumbar spine, is facet joint replacement. You know, they are already talking about it. And there are a couple of companies which are marketing this. Basically, it means 2 pedicle screws in each pedicle of the lumbar vertebra. But you see the joint in the middle, this joint, it gives you that movement which is possible in the lumbar spine. Some amount of flexion, extension, some amount of side bending, and some amount of distraction. All that can be achieved with this joint. So in effect, you have taken the load off the lateral facet joints and brought them to the midline. And this works as good as a facet joint. But unfortunately, there's not enough space to do all this in the C1, C2 area. So I'm looking forward. There must be some research going on to develop a facet joint replacement even for the upper cervical spine, so that we avoid fusion and complete reduction in the mobility, maintain the mobility, and still have a stable joint. That is the aim which the researchers are now focusing to develop something like this for the cervical spinal. That's the goal, I think, where the spinal surgeons today are thinking and working. Thank you very much for this opportunity. I am grateful. I hope you enjoyed listening to this short overview of how the approaches to CV junctions have changed over the last 3 decades. Thank you. Thank you once again.
Thank you, sir, for your excellent talk. First of all, I'd like to thank and congratulate Professor Sultania for supporting this Nepalese Society with the oration that bears his name. Secondly, I would like to also congratulate Professor Kale for being the first orator of Professor Sultania oration. And I'm sure both professors must be very happy, because doing something for friend or friendship is, very satisfying. Like dost and dosti ke liye, because, since you've been knowing each other for so many years. And I would like to also thank Professor Kale for his excellent talk, akin to his title, Back to the Future. Yes, you have taken us from the, for the past, shown us the methodology, the science, the philosophy, and the technology, and how it has evolved over the years of spine surgery for CV junction. And lastly, I'd like to say that since you're not here, sir, we would like to, we'll give the certificate of appreciation maybe at our NSI meeting maybe later this year. So thank you once again. And since the oration, I think we'll like to stop here. Thank you very much, everybody.
Very much thankful to the nation for accepting this oration, and also thankful to the Kale for being the first orator. Thank you, everybody.
Thank you, sir, for the wonderful talk. Ladies and gentlemen, we have tea sub outside. May I request the respected delegates to go get their refreshments and join us for the upcoming sessions. I'd like to take this opportunity that we now begin our parallel breakout sessions here and in neighboring hall. I request the respected delegates to kindly proceed to the respective halls, and Beginning with the first session of the day on research, education, current concepts, and social networking, I'd like to call upon Dr. Amit Thapa here and Dr. Amol Rahiza, Assistant Professor of Neurosurgery, AIMS, to kindly moderate this session.
Thank you. Well, I would like to open up this new session on research, education, current concept, and social networking. As has already been told by our MCs that we are running behind time. So I will request all the audience to please grab a cup of coffee and come inside again. Meanwhile, since our online guests are already waiting for their presentation, I would like to little bit change the order of presentation. Do we have Dr. Joshi George online? Yeah, so we can actually request him to present his talk. So Dr. Joshi would be talking on wrong side spine surgery. Are you prepared? Dr. Joshi, good morning from Nepal.
Thank you very much, Amit. I hope you can see my presentation.
Yeah, you are both seen and audible. Please go ahead.
Great. Okay. So first of all, good morning. And it's an honor to be invited for this. So thank you very much, Amit. So my talk today is on our battles with wrong side spine surgery in my unit and what we are now doing to kind of prepare for this eventuality. So I have a disclosure to make. I've been involved in the development of a spinal marker, but I want to stress I have no financial interests whatsoever in the company selling this. I am going to briefly be mentioning this marker. So we know that surgery is definitely not a sprint, but in general, wherever you go in life, you want to try and acquire things which give you an advantage or help you get there. And you want to try and get rid of the things which are holding you back. So these are the concepts that I would like to explore today. So how big is the problem of wrong side spine surgery? So we know that up to half of the American spine surgeons admit to having performed wrong side surgery. And some say they've had at least 3 instances that they recognize. And it's happened to trainees as well as consultants who are very senior. In fact, we had a consultant who was just 3 weeks away from retirement, and then he had his first wrong side surgery. So my interest in this started when I was tasked with investigating these wrong side events. And my unit in Manchester is a very large unit. We have 35 spine surgeons and about 60 to 70 trainees. And we were having 1 wrong side spine surgery every 6 months. So we tried to get all our senior surgeons together and ask them their views on this. And obviously every surgeon feels that what his or her method is the right way. And we try to incorporate all of these views into our correct side spine policy. And there was a time that our correct side spine policy manual was almost like a spine surgery technique manual. It was several pages long. But we found that this did not actually reduce the incidence of the problem. And another problem we noticed is that our surgeons started disengaging from the whole process. As soon as you start adding more steps, which didn't make sense to some of the surgeons, then they stopped doing it. And then we ended up in a more dangerous situation than before, because whenever then you had a wrong side event, you would check and investigate, and you would find that the surgeon has actually not followed the manual. And one of the other problems we noticed is that every wrong side event seemed to have a different sentinel cost. So there didn't seem to be a common theme. And these are some of the reasons or the sentinel costs found in some of the wrong side events we had, and they are all well described in literature, including lack of training, different errors in marking the theater list, anatomical abnormalities, poor quality image intensifier pictures, etc. And to make matters worse, we had a few cases where the surgeon did not seem to have done anything wrong itself. So this is a case which was listed as a straightforward ACDF. And the surgeon had this intraoperative image intensifier picture taken, which seemed a bit confusing. And he actually sought the opinion of 3 colleagues, including a radiologist. And they all agreed on one particular level. And the surgeon still ended up having the wrong level operated on. So then we started changing our approach. We thought, if we can't eliminate this problem, can we reduce it? And this, I have to say, was the breakthrough, which is we stopped focusing on eliminating the problem and simply started thinking, can we reduce it? Because the first thing we need to know to reduce a problem is to start thinking, okay, what are the most common reasons for wrong side spine surgery? And the second thing we want to know is, what are the most impactful steps? So there may be 100 different things we can do to reduce wrong side spine surgery, but let's just try and see which are the most impactful steps just to reduce it rather than eliminate it. So we looked at the literature and we found that actually the literature was quite barren in giving us information about what were the most common reasons. So we decided to do our own studies, and we did 3 separate studies. First of all, we asked our regulator, the government health regulator, NHS England, to give us the information they had about the wrong side surgeries which were sent to it. Wrong side surgery at one point was considered a never event, and hence if a hospital had an event, they were obliged to send the investigation file to the government regulator. And so we started analyzing that. We subsequently sent a survey to all our surgeons in Britain, and this included the trainees as well. And this had a series of 20 questions about what actually went wrong and how many incidents they had. And then we also did a thorough review of the wrong side spine surgeries in our own unit. So I won't mention all of the findings, but the key findings were that about half of the British spine surgeons also admitted to wrong side surgery, similar to what the American studies showed. And one interesting thing we found from all the 3 studies we had was that the L4-5 level was affected in 40 to 50% of cases. So this is something which had never been published before. And we found this very strange. As you know, the L4-5 level and the L5-S1 level are the most commonly operated spine levels. And in fact, the L5-S1 level is slightly more common than the L4-5 level when you look at the big trials of spine operations. And we were trying to understand what are the reasons for this. But if you think about it, the L5-S1 level has a few other visual cues, for example, which make it a bit easier to identify. So for example, the sacrum looks different. It has a definite feel, even if you are kind of tapping it. And, you know, the L5 lamina is slightly shorter and slightly more upturned. So these might be some reasons why the L5-S1 level is less implicated in wrong level surgery. And then we found the next most common problem was segmentation anomalies, or this thing called the laminar trap, which I will kind of go through in detail in a couple of minutes. And then we also obviously found that there were errors in counting levels. We found issues in surgeon training. And also important is that we realized the role of distractions and this thing called confirmation bias, which again, I will cover in a minute or so. And poor preparation seemed to be a common theme. So our goal then became to reduce the wrong side spine surgery events, and we set ourselves a target of reducing the incidence by half. So we had learned a lot of things by doing these studies, and we thought, well, there's no point in just putting this in a policy document. Let's conduct a workshop every 6 months so that we can talk about the things that we have learned, and we can also discuss near misses as well as new events. And we started inviting not just the surgeons and the trainees, but also the radiographers, the anesthetists, and the nurses. And we tried to simplify our policy and just put the most impactful steps that we had learned as a result of our studies. And one of the things in that policy is that for every spine operation, we generally have at least a minimum of 2 x-rays, one before skin incision and one before any bony work is done. So I'll just talk briefly about a few of the things that we focus on in terms of training. So first and foremost is segmentation anomalies. So this is a patient who was listed for what was thought to be an L4-5 disc prolapse. You can see a small disc bulge here, but in the intraoperative X-ray, you can see that the lowermost disc is actually not well visualized. So the surgeon was aiming at the level above and subsequently ended up operating at the wrong level. So in our workshop, we train our surgeons to kind of identify this problem in the clinic itself. We feel the preparation should start as soon as you see that MRI scan. You need to mention that in your clinic letter. You need to start thinking this is going to be a slightly more tricky level to check during the operation. And you can start taking preparations for it. So we list this in the operating list. So we will say there is a segmentation anomaly. It just focuses everyone's minds. And we've also found that doing a preoperative X-ray, a simple plain X-ray, actually enables us to understand how much difficulty we're going to have in theater. The second thing is how do we get around the problem of this laminar trap? So the laminar trap refers to this phenomenon whereby the second X-ray is done correctly and you have something pointing at the right disc, if it's a disc operation you are planning, but somehow the surgeon ends up going to the lamina above. And we realized that actually, though many surgeons do this second X-ray, there is no guidance as to how exactly should you do this X-ray. So many people would do it in very different ways. Some people would do it with the retractor in situ. So in this particular case, you can see that though the pointer is slightly above where one might put it in an ideal situation, the retractor is actually in the right place, but the surgeon for some reason has managed to operate at the level above. And what we realized the main problem was that many people would be pointing at the disc during the second X-ray, whereas what they should really be doing is point to the inferior lamina, point to the inferior edge of the lamina that they're planning to remove. So rather than aiming 2 steps in front, just aim to the next step, because if you get to the right lamina, then you're definitely going to get to the right disc. So a slight change in the way we're doing this second X-ray has actually helped us overcome this problem. So our current preferred way of doing this second X-ray is to put the retractors in and put a marker just tucked under the lamina that you're planning to remove. And after doing this, we've not had this laminar trap problem. Then when it comes to kind of thoracic cases, we're extra vigilant. As you know, some cases have extra ribs. So for example, this is a patient who has a cervical rib. So we spend some time training our surgeons to identify these rare events. And so whenever we're doing thoracic cases, we do a simple plain X-ray, a whole spine X-ray, to make sure that the patient has the correct number of ribs that one would expect. This is an interesting patient who actually has 1 vertebrae less than normal. And if you count from the top and if you count from the bottom, you actually get to the wrong level. So we found that there was no custom-made marker for localizing the spine. And so we decided to make our own. And so we did this with the help of a Swedish company. So we now have a gold marker, which we deliver with the help of a spinal needle. And the marker is delivered as a thin filament as soon as it's deployed, and we generally place it just above the pedicle, just kind of abutting the pedicle of interest. It immediately, as soon as it comes out of the spinal needle, it curls up into a jumbled shape, and so it doesn't migrate. And it's a fairly cheap thing to do. And once you have this marker, you can visualize it on the image intensifier. So our radiologist does this marker implantation before the surgery in the angio suite when they have a very good view of the spine. The reason why we use gold is that it can be seen on X-ray, CT, and MRI scans. So for example, if you're doing a thoracic disc, you can put the marker and just perhaps do another MRI to make sure that the marker is in the right place. Now, I mentioned before that we actually invite other members of the team, like the anesthetists as well as the nurses. And the reason for doing this is that we found that in many of the wrong site events we've had, there's not just one sentinel reason, there's often a series of problems which had started. Sometimes, for example, the consent is taken by a different member of staff who's actually not operating. Maybe there are some problems in the theatre list. Maybe there's a difference of opinion in what level should be done. So we found that actually let's involve everybody else in theatre, because they can actually help guide us, and it's just somebody else to check the right level when we're doing this. And we've also started realizing that there is this phenomenon called confirmation bias, which is we don't really see things which are out there. We see things which we believe. And this is something we've realized is very important to kind of battle against. So you might be absolutely convinced you're operating at, say, the L3-4 level. But if you actually ask the anesthetist to check the level, he might say, well, I'm not convinced. Can you just double check that? And that just kind of focuses your mind to look at it again. And if you both cannot agree, then we seek the help of a different colleague. So I see the role of other members like passengers in a bus. So the primary responsibility for where you need to go is the responsibility of the driver, i.e. the surgeon. But the other members in the bus or in the theatre team can look out for danger and actually guide the surgeon if they're heading in the wrong direction. So we always ask for their help when we do the checking during surgery, when we double check the scans and the site and the level, particularly after doing the intraoperative X-ray. And we also ask the nurses to help us. So for example, if I'm doing a left L4-5 discectomy, the nurse knows to put the drill on the left side so that when I'm scrubbed and I come in to operate, I automatically go onto where the drill is placed. And if I'm going to the opposite side, then the nurse can kind of guide me in saying you're standing on the other side. So our goal was to reduce wrong side spine surgeries by half, but since starting these workshops, I'm pleased to report that we've not actually had any wrong side spine surgeries in the past 3 years. So we should have had 6 by now, going back by our previous past record, but we've had none. So in conclusion, I'd like to say that if your unit is one where you've been having this problem, then I think by focusing on just 3 or 4 steps, you can reduce your wrong side surgeries. And the key is to focus on the most common level that you're doing, and which is notorious to have this particular problem, which is the L4-5 level. So focus on that, and focus on training to overcome the problems with segmentation anomaly, laminar trap. If you're having difficulty in counting levels, then try and get this marker. And that's my presentation concluded. Thank you. Happy to take some questions.
Thank you, Dr. Joshi. Well, that was a very good topic to be presented. In fact, our audience who are listening to your talk are full of young neurosurgeons, and the problems do occur. Well, we do understand that whenever such mistakes occur, it is just not one person who has failed, it's a system which has failed. Because system has to have an inbuilt check-in so that we can actually check all those levels. And in the spine, definitely, when we are doing decompressive surgeries, the chances of errors are far more than the instrumentations, because in instrumentations, you are doing in and out X-rays. So in Nepal, most of the institutions do follow the WHO checklist so as to mark the level and to again verify it amongst the team members who are scrubbed. And also in our center, we are using this labeling technique, as you have just mentioned, and all the levels are again reiterated and reconfirmed. And then one point which you have highlighted very well is the orientation of the X-rays. So if you have not parallelized or not made the end plates parallel, any shoot which you take can actually lead to a wrong level.
So that's why the upper end plate and the lower end plate of any point of focus which we are operating upon have to be parallel so that the orientation problem is not there. So the floor is open to questions. If we have any question to this presentation, Dr. Joshi is there with us. Dr. Neelam, yeah. Can somebody provide Dr. Neelam with a mic? Thank you.
Congratulations and thank you, Dr. Joshi George. It was very relevant topic to present. Personally, I agree with Professor Amit that we have started WHO checklist, which is a standard checklist. It applies for all surgeries, not only for spine surgeries, but it is more relevant to spine surgery as well. But we have to focus on what to, identify what to focus on. So personally, what I do is before going to theater, I always check with the radiologists. I discuss with them, the level and everything, whether it's stable or unstable, and then level everything, and the facet joints, everything. And even if I'm not convinced till then I will do dynamic fluoroscopic X-rays in the OT table, controlled one, and then convince myself which level to do surgery. Thank you.
Yeah, that's an excellent way of doing it. Great.
Well, with this, I would like to thank Dr. Joshi for his presence with us, and we would definitely like to have you here physically anytime in future. Dr. Joshi, well to the crowd, he is the SBNS lead on the spine, and he is very much interested in proliferating spine education all over the world. So with these words, I would like to thank Joshi and will like to part with you. Thank you once again.
Thank you, Amit, for inviting me.
Next, I would like to request the AV to put on Dr. Vipul Gupta's presentation. Dr. Vipul Gupta is from India, Delhi, and he is there online with us. He has sent us a recorded video. Since we are running behind time, we don't want our online speakers to be waiting for their turn. So maybe have Dr. Vipul Gupta's talk on the slide, please. He's going to talk on recent advances in neurointerventional approaches to aneurysm. We check on the audio. This is a recorded video. Dr. Vipul, by the way, is on the line. So if we can request him to present, if your audio is not playing, then we can. This recorded video did have an audio, so I think there's some problem in the system. You're not able to transmit the video audio. EV team, can you fix the problem right now or should we move to the next talk?
I would like to invite my co-chair, Dr. Amit Thapa, for delivering his talk on the Neurosurgical Skills Lab, a necessity for training programs.
Well, good afternoon, ladies and gentlemen. This topic is very dear to my heart with 7 surgical centers offering training programs to 10 neurosurgeons every year. We see there's a lot of improvement in way the course is delivered to the people. But then during my experience as a resident as well as a young surgeon, I have learned through my experiences that getting a surgical dexterity is by practice. And this practice comes only when you're working on a skills lab rather than directly working on a patient. And this is what I'm going to talk about in the next few slides. It's a necessity for the programs. So I have nothing commercial related to this presentation. I will be using some of the products just for the demonstration purpose, but then we do not endorse anyone over the other. So yesterday we had a workshop on the cadavers in Manipur Hospital on endoscopic skull-based procedures, and I thank the organizing team as well as the local host for organizing such a beautiful cadaver workshop. Well, microneurosurgery is all known to us. That is a mainstay for basically all neurosurgical procedures. What we also need to understand that as we are going into exoscopic surgeries, endoscopic based surgeries, microsurgery is here to stay. We are going to use all these methods into this particular new modalities. And that's why microneurosurgery is something we need to understand and adapt as soon as possible. Now, why there's a demand for technical skills in microneurosurgery? Why? Because we are working through a narrow operative corridors. We need to have a hand-eye coordination, precise manipulation techniques with detailed microanatomical knowledge, depth perception, sensory feedback, joint positions, and these all actually are reflexes which are developed as we start working with these techniques more often. And also complex ergonomics are involved. So that's why we have to know our sitting position, how we sit, how we keep our back straight, how we move our eyes, and also to control our physiological tremors. So all these things, they demand skills training. Now, there have been many reports recently where they have found that the dry lab training prior to training in the OR reduces the patient's morbidity and mortality in almost all endoscopic surgical disciplines, not only speak of neurosurgery, but also gynae, surgeons, GI surgery. And as such, the skill testing infrastructure should aim for multidisciplinary usage. So a task-specific simulator has been shown to yield better results on a specific suturing task in laparoscopic anastomosis than just training in a basic suturing task. So that's why these types of simulations are very important. And in the specialty of gynecology, even the 6 different associations, they have actually endorsed the need of hospital-based teaching on endoscopic surgery in labs before the trainee actually goes on to operate on a patient. We all know this is basically the thing which we all adapt in our surgical career of learning. We read books, we go for surgical books, we go for lab training, and then we go for the clinical orientation in ORs. We'll see for the operative videos are nowadays available YouTubes. But what is missing is definitely the skills lab component in most of the surgical programs. So we practice with our mentors, seniors, we read, see, assess, and practice. But because of the limited time, limited exposures, limited variations, not many cases are the same which we are being actually practicing upon. Now, it has been also published that more laboratory simulations actually leads to fewer brain complications. And this is also very important because such types of skills lab training actually motivates and engages the students in the programs, and this also increases their interest in learning. In the present era of restricted training period, when the training period is actually getting limited because of the current work hour restrictions, the students are actually getting lesser exposed to these surgical skills, and this can be actually supplemented by much more of a dry lab trainings. Dr. Sontag actually talked about that we, the surgeons, the surgical tutors, they could assess the surgeon's judgment and the decision-making capacity as we interact with them, but how to access their technical and psychomotor skills? When we are looking at them as they assist in our surgeries, it's actually require much more of supervised monitoring. We have to be extremely subjective, as well as it's very time consuming for both observing and expert surgeons to see how their young generations are doing. So to help us, there are many surgical skills rating tools which has come up recently, not in neurosurgery, but in other specialties like Global Rating Index for technical skills, structured assessment of microsurgical skills, multiple objective measures of surgery, and even sensor-based assessment as to how you move your fingers, your wrist. So these are also being actually monitored by various sensor-based assessment protocols. And then most of these protocols which they actually use an expert novice design concept to validate the tool. So that is to say how a novice is going to become an expert. They actually see a graduated improvement in their skills. So these are 4 different things one looks for it: phase, content, construct, and the concurrent validity. But in phase and content, they actually want to evaluate whether the technology is realistic and it targets the training skills that is to be trained. Construct actually scores which correlates with the actual operative technical skill by discriminating expert from novices. And the validity is by actually looking at these training, whether it reflects the performance in the operating room. Now, there are many of these tools which are used in other surgical specialties, not in neurosurgery. And in neurosurgery, there is a new tool which has been now come up as global assessment of intraoperative neurosurgical skills. This is a skill been validated in various centers, but then no such research paper has been published on this. So they are trying to make it a for. Now, there may be some contention that why the young neurosurgeon should do it. It's only for the residents. Well, there has been a paper which has shown that as after we get trained as a resident and we go into our practice, we actually give away this method of dry lab training. And that's why our dexterity actually decreases down. We are limited to only a short duration inside the theater where we do the skillful job, but where we have actually condemned the boredom of doing the repeated things times and often. Well, in fact, I just want to share my talk with one of the Olympic coach. And I was asking how this Olympic player becomes so great. So he shared to me the secret, which I think we should be shared to all of you. The expertise is not in doing the same thing times and again. The expertise is to overcome the boredom of practicing times and again. Because as an expert neurosurgeon, what happens is that we think that we are so much expert that we do not need too much of training hands-on. In fact, that is not true. So subsequent study had actually proven that the expert, when they perform, they actually do the same thing times and again. They try to come over the boredom of practicing times and again. And they do deliberately certain things very differently in the next step so that they can actually improve on their expert performance. If you do not do this, your development is arrested and sometimes it may even go down. So this psychomotor training needs a lot of hands-on training. Now, skills lab can be dry lab, can be wet lab, and even can be hybrid. When we say wet lab, it uses human or animal tissues into it, and the dry lab are much more of a simulators. And hybrid is basically a combination of both dry lab and cadaveric labs. So in Nepal, there is no organized surgical skill lab, even though there are a few centers which have developed few of these stations on the microscope. But then we definitely required that there has to be a dry lab and a wet lab, which is necessary for training our students as well as the surgeons who are working in the department. And we thought that this is very much important for the safety of our patient before the students and the young surgeons land onto the patients. And we also realized that the benefit of the skill lab is just not limited to the students or the trainees, but is also important for the surgical programs because it helps us to evaluate the progress of their learning. It also is good for the hospital because it decreases the chances of error on the patients. For the country, definitely, because a lot of trainees are actually going abroad for these types of exposure in absence of these types of training centers in our place. And also for the neurosurgical community, because we can come up with much more of a validated tools to evaluate and train our students. Well, there are definitely some certain limitations to start these types of program. Definitely, most of the courses may not feel a need because the students are directly going and assisting in the cases. So that may think that is a hassle to start this program. And then there may be a thought that the cost of establishing this dry lab may be very much higher. Well, this was a latest publication by Dr. Suri et al. In Neurology India, where they have estimated that almost 1 crore Indian rupees is required to establish a dry lab. And then, of course, there's a variation in protocols and what we want to do, ask our students to do. Well, we are blessed that we could start the first neurosurgical dedicated lab in Kathmandu Medical College. And this was with the help of University Grant Commission, who actually gave us some grant to start, the seed money to start with. And then what we actually went on to cover in this skills lab was to cover at least all the modalities which a modern neurosurgeon uses in his or her practice, and also to describe how each modality works, learn to use them on a models, and also follow the learning cascade which we have just discussed. So it starts with a didactic lecture on each tool, and then we go on for simulations with hands-on, on gloves and animal models. So basically the orientation starts with knowing your gears. So we have craniotomy instruments, spine instruments, microscopic instruments, and endoscopic instruments displayed and told as to what are the finicity of holding an instrument and what are how you choose the length and the diameters. Then we also talk about the navigation, the INM systems, the intraoperative ultrasound or sonoscopy, which we are very much using in almost many cases inside the theater, and also handling the microscope. Well, it is very strange that once the microscope bulbs goes off, most of the neurosurgeons don't know how to change the bulb. Why? Because we have only been taught how to switch on the microscope, you use the zoom and magnification, but we are not learning how to use the intricate parts of it. So at least we should be aware of how to use all those things. And also to handle the endoscope and the exoscopic system and the C-arm. So we start the hands-on training with the loop, because that is the most easy one to be used by any trainee as well as the young surgeons. And we have a list of the procedures laid down as to what they are supposed to do. And the same thing is being carried out by the microscope. In the microscope system, we actually ask the trainees to first of all have a feel of their hand movements under the magnified image. And then they start marking it onto a gauze as well as on a grape, and then the same mark has to be peeled off. So this actually helps you to gain your dexterity or in handling the micro instruments under the microscope. And then we go to the next step, that is the suturing. So suturings are done on basically the gloves, which is cut and then placed in different orientations. So we go from a simple orientation, a simple one, and then we go to a little bit of much more graduated difficult, that is at 10 or 2 o'clock positions, where the suturings are difficult. And all those things which they are doing under the microscope is recorded, so that they can come back to their what all procedures they have performed and to refine their process. And then at the end of it, they go for the vessel harvest from the chicken wings, and the same can be sutured by end-on as well as end-to-site methods. And then after they have graduated from endoscope, they go on to an exoscopic system. Now, exoscopic system, even though it is perceived to be very simple, it is very difficult in the other sense. Why? Because there is no stereoscopic image, orientation. It is all a 2D image. So one has to keep moving his instruments, keep touching his instruments to have a feel of the depth. So that's how a person does it in the exoscopic system. And we ask the person, the trainees, to do the same step multiple times. In the drill, well, this is a very standardized method of learning. So we have taper tool, med shed, acorn tool, ball tool, and foot attachments to do various dissections. And at the end, we even ask the trainees to shave the skin of the egg. And then they have marked many good images in our last training programs. And then also in the endoscopic system, we use the turtle to teach the students. Why? Because even though we are not using in laparoscopic in the neurosurgery, but endoscopy training under a turtle scenario actually helps them to understand a moving image. What has happened over the years are that we neurosurgeons are so much adept in using microscope that we are actually tuned to static images, whereas endoscopic images are moving images. And these moving images actually cause disorientation and sometimes even dizziness to a surgeon who is so much accustomed to operating on a microscope. So one has to train their eyes to work up on a moving image rather than a static image. And that can be only achieved when they are doing a forehand technique into a turtle. Similarly, we have module to train people on INM techniques as well as use ultrasound to identify the structures and to track it. And then we have a very strict housekeeping announcement discipline system to have the proper gear while they are practicing on the models. And then everybody is supposed to maintain a log as to how much duration they have spent on each of these stations. And then we recently conducted a workshop there, and where we have a pre-test and a post-test after this workshop. And we definitely found that in most of the modalities, the trainees had an excellent improvement in the post-test as compared to the pre-test. So we did find that even with the 3 days training program, we can actually improve upon a lot of things on the understanding of the gadgets. And then most of the participants said give the thumb up to these particular courses. So this was the first skill lab course, which was recently concluded. And we even gave them tips as to how they can adapt these types of dry skill lab training at their setup once they go back, so that they keep on training. This has to be there at an everyday basis, at least, so that they can keep the surgical dexterity on. And now we have introduced a regular 7 days courses. So these 7 days courses actually involves the same thing, which has been just concised into a 3-day program, and it is regularly available at Kathmandu Medical College. One has to apply, and it has a nominal fee for these courses. But then, even though I have presented all of these things, this is not at all a complete package, because most of the models still are far from almost real. We are looking forward to a day when the neurosurgeon will be practicing like an airline pilot. They have a simulator which actually resembles the whole cockpit of their own plane. But then we are still very far away from that. The high fidelity simulators which are now available in the market, they are very costly, and they are yet to be analyzed for their cost effectiveness. And there is a need for focused research to justify the costs of development and use of all these techniques. So learning how to carry out a surgical procedure after the core skill has been mastered has been found to be overwhelmingly a cognitive and not a technical task. So that's why the expert neurosurgeons or the surgeons who are the masters of the art, they do not need that much of things, because they've already developed the psychomotor skills to develop on it. So to conclude, hybrid skill lab is not only good for trainees, but also for the trained alike. It provides a progressive focused task-based training which enhances the psychomotor skills, decreasing the surgical errors and improving the patient outcome. It shortens the learning times to master the complex neurosurgical procedures, and a lifelong interest in maintaining and augmenting the surgical skills. So it helps not only the trainee, but also the training programs, as well as the society and the neurosurgical community. This is just a small snapshot of the WhatsApp, which I just, Facebook message, also known as Dozer Atank, which is going on in the country these days. And people have even found opportunity in that. So movers and packers are finding opportunity to shift your shop if in case they say a crane coming to your shop. So we have to take this opportunity. Now we have more centers than ever to train the neurosurgical residents in our place. So if in case we have dry labs in the other surgical training programs, it will be helpful to all of us. Thank you for patience listening, and I'm opening to questions.
Yeah, thank you, Dr. Amit, for an excellent talk. You and I have been privileged to have worked at a center where the skills training was really a part of our training curriculum. And that really makes a lot of difference to get the skills up to speed. Because in the current era where the litigations are on the rise and the patient expectations are sky high. So you need to really have the skills good enough before you operate the patient. So very well presented. Now the paper is open for discussion. Anyone with the comments, sir? Yeah, Dr. Neelam.
Congratulations and congratulations to all of us. I didn't know that you had started neurosurgical skill lab. My first of all, my question is dry lab. What is wet lab? It's animal.
So what uses an animal or a human tissue?
Pardon me? Yeah.
Which uses an animal or a human tissue for the work.
Yeah, when I was in China, in the neurosurgical skill lab, there for microvascular anastomosis, I killed 2 rats. I still repent that I killed the rats, because if I had done more dry lab before going to the mice, that would have been better. And in AIMS, for multiple times I have gone to the neurosurgical lab there, run by Professor Suri. And last time, I think 2 years ago, I trained there for 3 weeks, and I knew how unskilled I was. I found myself so unskilled, before starting that thing. And after that, after coming from there, still I couldn't get the rats, because I was still unskilled to get the rats. But in China, I straightforward got the rats. So dry labs are very, very necessary, and we should there should be a threshold before you can go to the rats, live animals. You must have this much of this level of skills to go to the animals.
Very well said, Dr. Nidam. In fact, this is what the protocol is being used. One is not provided with the animal immediately. At AIMS, when I was trained, I still remember Dr. Suri had a very strict log making, and then we have to complete certain hours of practice on inanimate objects before we get a live rat. And in the live guinea pig, even you have to salvage it. So we used to start with the nerves and then attack on the arteries at the last. And if your guinea pig dies in between, then you're not going to get any other one. So we have to preserve him, the rat, at all the cost. Dr. Mohan.
Yeah.
Dr. Amit, you really led the way, for the skill and both dry and wet lab. The way to go first is, of course, dry lab, then go to wet lab. And with that, non-technical skills should also be included in this curriculum, non-technical, which was copied from the aviation technology, this thing. They have actually done, lab which teach you how to control the intraoperative aneurysm rupture. So inject through artificial artery and create an aneurysm and run the blood, and it's a red liquid, and train them how to control the bleeding during intraoperative. Those kind of things is there. One important thing is it doesn't really copy your last slide. It's never, the moment you are practicing takes away the intense intraoperative pressure goes away, and then they of course have to go through the real world, but it will greatly decrease the complication rate, especially in the neurosurgical academic setting. You have to give the operative chance to the juniors, otherwise new shed won't develop. And before giving them directly to the patient, always nice to take them through this lab before letting them to operate directly on the patient. Thank you.
Thank you.
Thank you, sir, for your comments. Thank you, Dr. Amit. I think we can call the next speaker. There is a slight change in the schedule. And I would like to call Dr. Nirmal. And I would like to call Dr. Nirmal Ramishan for presenting his talk on only movers and shakers are not seizure. Okay, so.
Well, hello. With the speed technology and robots are taking over the medical practice, I'm afraid a day may come when doctors would be going to the engineering college and the vice versa. So I hope that day will not come. I think we should also think in those terms. Thanks to Dr. Amit, Balgopal, Sudan, and Praveen for providing me this opportunity. Just 1 hour late, don't worry. If everything happens in time, we may lose our identity as a Nepali. So, lage raho. What I'm going to present today is about rare cases of seizure. My plan of presentation will be, I'll talk about brief introduction, classification, then discuss about case series and some take-home message. I'll not go into this introductory part about prevalence, epidemiology and all. We all know the scenario, at least 1% prevalence in Nepal. We have huge burden of seizure disorders, always demanding quality management. Known since antiquity, not the whiskey though, known since antiquity, it has been named different things, it still carries the stigma. Despite that, we know that there were many learned people who were highly respected and had merit, had seizure disorder and had a successful career. So maybe this preaching about this will reduce some stigma from our patient. It is very common in medical practice while evaluating a case of fainting attack or for matter clouding of consciousness. We health workers, medical officers, and we doctors usually would say there is no uprolling of eyes, deviation of angle of mouth, frothing from the mouth, tongue bite, abnormal jerky movements of limbs, bladder and bowel incontinence. So seizure is ruled out. Have we ruled out the seizure? I think according to the International League Against Epilepsy definition, we have just ruled out generalized tonic-clonic seizures. So we as a teacher, I think we should stop confusing our student, giving them that statement. There are more variants of seizure in classification, which we tend to ignore as the above mindset, thought, or assessment. So in this presentation, we'll be discussing about case series of epilepsy without moves and shakes. I'll not go into the details of this international classification. There are many variants we know. Let's not only talk about movers and shakers on. So I'll be presenting 3 cases that we encountered in our clinic, 2 of diachronistic seizure and 1 of gelastic seizure. Diachronistic seizure are characterized by paroxysmal episodes of stereotyped crying. The majority of the reported seizures appear to be triggered in the hypothalamus and seem to be frequent in individuals with hypothalamic hamartoma. However, in rare cases, it may also occur beyond hypothalamic lesion. Such cases are reported here. Case 1, a 3-year female child was brought by her mother with complaint of crying, waking up from sleep at night without any apparent reason for past 2.5 months. The inappropriate crying lasted for 15 to 30 minutes and occurred most of the days with gap of 1 to 2 days a week without any associated symptoms, and the child did not recall any of the episode. There are no significant past history and family history in the patient. The patient came to us after visiting many centers. By that, I mean the traditional healers. Unfortunately, they didn't find an exorcist in Nepal, so they couldn't do that. That was a joke. Nobody seems to get it. On physical examination, vitals were stable. Her respiratory and cardiovascular examination showed no abnormalities, and neurological examination revealed normal sensory, motor, and cerebellar function and intact cranial nerves. EEG was advised, which showed high voltage generalized slowing to theta and dental range with sub-wave activity, followed by MRI brain, which showed normal. We started anti-epileptic and patient started responding. And currently she is continuing on the same treatment, and the mother is very happy. She has stopped searching the exorcist. Another case is a 6-year-old male child brought by his father and mother with complaint of crying, waking up from sleep at night without any apparent reason for past 1.5 months. Oh man, this is I think it's repeating here. This is so this case was also started on anti-epileptic, and then the dose in the first follow-up, the frequency decreased. Then we increased the dose. After 1 month, it subsided. Case 3 is about gelastic seizure. We know gelastic seizure are almost always the first seizure manifestation of hypothalamic hamartoma. However, in rare cases, it may also occur beyond hypothalamic lesion, which was our case. A 12-year-old male child was brought by his mother with complaint of laughing without any apparent reason for past 6 years. The child would laugh incessantly to the point that he would become cyanosed. The inappropriate laugh lasted for a few seconds and occurred 3 to 4 times a day without any associated symptoms, and child had no recollection. There was no other significant past history. Positive history of tonic-clonic seizure in grandfather was there. I don't know how much that makes it significant. Vitals were stable. His respiratory and cardiovascular examination showed no abnormalities. Other functions were also normal. EEG was advised. Oh no, it's going back. Okay. Sure. Can somebody help me? It's just moving forward. Can I go back? Yeah, one more. Sir. Thank you. Okay, so gelastic seizures are hallmark of manifestation of, again, hypothalamic hamartoma with onset usually in early infancy and are produced by hypothalamic hamartoma itself. In this case, the mother did not realize that it could be a problem earlier. So late presentation is because of the ignorance. Now I can change. By pasari janna dui step agari gayo. Sorry. And then this case responded to anti-epileptic medicine that we started. And in gelastic seizure, usually it is resistant to anti-epileptic drugs. So this gelastic seizure being outside of hamartoma also is signified by the response to the anti-epileptic drug in this case. Okay, so what I'm trying to tell as a take-home message is, nowadays with development of technology and everything, I think we are losing the art of history taking. What Dani has said here is, if you do not take history, you won't be able to solve the mystery, and all your medical knowledge will go in the ashtray. Another take-home message would be, eye doesn't see, ear doesn't hear, nose doesn't smell, tongue doesn't taste, and skin doesn't feel what brain doesn't know. So as a doctor, I think we should be open to all this perceptual mechanism, not merely depending on technology. And what medical science has become really pains me. Medical science is as much or more of an art than it is a science. In current practice, it is becoming more of a science than art. So maybe we need to revisit. I like B.M. Hegde's saying, you practice allopathy, homeopathy, naturopathy, or whatever pathy. If you do not practice empathy and sympathy, you will reach nowhere in treating patient. This is for us all. What other specialty deal in macromillimeters, neuroscience deal in micromillimeters. So we all are the goldsmith and others are blacksmith of medicine. These are my references. Thank you very much.
Thank you, Dr. Nirmal, for letting us feel great. I believe there may be many questions, but since we are running short of time, I will request all the audience whoso has questions to discuss with him in the lunchtime.
If there is no question, I have one question for this August gathering.
Yeah, please.
Will somebody tell me when it is right time to stop anti-epileptic drugs? To the dot, not the philosophy.
Well, that can be answered, but then I will like to again post these questions after in the lunchtime because there are certain online speakers, they are waiting for their turn. So thank you, Dr. Nirmal. And with this, we will little bit change the order again, since we have Dr. Vipul Gupta from Delhi live with us. His recorded presentation had developed some snacks. So we are requesting Dr. Vipul to speak the presentations live. Please put on Dr. Vipul Gupta.
So I can do share screen now.
Yes, sir. Please share the screen.
I hope you can see my slides now.
Yeah, it's all visible and you're audible too. Please.
So, my talk is on, so it's a pleasure to be here and I would have loved to be there and missing all the friends, but next year, surely I will come over. So I'm going to talk about the neurointerventional approaches to aneurysm, how they have evolved in recent times. So, before going out to the, newer technologies and techniques, I would still say that balloon reconstruction remains the mainstay. Particularly using the double lumen balloon, we are able to place in any anatomy. And that is my favorite technique for acute cases of subarachnoid hemorrhage. The challenge here is using the balloon doing complete reconstruction. Like this is one of these cases, anterior communicating artery aneurysm. There's a lobule pointing posteriorly as well. So we did balloon assisted coiling. You could see that this part remains slightly undercoiled, posterior superior. But what we could do was we could reshape the micro and enter that is a video showing entering that lobule, and then we'll pack it as well. So balloon gives us this flexibility and that we can re-enter, reshape, and this is the end result. It is pretty good occlusion, and this patient has remained stable on the follow-up. Even for very small aneurysms, at times I like balloon, like this patient with a very small, acutely ruptured distal AC aneurysm. It's on the pericallosal. One would say, let's place a flow diverter, but again, one can avoid if possible in acute stage. So this is balloon there. We microcatheter just at the neck of the aneurysm, and we were able to place a very small coil and sort of twist it into an 8. And you could see we could get a good occlusion while the artery remained patent, and this patient remained the same. So again, for all the flow diverters and stent, still balloon-assisted coiling remains one of the very important ways we can treat these aneurysms. Now, coming to major advances have come, of course, all of you must have heard multiple times about flow diverters. The flow diverters which reduce the flow within the aneurysm leads to fibrosis and thrombosis of the aneurysm. And the intima covers the stent while sparing the arteries arising. This is one of my first case, I think first or second case we had done at Medanta when we started the flow diverter program. Partially thrombosed giant IC aneurysm, partially coiled, flow diverter placed. There is immediate stasis, but you can see on the long term perfect reconstruction. Here you can see how the artery was kinked. We have been able to manipulate it to reconstruct it well. But where are the challenges where we are changing? It is ruptured aneurysm. It's a challenge, as I mentioned, using the antiplatelet drugs. So what we are doing nowadays is we are loading them just before the procedure, an hour before the procedure, and it works very well. We haven't had thrombotic complications and very few bleeding complications, if any. We use Pasugra or Ticagrelor, which have low chance of any resistance as loading. But the key thing is if you need any EVD or Omaya, that has to be done beforehand. And another challenge is when the vessels are in spasm or dysplastic, getting a proper wall or position is the key in flow diverter to avoid complication to be effective. And another change has been that most of these ruptured cases, we are using device which is known as pipeline shield, which is basically coated with synthetic phosphorylcholine, which makes it less thrombogenic. So in fact, there are already studies which have tried to use only single antiplatelet in acute stage and do it. We are using double, but we know if there is a problem, then it's easier to stop one of the drugs. So you can see this is a classical ICA blister aneurysm. We'll get the EVD done beforehand, load with Pasugrel, and this is the flow diverter vaso seat in place. You see, we'll compact it very well in the region of the neck of the aneurysm to get a good occlusion, and a follow-up is a very good outcome. So we have published in BJR about our outcomes, and we found that Pasugrel loading was very safe in these patients with much more better complete occlusion than our previous study using the stents. 90% complete occlusion, no need of repeat treatment, and no rebleeds in this patient as well. But I mentioned about remodeling the artery when there's a diseased parent vessel and you're using a device with a lot of metal in it. If you don't get a good wall of position, there'll be endoleak, aneurysm will fail, and also it will lead to thromboembolic complications. For example, this patient acutely ruptured, again a blister aneurysm, but you can see the IC is severely narrowed there. So what's the neck here? Is this the neck? Or to me, this is the neck. This is the artery which has gone into spasm. It is narrowed. So we have to model the flow diverter in a way. So we like to use flow diverters because higher radial strength, they're more difficult to manipulate, but the higher radial strength, some intra-arterial dilators, we have opened the artery completely and well compacted the flow diverter in the region of the aneurysm. And this is the follow-up, then the artery is remodeled. Another patient we did in the lockdown period, this patient had COVID pneumonia, was on ventilator, subarachnoid hemorrhage, EVD had to be done, and a dissecting vertebral artery aneurysm. So usually we'll do a PVO. if the other vertebral is fine. But here the arrow points, there's a big perforator coming from the base of the aneurysm. So we thought PVO could be dangerous, but here you can see the artery is very small, some narrowings are there. And again, we use a stiffer flow diverter here. You see when you place the device, the whole artery gets crumpled. It is very uncomfortable. But as soon as you place and take out the microcatheter, you can see it is completely remodeled. It's straightened, narrowings are gone, and immediately there's a stasis within the aneurysm. Here you can see a open flow diverter with stasis within the aneurysm. And this is what you want rather than just gently placing a device. And this is the follow-up. The aneurysm is completely gone, but you can see the perforator remain absolutely patent. And this is show the intima. You can see the white line intima is thickened, while perforator area intima didn't grow. Another challenge was how to take this stiff devices way beyond the circle of Willis into smaller arteries. So we are getting smaller flow diverters. Also, we are using distal access catheters like this patient with a fusiform anterior communicating artery aneurysm. Here you can see even the other AC has an aneurysm at the origin. So we decided to place one long flow diverter. And this is the device which we placed. We have well compacted it to expand it very well in that area. And this is the follow-up. The whole artery is remodeled. It is slightly dilated, but it doesn't matter because it's metal outside. So that let the dilatation be. But you can see the other artery, which was covered by the flow diverter, remained filling, but the aneurysm seems to have regressed a little bit, and the arteries remain patent. So using the newer flow diverters, which are softer devices and longer lengths, we are able to reconstruct distally. Particularly one device which has really changed it for distal flow diverter is Silk Vista Baby, which has come up to 3.25 millimeter in size, but can be delivered through a regular coiling microcatheter, 07 microcatheter. So this is a middle cerebral artery dissecting aneurysm. Some coil previously in another institution has grown again. Again, you can see crumpled artery, dissected artery. So this is the thin microcatheter, and these are very soft devices, easy to take very distally. And we placed it here. This is the vaso-CT, showed well open flow diverter and an immediate stasis within the aneurysm. And sometimes because these are so soft, we can use it in a very different manner. This patient had a acutely ruptured pica aneurysm here, old lady, but you can't occlude such a big pica. So how do you treat this blister aneurysm? If you are trying to take a flow diverter from here to here, it will be very challenging because of the angle. So we decided to come through the right vertebral, and through the basilar bifurcation came reverse and easy to enter the parent vessel and cross the aneurysm. So because these are such soft devices nowadays, meant for small arteries, we could do it in this manner. Previous devices would have been very challenging to do it like this. And this is the device plate. This is less than is around 1.4 millimeter artery, but a well open device. You can see on the vaso-CT and immediate stasis within the aneurysm. And this is the follow-up, complete reconstruction. This is another child which had to again take the contralateral route. This child had a bleeding with a giant ICA, which was treated by partial coiling in PVO, but the distal aneurysm started filling retrogradely from the ICA bifurcation and started to grow with time. Once started growing, we were worried, and the only way to treat was to go across the ACOM and place a flow diverter from MC to ACA. So this is what we did. We have gone through the left side, and this is a fenestrated ACOM. We have taken the flow diverter micro, another micro catheter for coiling, again, because of the smaller profile ones. And we have a very distal IC access for the stability of the everything. So some coils and a flow diverter, and we got a complete occlusion. And we have done now a 1.5 year follow-up in this child. The aneurysm has regressed and the result has remained stable. So while flow diverters are great for the sidewall aneurysms, the challenge has been in the bifurcation aneurysm. So one of the things is we use stent-assisted coiling in many different manners and intra-aneurysmal devices. So I don't like to use two stents. There's too much of metal in a small vessel. So how do we use a single stent to preserve two arteries? So we have two techniques there. One is shelving technique, one is stent and balloon technique. Like this patient with a very broad neck ACOM aneurysm. So if you place a stent in a regular manner, it will come like this, and this part of the neck is not preserved. While in shelving technique, we push the stent, hyper expand it, and then it covers most of the neck, like regular stent placement, and this is the shelving. And this is how we treated this aneurysm. Another technique is that we can use hybrid technique, that we use stent on one side in artery and the balloon on the other branch. For like this patient with a middle cerebral artery, very fusiformal aneurysm. So we have taken one micro, which has got a stent in it. This is the balloon micro, and third is the coiling micro for coil placement. And this is what we are doing. Stent is partially deployed braided stent. That means in the end, our plan is to withdraw the balloon and then only deploy it completely. But at the time of the procedure, balloon is saving this part of the neck so we can do tight coiling. And this is what we call as hybrid technique. So after the tight coiling, then we deploy the stent and expand it a lot. And this patient also this is the end result. And this patient has a good outcome and a follow-up. Another challenge is getting good packing when you're using stents. So what we use is sometimes we use even 2 microcatheters. To me, coiling is just not placing coils with a balloon and stent. You have to get a great packing, which is not so simple at times. At times, you have to reposition the micro as well. This patient had a middle cerebral artery bifurcation aneurysm, very broad-based, 2 lobules pointing superiorly and inferiorly. In such a flat aneurysm, you place a micro, it is very difficult to pack the aneurysm from top to bottom. And then there's always a chance of it coming back. This is the end hole view, down the barrel view of the bifurcations. You can see the aneurysm is encircling. So we decided to use 2 microcatheters. So 1 microcatheter here is for stent, but 2 microcatheters, one we could direct in the upper lobule and the other into the lower lobule. And then we started to do coiling. You can see with 1 micro, we could pack the lower part densely. With the other part, you can see the micro is a reverse shape, upper part densely, and ultimately get a good packing in. And you can see in this CT scan image how the bifurcation, we have done encircling coiling. To me, that is another important point. More and more, we are realizing some coiling, and then after 5 years, you see there is a recurrence. So at the first stage itself, particularly in subcontinent where finances are a big issue, doing a repeat procedure is a big challenge. Getting adequate coiling, microcatheter shaping, repositioning, or 2 microcatheters. Really recently, we have seen that we can get good packing. What about stent as flow diverters? This patient had ruptured middle cerebral artery dissecting aneurysm. It was a very long segment for a flow diverter, so we placed overlapping pink stents, which can work like a flow diverter. This is the first one. Then the second one, overlapping stent being placed. After that, we coiled it partially and deployed the third stent. And this is the 2-year follow-up where the artery remains absolutely fine. And so sometimes very distally, one can use even a stent like a flow diverter in a very small vessel. Another such patient, she had a middle cerebral artery distal dissecting aneurysm here. In the past, we would think about taking a device there, but in the acute, we wanted to occlude the artery, but this was motor cortex artery with no collateral. So in the acute stage, we coiled it. You can see the kinked disease artery, but all these cases will come back. So this aneurysm grew with time. We coiled it more, and then into that very small vessel, we placed the stent. So how can you do that? Distal access. This guiding catheter is in the M2 MCA, is beyond the bifurcation, is already into one of the MCA division. And then only one can get enough control and force to open the stent as well in that area. Without this kind of distal access, one cannot do it. And this is again the 2-year follow-up, shows how the artery is remodeled. You can see it's become straightened, but it's well open, and the aneurysm is completely gone. But the newest change which has come in the bifurcation aneurysm is intrasaccular device. These are like flow diverters within the aneurysm. So one of the most researched one, widely used world over, is Webb device, which is like a ball of fine meshwork, which you can develop through a microcatheter and then detach it. So these were the first 2 cases we did. Large basilar top ruptured. Would have been a very long procedure otherwise. We took a microcatheter. This is the Webb being delivered. Once you deliver it, we check that is well placed, artery is preserved, and then we detached, immediate stasis, and you can see complete occlusion. And this was a 20 minutes procedure. So the biggest thing with these devices is that they are very fast, and we need not use any long-term interpolated agent. Another one which is becoming very popular is a contour device. Rather than a ball, is more like a cup which you place at the neck of the aneurysm. Like this patient, middle cerebral artery, very broad neck, would have used 1 stent, 2 stents, balloon, long procedure. But here, what we have done, you can see the very broad middle cerebral artery aneurysm. This is the vaso-CT. So once we have placed this is the microcatheter tip, the device here, if this is an intraarterial injection, a very high resolution, 0.1 millimeter resolution vaso-CT, which we rotate in various views to show that it is well fitting. And in the other view, it is touching all the walls, and then we detached it. Immediately, you can see the aneurysm is filling, but we have just done a follow-up. And you can see it's completely gone here. Some bulges remain here, which is fine for such a dysplastic aneurysm. And again, as I said, no long-term interpolated issue in this patient. Another patient treated by contour device, very broad neck, ACOM. Again, the whole ACOM area is dysplastic in this patient. In this view, this is again the contour device, which has been taken and deployed. After deployment, we'll do vaso-CT to see how the device is like. And just to give you a 1 second, you can see we can do a 3D reconstruction of this vessel CT, and we rotate it in various planes. Look at that the parent vessel is really preserved before detaching. So this view gives us a lot of comfort that the both A1, A2's junctions are preserved, and then we know we are at the right place to detach the device. This is immediately after detachment, some stasis, but this is the short-term follow-up. Already most of the aneurysm is gone, and we hope for a further progressive thrombosis. The last bit, which is really changed in last, I mean, say 6 months in my department, is that what we realized that a lot of our complication with this access complication, femoral side, because you're using these flow diverters, antiplatelets, and old patients, bad arteries. So, and sometimes bad arch, we could get by, but a lot of struggle there, and groin complications really worried us. So we have started using a lot of radial approach now, even for neurointervention. Like this patient, very bad arch, very difficult to catheterize, very difficult origin of vertebral artery, had a basilar top ruptured aneurysm. So we went through the radial route here, and we are able to take nowadays neurosheath through the radial, and it's very convenient. This is the arm, femoral is spared, and we are here sitting on the table and very conveniently doing it, and we could coil it. So we are doing now carotid stents, flow diverters, stent, balloons, all by radial route, except for mechanical thrombectomy, in which there are some limitation at times taking the balloon guiding in there. So I wish to thank all my friends in Nepal for this opportunity. It has been a pleasure to take this lecture. Thank you.
Thank you, Dr. Vipul. It had been a very illustrative and elaborative talk. Well, since we're running behind time, let me take only one question from the audience. Okay, so Dr. Vipul, I see as the new technologies are coming up, the packing ratio is getting reduced. We are not actually too much focused on how we pack the aneurysm from inside. And also, I think the antiplatelet regimens are also getting changed. So can you just briefly on these two aspects?
So that's what I wanted to emphasize. When we are using a balloon or a stent, packing remains very important. A stent has some flow diverter effect, but not that much. So I think sometimes, if you don't have a biplane, you're not confident, you underpack, and you hope it will thrombose with time. What we realize when it does so, after many years, it can start coming back as well. So, but definitely with flow diverters, if they're well opposed, then you don't need to pack the aneurysm. Sometimes we place a few coils in large aneurysms, but don't need that kind of packing with flow diverters. But stents and balloons, definitely yes. Antiplatelet regimen, I think the major change has been that we used to have a lot of thrombotic issues with clopidogrel. So by and large, we have shifted to pasogral and ticagrelor. In my department, our first preference is pasogral. Unless a patient had a history of TIA or a stroke, or patient's weight is less than 55 or 50, then we switch to ticagrelor, otherwise use pasogral with aspirin. In fact, we have done many flow diverters nowadays, particularly the shield cases, without aspirin. We just use single drug pasogral, and it works very well. And by and large, only one case recently, we had an occlusion on these drugs. So maybe in the last 300 flow diverters, we have had 2 occlusions on these drugs, which is pretty low. And both the cases were acute stage. And I think one of the patients, there was a drug happened after 20 days, so patient didn't take the drugs properly. So antiplatelets really changed. But the challenge here has the neurosurgeon coordinating the EVD Maya business. So you need a very close cooperation with the neurosurgeon there.
The collaborative effort between your team and neurosurgical team. And thank you once again for talking in this meeting. We'll definitely like to have you physically here with us in Nepal in future meetings. Thank you once again.
Thank you.
So with this, let me invite the next speaker. Well, the next speaker is a world-renowned person on the social media, Dr. Bipin Chaurasia. Yeah, so can we have Dr. Bipin's talk on the slide, please?
Good evening, sir. Thank you, sir, and the organizer for giving me this opportunity. I am Dr. Bipin Chaurasia, consultant neurosurgeon from Birganj.
Professor Mohan Sharma has already talked about the many aspects of the research in neurosurgery. I will especially focus on the social media in research, their opportunities. The social media is undoubtedly a great revolution in 20th century, and for neurosurgeons worldwide, neurosurgery cocktail has emerged as a footprint imparting a great impact on neurosurgeons' communication, research, and education. Neurosurgery cocktail has now greater than 35,000 members. We have 49,000 neurosurgeons worldwide, and in neurosurgery cocktail we have 35,000 members in all of the social media platforms, including Facebook, Twitter, Telegram, Instagram, LinkedIn, WhatsApp, and Imo Viber also. And our primary motto is connecting neurosurgeons worldwide. Within academic medicine, social media is increasingly being utilized for professional networking, the recruitment of research participants, patient support, and the dissemination of emerging clinical knowledge. From educational point of view, neurosurgery cocktail is helping world neurosurgery community in many ways: dissemination of conference flyer and daily discussion of news and interesting cases, interaction with mentors and experts in neurosurgeons, exchange of neurosurgery PDF books completely free, and live demonstration of cases, assisting in fellowship, observership, providing latest updates in research. In research, social media, especially neurosurgery cocktail, is also helping in making collaboration among different institutions in all around the world, and their final expert view on that subjects, helping in publication, editing articles, and policing also, reviewing the submitted articles also. We are only focusing on the social media. So related to social media, recently we have published few articles making collaboration with one of our friend Bozkurt from Turkey, and we published in World Neurosurgery, Attitude of Neurosurgeons Towards Social Media, a multi-institutional study. We tried to get the neurosurgeons view of neurosurgery in social media, and this is the we published in World Neurosurgery. Perhaps this is the largest survey till now in the neurosurgery history, and we gathered 1,190 response of neurosurgeons from all 104 different countries, and we get the summary that the use of social media could have beneficial and advantage effect on neurosurgery practice, while the frequency of misleading information and lack of privacy were perceived as barriers. Despite the advantages, platforms pose a major problem when considering the nature of patient-physician communication and medical confidentiality. Advanced personal privacy setting on social media could make these communication platforms safer for such use. Next article related to social media, of course, the neurosurgery cocktail we published in British Journal of Neurosurgery recently, with huge collaboration from all around the world, including Lalingam Shekhar and that was the largest neurosurgical social media group, perhaps obviously the neurosurgery cocktail and its impact on communication and research. Previously, we have given the title of largest neurosurgery group, neurosurgery cocktail, and its impact on communication and research, and later it was rejected by many top journals. So we changed the topic. The largest, I removed the neurosurgery cocktail, and later they accepted in the British Journal of Neurosurgery. So it is one way of next in line related to neurosurgery social media publication, and this will come in within a week. Already has been accepted by Journal of Neurosurgical Sciences, one of the top 10 journal of the world. Social media in neurosurgery during COVID-19. We did a survey and analyzed that how the COVID has affected the social media, and an evaluation of neurosurgery cocktail and review of the literature, how the neurosurgery cocktail has helped in COVID-19 era. And the primary author of this is from America, and later we collaborated from different part of the world and published in the Journal of Neurosurgery Sciences. Will come within a week, I think. So the conclusion of this paper is that social media has gained momentum during COVID-19 pandemics. So as neurosurgery cocktail has been added by 4,000 members during that period, and within 2 years, the 4,000 neurosurgeons have been added. This shows that how the neurosurgeons are added to attracted to the social media for their education and for other purposes. This is another article of relevance we published in Neurosurgery. I mean, and this is article related to those neurosurgeons who died during the COVID-19 area due to COVID, and we published our obituary in the Neurosurgery, and this is the article. There are so many bibliometric articles of major neurosurgery published by us, 4 or 5, I think, and we try to analyze that how the neurosurgical publications are going all around the world, and especially in Nepal. So we found that in Nepal we are not much interested in research articles. So we are not in the top 10. Not even India is in top 10 in research. So we should focus on that. We will also do some research so that our presence will be felt in the world. And this is look at this. This is the corresponding authors history. USA is #1 in neurosurgery. But if you talk about the research all around the world, China is #1 in doing research. And so our conclusion is that continuing education and making yourself update in neurosurgery is essential part of neurosurgeon's life. Despite busy life in neurosurgery, research should be made a mandatory part of it so that we leave some of our footprint for future generations. And this is my publication till now. And many thanks.
Thank you, Dr. Vipin, for a nice talk. And you really are a social media, tycoon, I would say. So how do you, just one important question, how do you prevent medical legal litigation issues which can crop up while sharing, just like you said, the patient confidential scans, because anyone can probably post, if I'm not wrong,
yes,
their cases. How do you ensure that?
This is a crucial problem of the social media. But neurosurgery cocktail is a secret group. Secret means this is a private group. No one can enter in that group except neurosurgeon. So within the confidentiality is within neurosurgeon. So that message, whatever you are posting, is not going in the public, because this is a secret group. There are so many types of group in the Facebook, like general, public. So this is a secret group. This is the matters are only within the neurosurgeon. So this is one type of, you can say, but still the social media is very vulnerable.
But being an admin yourself, I think you should ensure that patient anonymity is maintained. Any time if anyone is posting. So at least as an admin, it's your ethical responsibility.
That is not ethical, but maybe in future social media will improve, I think. And patients are not going to see whatever you post in the neurosurgery cocktail, because this is a secret group. Only you will see if neurosurgeons are there. I have allowed, then you can see. Otherwise, you can see.
Yes. Anyone else for comments? So, paper is out for the discussion.
So many neurosurgeons on the group. Isn't there a risk of that material going out somewhere? And I will directly the public may not see it.
Yes, sir. Not so many. Almost 35,000 neurosurgeons are there in all of the social media group, and we are also distributing PDF books. Whenever it publishes, it comes on that day to me. So you can get it PDF books immediately without any charge. So, sir, that privacy is restricted within neurosurgeons. So there are some legal issues I am still facing, but that is not. I am not talking about that. Not want to tell you, but I am still facing some legal problems.
Well, Vipin, we would like to congratulate you that you have actually initiated good things in your career. And one is definitely the collaborative research. A lot of your work involves multinational, specialty sometime people in your research works. And that actually talks good about you, that bringing in a lot more people into your research actually makes it much more widely acceptable. The findings are widely acceptable and adaptable. And also you have worked upon bibliometric studies, which are recently a new concept. And these are good things which we definitely want to appreciate you for. And we'd like to congratulate you on your success and wish you best wishes. But mind you, there are certain loopholes which needs to be corrected. So
Yes,
keep a mind on
thank
that.
you for your advice.
Okay, thank you everyone for this patient hearing and active participation. Thank you, Bipin. And we would like to call the end to this discussion seminar, and we would like to invite the next talk.
Thank you, gentlemen. That was a very informative session. Due to time constraints, we have a slight change in our schedule. I'd like to inform that we'll be having lunch break now. Hence, I humbly request the respected delegates to proceed towards the dining hall to enjoy the delicious meal. We'll gather again for the upcoming session at 2 p.m. sharp. Thank you.
Hello. Hello, 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 check.
Yeah.
Good afternoon, ladies and gentlemen, and welcome back. I hope you enjoyed your lunch. To start on with our next session of the day on minimal invasive and endoscopic neurosurgery, I would like to cordially invite Dr. Avadish Kumar Jaiswal from SGPGIMS Lucknow, India, and Dr. Bhagopa Karmacharya on stage to moderate the session.
So good afternoon. Actually, this session was supposed to happen before the lunch, but because we were late on our schedule, so we are starting this session. The first speaker is Professor Avadish Kumar Jaiswal. He will talk on keyhole endoscopic excision of intraventricular tumors, early experience and outcome of endoscopic. Okay.
First of all, I am thankful to the organizers for giving me this opportunity. I will be talking about endoscopic keyhole surgery for lateral ventricular tumors. Lateral ventricular tumors are not very common in neurosurgical practice, and surgery is the mainstay of treatment. There are two surgical approaches to address these tumors. One is microscopic and other one is endoscopic. Among the microscopic, transcloisal and transcortical are the two corridors usually used. And the endoscopic, the corridor of use is transcortical, which is done by either endoport surgery or endoscopic control surgery. And I will be focusing my talk on endoscopic control method. So what are the challenges in surgery for lateral ventricular tumors? Basically, these tumors are located in a deep location in the proximity of the vital structures like thermostat vein, fornix, coracoid plexus. All these things make the surgery very challenging. And microscope offers poor visualization as well as a limited view of the tumor. Here, the endoscope wins the game because it provides excellent visualization as well as panoramic view. Case selection, those cases of the intraventricular tumor which have concomitant associated hydrocephalus are should be done with this approach. Hydrocephalus provides space for instrument manipulation, and one can work around the tumor in presence of hydrocephalus. We do this surgery in supine position if the tumor is located in the body or the frontal horn. We do not use any head fixation device or any navigation. However, the tumor is located in the trigone area, then the keyhole is placed above the pinna, like you see in this diagram. These are the scalp marking. We mark the sagittal suture and the coronal suture, and the keyhole made in the precoronal area, like you see here. And the creatinine size not more than 1 coin rupee, as you can see here. The skull flap is raised. Earlier, we used to take linear incision. Now we take C-shaped incision, which provides pericranium to cover the dural defect, which if present during the surgery. We do not use any retractor. Rather, you try to use stitch retractor, which offers less tissue destruction. The skull flap, after raising the skull flap, you can see here the bone is exposed. After that, a small hole is made by drill, and then craniotomy is completed. You can see the size of burr hole, mini craniotomy. After that, dura is opened and stitch sutures are taken. The pia is coagulated and then incised. Then after, we do ventricular typing by using a ventricular scope or a large bore cannula. And then we do a rotatory maneuver of the ventricular catheter like this. This video is not working. This is a small video lower down. Yeah, like this rotatory movement to increase the cortical, widen the cortical tract. And this is the operating setup. The role of assistant who sits left to the surgeon becomes very important. You have to keep the assistant very comfortable because he is the main game player and hold the endoscope in both hands like this, as you can see here. These are the operative instruments which are used. And this is lower down on the left side. You can see the close-up view of the operative area where the surgeon in the left hand holds the suction and the right hand holds the instrument, bipolar, dissector, or surgical or for seizure. And the assistant holds the scope with 2 hands, giving rigid fixes hold of this endoscope. And on the right side, you can see this is a schematic diagram which shows the arrangement of the endoscope in the top and the section on the left side and bipolar or other instrument on the right side. And all these 3 instruments, they provide dynamic restriction over the cortical tract, keep the working corridor open, and through which the surgery is performed. And this is entirely a freehand technique and no retractor, tube, or any specialized use whatsoever in this procedure. And this is the closure. And we usually do not put any EVD because with the endoscope, we can navigate and take out all the hematoma collected blood present in the ventricle. So this is a illustrative case. You can see here this patient presented with large anterior lateral ventricular tumor. This is the operative video. Can you play the video, please? You can see here we are the left side of the ventricle and doing standard microsurgical technique, defining the tumor from the surrounding parenchyma and separating it from all around. There is good plane. You can see endoscope provides excellent visualization. And suction acts as a retractor, suction as well as dissector, everything. Using both hands, the endoscope is held by the assistant and showing the things. We are separating toward the septum side. You can see septal vein. Gentle separating the tumor from all around. We can do piecemeal, but that provides bleeding, makes the area bleedy and mesh. So we try to go all around because we are getting good pain. So gently separating is from every side. Usually, we don't use internal decompression unless the tumor is very large. And We are not able to see the surroundings or attachment area. So once the tumor is separated from all around, we rotate it, see from where it's attached. Now it has been separated from all around. We keep on putting irrigation to keep the area visualization clear, because sometimes there is fogging. And now it has been separated from all around. We are taking it out from the tract. In one piece. Now we are navigating endoscope through the atria to temporal horn, taking out the blood. You can see choroid plexus. So that's why we don't put any EVD, because everything is very clear and under vision. You can see, I can see toward the temporal horn, taking out every blood clot, everything. You can see the choroid plexus, thermostat vein, the foramen Monroe, like here. This is the foramen Monroe, which was compressed, which is seen. No, nothing was injured. Everything taken out very easily. The size of credit is only the fingertip size, not more than this. This is the immediate post-op scan. Complete tumor has been excised. This is another patient having very large tumor. This is the operative video. Can you play video, please? Same technique. The tumor is being separated from the septum pellucidum. You can see the opposite ventricle also. There actually a hole. The tumor was involving the septum pellucidum. There is a hole in the septum. We are trying to separate the remaining septum from the tumor. Everything is being done under endoscopic guidance. The assistant is holding the scope, and they are well trained and they can show everything. What I want, they know it. In this patient, because the tumor was large, we did piecemeal excision. So this is the remaining part of the septum. Unfortunately, I don't have pointer, so I can't show it. But this septum, the opposite ventricle is seen on the behind it, posterior to that. So after the tumor has been removed, you can see the opposite choroid plexus, opposite ventricle, thermostat, foramen Monroe, atria, everything. The complete tumor has been removed. This is ipsilateral foramen Monroe. You can see choroid plexus. We are going again ipsilateral atria towards the temporal horn, taking out the blood and everything. This is creatinine size, very small. This is immediate post-op scan. Complete tumor has been excised. This is follow-up MRI. No residual tumor after 1 year. This is another patient, child having large tumor on left side. Please show the video. We have dissected the tumor from all around. You can see the ventricle and choroid plexus, posterior the tumor. Here the tumor was very large. We are taking it out, and it was delivered on my palm, just like a baby. You can see here, it is so large. This is the cavity. You can see the ventricle, choroid plexus, everything intact. This is the immediate post-op scan, complete tumor size, and child were completely all right. Another patient, a small tumor, removed completely. This was my earlier cases where I used to take linear incision and was not using skin detector, rather using this mastoid detector. This is another patient, large tumor, completely excised, same technique. And the small tumor, you can see here the linear incision. Earlier cases, biopsy was central neurocytoma. Another patient, large tumor, completely excised, biopsy was Sega. This large tumor, completely excised, central neurocytoma. Another one, large tumor, biopsy was central neurocytoma. And the even larger, this was earlier case, linear incision. This patient developed transient hemiparesis, improved after post-op. And the very large tumor, child, complete excision. You can see small hole, linear incision, biopsy was anaplastic hemadenoma. And the patient, very large tumor, central neurocytoma, completely excised. And the small tumor, ependymoma. You can see here this is a large tumor filling on the both sides of the ventricle, completely excised. This is left side, right, on my right side, this is a post-op scan. Biopsy was ependymoma. Another patient, ATRT, small tumor. This is tumor filling both the ventricles. It was operated through single approach because we can navigate it with angle endoscope. Biopsy was central neurocytoma. Another large tumor in a child, complete excision, ATRT. Another central neurocytoma, pre-op and post-op. This is another patient, pre and post. Large tumor, completely excised, anaplastic ependymoma. This patient presented with tumor with bleed. Same approach, complete excision. Another central neurocytoma, complete excision. Lower was the post-operative scan. This tumor patient was operated earlier. You can see large incision, only decompression was achieved. You can see ours was a small incision, complete excision. Biopsy was pilocytic. And the patient oligodendroglioma. This patient Sega, complete excision. This is a recurrent teratoma. You can see here this large incision operated previously. Entirely our incision, complete excision. And the patient dermoid, again Sega, again central neurocytoma, large tumor, complete excision. This patient having large atrial meningioma, complete excision. You can see here there with small hole. And the ependymoma, complete excision. And the ependymoma, completely excised. This meningioma, completely excised. This choroid plexus papilloma, complete excision done. Another patient having very large tumor in a child. We tried to remove it. Patient had massive bleeding. We had to stop. Patient developed hypertension. This is the residual tumor. Had some recurrence. We again operated. Biopsy was yolk sac tumor. Another patient has large tumor in the atria with massive edema. We went ahead with the same approach. Patient developed postoperatively IVH and edema around it. We had to go decompression. Patient improved. So we have experience of 40 cases. In 37, complete excision was done. These are the complications. This is a very type of lesions of the histopathology. The limitations are basically there are two-dimensional image. There is a steep learning curve, and one has to learn how to operate in a limited working space. So to conclude, endoscopic excision of lateral ventricular tumor is feasible in small and larger size tumor. This is minimally invasive, has good surgical outcome. However, learning curve is a limiting factor. Thank you very much.
Thank you, Professor. So if there is any question, one question. Okay, if there are no questions, thank you, Professor. So now I'd like to call upon Dr. Nikunj Yogi. He will present on experience and outcome of endoscopic evacuation of supratentorial spontaneous intracerebral hemorrhage.
Good afternoon, everybody. Slides, please. Let's start with today. I'll be talking on our single institute experience on endoscopic intracerebral hematoma evacuation. So we started operating on endoscopically in intracerebral hematoma some 3 to 3.5 years back. Initially, it was rather difficult. It was not an easy way. Learning curve is definitely there. Now, almost all cases we are doing by almost all, not every cases are possible by endoscopic ICS, but almost all cases we are operating this method. So today I'm here to share my experiences on endoscopic ICS in our institute. We all know the dilemmas in operating or not operating, the debates on operating and not operating, going operative or conservative management of ICH. I need not elaborate on the various the trials that had been recently done in industrial hematoma. I would rather like to focus on a point that what the principal investigator of this trial has mentioned. He had told that it's only reasonable, advisable to operate on those patients who deteriorate in ICH. So in our institute, we take it a very that is a very important point. We admit the patient if the patient's GCS is fairly good enough, and even the patient is having a borderline size of hematoma. If there's any deterioration, we go ahead with operation. There are two important benefits actually. One, the hematoma is localized. Organized, I'd rather say organized. So if you have to operate, the operating is easy. Second, once the patient is deterioration, that means there is urgent need of decompression. At that point, going would be rather feasible. Now, the surgical goals is not only to remove clots, but then to relieve the mass effect. And again, after 72 hours, usually there is cytotoxic edema, the metabolic effect that occurs in the perihematomal area that actually causes a deterioration, secondary deterioration of this patient. To alleviate that, usually operating whenever the patient immediately deteriorates is very much important. So that is the main goal of treatment. Now, coming to the topic proper, endoscopic ICH, and there have been many trials that has been going on in endoscopic ICH, which are ongoing. I would rather say rather than endoscopic, minimally invasive intracerebral hematomas. But the first RCT was done somewhat around 1989. We showed that there was some reasonable benefit in doing operating endoscopically in ICH, even in ganglionic, even though there was no any statistic difference in the outcome in ganglionic ICH, but then trends were towards the better outcome. And other studies thereafter also concluded that there are higher evacuation rate in case of endoscopic ICH. There are lesser complications. There are higher chances of good prognosis, and mean changes in GCS are also more in endoscopic ICH group. So we all know the indication. I'll quickly skip this slide. I already told that what we are operating on. Usually the size of hematoma, if they are more than 25 to 40 ml, and again, deteriorations are there. Now this picture I took taken from a study where they have showed various devices that have been used in endoscopic assisted techniques in ICH evacuation, right from craniopuncture. Basically, craniopuncture, stereotactic aspirations are all the same. It's only Chinese and Western version. In China, they said craniopuncture. They put a small stereotactically placed puncture device, which is as a very small hole. They aspirate some amount of blood, and then they push some urokinase thrombolizing agent and put in a catheter. So these are catheter-mediated thrombolytic agent used techniques. So in endoscopic techniques, basically they are either catheter the placing procedures. There are urokinase like thrombolytic agent using procedures, and then there are endoscopic assisted procedures where you plan to remove all the hematomas in the single setting, whatever is possible. So here in this picture, I have showed the instruments that are basically necessary in endoscopic assisted procedure. This is what we are doing. So I will be focusing my talk on that. What we use is the routine endoscope, usually 30 degree and 45 to 45 degrees are beneficial, but up to 30 degrees, okay. We can sometimes it's risk to look at the corners and where you can have a direct visualization. And then approaching passage is very much important in endoscopic ICH. I'll show you in the other slides where we have devised all the other investigators, surgeons have devised their own devices whenever there is a commercial sheath is not available. But nowadays the commercial sheaths are available, and these two also have gone through many improvements. Initially there were metallic sheaths that were developed through which we cannot see at the corners in the brain surfaces, like I would not say surface, in between the hematoma and the surface of the cortex, the brain parenchyma. However, with the transparent sheath, you can see through the sheath, and you can see the corners where the hematoma is still present. So that is the advantage of that. And then This is something a few of the investigators have devised, and I've copied from them. When approaching into the hematoma, usually we make a small incision in the sulcus, transsulcal region, and then passing that bigger passage is slightly like, you initially are slightly threatened to pass in the passage. So what you do is you put in a dendu cannula, you hit the hematoma. When you know that you have hit the hematoma, you take out the dendu cannula, remove the thread, and take a glove, finger of a glove, tie a thread into that. Then with 3 cc to 5 cc syringe, you push the dendu cannula inside the hematoma cavity again, push it inside, that will inflate and pull it outside. So that makes a small passage, so that when you pass the passage, it becomes easier. Slice please. No problem. And then after that, what you do is you put in your endoscope, you ask an assistant to hold the passage in a position where you want to be. This is all like what you do conventionally. One important thing is that we have to be in the hematoma to evacuate it. Try not to go into the surfaces. And when you are in the hematoma, core of the hematoma, you can use a high suction power, so that you can take out the clot fast. And when the remnant is towards the cortex, towards the wall of the hematoma cavity, you go slow and try to irrigate, try to swirl around and take out the hematoma as far as possible. Right, and obviously the angle suction tips are very much important when you want to take out the hematoma from the corners. Sometimes when you don't have a navigation device, you all don't land up in the trajectory you want to be. So what happens is some amount of hematoma are always there in the corner. So if you want to attack that, a 90 to 45 angle suction is always helpful. Now these were the ports when I started initially. I made a small incision in the cortex, like we always do, transsulcal cortex. Whenever you do a big craniotomy, we should always remember that the craniotomy is big. The corticotomy is always small, like exactly what you do in endoscope. We're not doing anything different. The corticotomy is always small. We pass a small brain spatula and within retract and then go into the hematoma. So exactly we're doing the same thing. We pass in the nasal speculum. I passed in the nasal speculum, tried with that. It was possible. So I got an idea that first I'll make borrow and try with that. So what did I do next was I took a syringe, cut it off in the tip, smoothen it, and then pushed it inside. Then someone came and gave me an idea that the third device is the sheath that you get with the Medtronic's drill package, the plastic cup packet of the Medtronic drill bit. You cut it in the tip, smoothen it. That can also act as a passage. So whenever you don't have a commercially made passage, this can always be improvised. And this was not done by me the first time. Everybody has done it. Whoever tried endoscopic ICS. These are the commercial ports that are available. It is slightly tapered in the tip, so that's very easy to insert. Now, entry point. Initially, when I started doing endoscopic ICS, I always marked my curvilinear incision right from the temple into the frontal region. And the Keen's point, which came, that was my linear incision part. Why did I do that was in case I landed in trouble, I always wanted to change it into a conventional strategy that was always known with. I was very much experienced with. So whenever you start, try to make a point somewhere here or somewhere here in the frontal region, so that whenever you require, you can convert it. And later on, most of the hematoma can be attacked pre-coronal, from somewhat ahead the central sulcus, pre-coronal region. You make a borrow exactly at the Cosas point, because the hematoma usually are at the region of the ventricle. The ventricles is usually shifted towards the other side. So that is the trajectory that you need to hit. When you hit in the Cosas point, you will directly land up into the hematoma. Then the rest part is always easy. Or sometimes whenever there is a temporal extension, you can always use the Keen's point. That was the point let's say not exactly Keen's point, but somewhere around there was the point I started to begin doing these surgeries. I have never used a Frazier's point, though. Whenever there is occipital extension, that will be an easier point. When we were taught in our residencies, my prof used to say you can always attack a hematoma through a temporal lesion, to a frontal lesion, through occipital lesion. That's what the trajectory that we are using to reach the hematoma. Now, these are our experience. Over the period of 3 years, we have already done around 21 cases. The mean age of the patients and the other demographics are mentioned there. One important point is the mean operative time really shortens. Because you're not doing a larger craniotomy, you're not raising a flap, you don't have to meddle around the small vessels in the dura, you don't have to coagulate them. These all things are shortened. Small incision, one borehole, maybe you need to enlarge a bit to allow the passage to enter. And one thing important to remember is they have to create a slightly bigger hole than the size of a passer, so that sometimes at the corner you need to remove the hematoma, you need to change the angle of the passage slightly anterior, posterior, and sideways. For that reason, also slightly it has to be bigger. So the duration of surgery, in general, if I operate through my conventional way, it might take around let's say more than 1.5 hours to 2 hours for me to complete a hematoma surgery. Whereas in this, around 45 minutes to let's say around 1 hour is more than enough. Blood loss is really reduced because you don't have to go through a larger craniotomy. And these are our access point. Most of the cases we access through courses. Yeah, I have mentioned 2 others. When I initially started, there was I had an idea that the trajectory which is in the straight point should be attacked first. So I tried with the supraorbital region, and that was a blunder because the trajectory is slightly larger and the suction you have is not that large enough, neither the passes. You can only reach up to half of the hematoma. You cannot go up to the posterior side. So I found that supraorbital rather than supraorbital, the cox's point, a slight ahead of the cox's point, is the best way to deal with these kinds of hematoma. So far, I have been always able to take out those hematoma from cox's point or the Ferrius point. And these are the recoveries within 45 days. There were 2 deaths. Initially, the one death I had mentioned was supraorbital one. I had to go back again, evacuate the hematoma again, but the patient didn't make a good outcome at that point. Now, this is the incision. Initially, this was the incision I was doing. Now, currently, most of the cases I'm doing it to the cox's point like this. And I put a small retractor, master retractor, make a borehole, and enlarge it with either a drill or a nibbler, so as to insert a passage. This is the post of view. The tight brain is usually lax. Once you have a lax brain at the end of the procedure, it's almost sure that your procedure is over. Even if you have a dilemma that I might be leaving some amount of blood, yes, there will always be some amount of blood left. 5 ml to 15 ml is normal. But then you have already achieved the goal. The midline is corrected, the mass effect is gone, because you can see it from the above. The brain is lax, sag down. And sometimes I initially used to close the dura with a suture, like I open it in crusade vein. Sometimes nowadays, since there can be because of lax brain, there can be an post-operative EDH in some cases. I tend to use hit it with the pericranium, as we do in chronic subdural hematoma cases. Now, this is the cannulation I told you I usually do to confirm that I have reached the hematoma location. Now, this is the one illustrative diagram that I found in one of the literature. This is what exactly we need to do. First, we need to cannulate the hematoma, inflate the passage, put in the passage, and then we suck out the hematoma. The passage can be maneuvered slightly anterior, posterior, and laterally or sideways as you require. And then once we come out, we keep on putting a surgical and gel or abgel gel form, whatever is required hemostatic agent, and then we come out completely. As we come out, the layers coap together, and then hemostasis can be well visualized as well. So this is the hematoma evacuation surgery under the endoport that we can see. We should always be attacking the core of the hematoma. We should not meddling with the brain that slightly herniates within the port. We should be careful not to touch that, because that will lead into small oozing, and then that creates a bit difficulty. Obviously, we can put irrigation as well. From there, the assistant can pass in the irrigation, and then we can suck out the tumor. About hemostasis, whenever hemostasis is required, we can use bipolar. bipolar can also be used, but then there's a difficulty with the inner port. You can use the bipolar that is usually used in transnasal surgery, the endoscopic bipolar that can be used. But then I rarely remember using a bipolar in any of these cases. In one cases, initially I had to use a bipolar. In that case, I was really worried. I took out the port. I used the brain spatula and did it as we used to do before. I used the bipolar as we used to do in a conventional way. And thereafter, I don't remember using any bipolar. Please click on the link. After completion of the surgery, so as we come out, this is how we pack on the surgical, and then as we come out, we see whether there is a hematoma. You can see the brain parenchyma around the transparent sheath. It is snugly, it is tightening around the sheath, so there is no point, no chances of bleeding to occur in the passage. Like unlike in conventional surgery, where sometimes while maneuvering with the brain spatula, we can injure the surfaces. There can be hematoma, and we'll be keep on using surgical on the wall above, and that can be really a challenging thing. Other thing that is challenging is the vision.
Dr. Nikhil, could you please conclude?
Sorry?
Could you please conclude? Time is over.
Sorry.
Your time is over.
Okay. Can you go on to the next slide, please? Okay. So basically, this is all that I had to put up with my experience. Now, coming to my experience with this, what I feel there are advantages of this kind of procedure. Now, this is the preoperative and postoperative CT scan of my case, one of my cases, and the other cases also. You can see there is a good evacuation of the hematoma. Advantage is that, like, reduced operative time, decreased bleeding is always there, and then illumination is very good. Illumination and ventilation. One thing that we always encounter in evacuation of hematoma surgery is we use headlight, we use microscope, we use top light, but then we are always trying to look into the hematoma cavity, whether we can visualize on that. Endoscope gives a brilliant solution to that. You can directly take your light right up to the hematoma and see whether there is a bleeding vessel, whether there is a hematoma left or not. So that is one important. Disadvantage obviously is like control of bleeding. I have not encountered 12 till this 21 cases, but if there is a bleeders that I encountered, sometimes controlling that can be a difficult one. Of course, you can use with your experience bipolar catheters, bipolars to coagulate those both vessels, but then that can be a problem. And then the steep learning curve also. So thank you. In this picture, what I have shown to you is that I am using a headlight when I was starting a case. I always used to use that one because what I was always thinking is I might need to convert. So in any time I was prepared with a scope or with headlight. So that's my experience with the endoscopic hematoma. Thank you.
Thank you, Dr. Nikunj, for your nice presentation. Because of start of time, only one question is invited. Yes, please.
Okay. What we do is we put a dandy cannula inside. Once then we take out the seed. We are sure that hematoma is there. Then I take out the dandy cannula again. Now I put the balloon in the cannula. Then I put it back inside and then put the seed. Yeah. That's all.
Thank you, Dr. Nikunj. Next speaker is Dr. Nishant Goyal, and he'll be talking about transciliary keyhole supraorbital craniotomy.
Thank you, sir. Good afternoon, everyone. I would like to thank the organizers for this wonderful opportunity and nice hospitality in the very nice city of Pokhara. So I'll be talking about transciliary keyhole supraorbital. There's another presentation. This is the other one. There are two presentations. Yeah, thank you. So I'll be talking about our experience with the transciliary keyhole supraorbital craniotomy at Rishikesh in India. So as we all know, craniotomy is a very good approach with good maneuverability, and ciliary dissection is very easy and approach for variety of aneurysms and tumors. This is how it looks. However, the world going from big to small, we would all want to should try to convert it to a smaller craniotomy whenever possible. So we should know when to do it. I'll just be going through a few videos very quickly so that just to share my experience. You start the video, please. So this was a young lady who presented with Huntington's grade 1 SH with a thick SH. We could on the DSA we could see the ACOM aneurysm at A1 A2 junction. So we made a small craniotomy by giving a small supraorbital superciliary incision. The keyhole is first defined, after which the keyhole is made and we make a small mini craniotomy. And the important thing is to drill the inner table of the frontal bone so that we can get more access there and we can reflect the dural flap better. After this is done, the dural incision is made and the dura is reflected inferiorly. The brain can be tense initially, but as soon as you start taking out the CSF, it will become lax. So that is CSF being drained, and following which the brain becomes relatively lax. And if like cilium fissure resection is more difficult here, I'll be talking about that at the end. But whatever cilium fissure you can see, we should try to dissect it to free the frontal lobe of the weight of the temporal lobe, as you all know. And then once we have done this, we can visualize the optic nerve, the ipsilateral ICA, the bifurcation, the A1, and that is the aneurysm at the A1 A2 junction. In this case, I did a little bit of gyrosectus dissection also to make it to visualize it better. Now this is you can see very well bilateral A1s, A2s, ACOMs, and the aneurysm, and confirmed by ICG. Then the temporary clips are applied on both the A1s. You can see that the approach is not very different from the standard diurnal. Everything that we need to do is in front of us. This we need to be very accurate about where we want to go. And after doing everything, we put a permanent clip. Remove the temporary clips to see, check with the ICG. There's a small neck, which was after which the clip was readjusted. And this is the ICG post clipping. Because there was some amount of hydrocephalus, the laminar terminus was fenestrated to let the CSF out from the third ventricle. And because there was thick SH in the basal cisterns, the cisternostomy was done to clear the debris and the blood. And you can see the basilar trunk and the bifurcation in the third nerve there. That's a better view. The contralateral PC, SE, and the third nerve, and similarly on the ipsilateral side. This is the patient's post-op picture. So this is another video. This patient did well. Yeah, just play the video, please. Back into it. No. Just play the video, please. Yeah. So this was another AD with another ACOM aneurysm. Similar steps. The important thing is that ACOM aneurysm provides you, like, everything is there. So supraorbital craniotomy provides you everything that you need to see with ACOM aneurysms, all the 11 vessels. Cilium fissure opening is very difficult, is comparatively difficult in these approaches because you can see the needle is pointed very vertical compared to pterygonoid craniotomy, where you can make it horizontal. Your hand is very horizontal in pterygonoid craniotomy, which is a better way to do it. So once we have again we've reached the area, this is the optic nerve and the ipsilateral ICA. The ipsilateral A1 was seen. The temporary clip is applied on the ipsilateral A1 because, and no need to apply it on the contralateral because it was atretic. After applying the permanent clip, I dissected the aneurysm further. The clip was readjusted. And then the temporary clip was removed. This is the post-op CT of the patient, post-op picture. And DSA showed complete occlusion of the aneurysm with good flow. These are some cases of tumors which I did with supraorbital approach. It was an 11-year-old girl who presented with third nerve palsy for the last 7 months and right side hemiparesis for the last 3 months. And she came to the emergency in a drowsy state with the recurrent episodes of vomiting for 4 days. So when we saw her, she was even V1 M2, and after intubation, she became even E2VT M4. We saw the CT scan at presentation with a large solid cystic lesion with calcification. So after first a shunt was done, following which she improved to E4V2 M6. And this was the MRI which was done after the shunt because it did not have an MRI available before that. So again, supraorbital approach was taken, thinking of it as a craniopharyngioma. The periosteum is elevated. Defining the key bore hole is very important in this approach. You can find it at the lateralmost extent of your skin incision. Then after the aortotomy, CSF egress is done, and then the brain becomes lax. Again, silver fissure is dissected so as to allow better retraction of the frontal lobe. This tumor was basically approached from the subfrontal approach, and you can see the IC bifurcation. That is the craniopharyngioma capsule in the interoptic corridor. You can't go through the optocarotid corridor because the corridor is the IC is very much pushed laterally. So I decided to go through the interoptic corridor. You can see the contralateral third nerve there, that one, and the contralateral PCA. So the trick is to just dissect it slowly, gradually, pull the wall, like shown by Dr. Avdesh just now. We don't want to decompress it initially. But if it is cystic, then you should decompress it first so that the brain becomes, wall was removed nicely in the tumor, solid part of the tumor. There's no need to pull too much. Whenever you're not able to get it out, it's better to cut it and then remove the remaining part separately rather than trying to remove it in one bulk when it is not possible. So again, this last bit also came out nicely. And just visualizing for the remaining structure, the normal structures and proper hemostasis was achieved. This is the patient's post-op CT with the complete removal of the tumor, and patient felt some DI for which was managed conservatively, and patient gradually improved to power 3/5. This is a follow-up CT scan and follow-up MRI, which shows good excision of the tumor. Another case of craniopharyngioma. I'll not be going through a video again because probably it will take too long. Or if you allow, maybe I can just show one more video. Another similar case, large cystic component, and solid was more on the right side. So we decided to approach it from the left side because we thought at least we should decompress the cystic part first. These are pre-op pictures and the video. So same steps, and again, as soon as we opened the retractor frontal lobe, we could the cystic portion got decompressed on its own, and the brain became lax. And the next step is to just look for the tumor capsule and the solid component so that we can take it out to prevent the recurrence. So this is again the interoptic corridor and optocarotid corridor also being explored. This is a bifurcation of on the left side. Again, the solid component of tumor being debulked. It was multi-compartmental, so in between it would be like some cystic portion would get decompressed and we'll get more of the capsule. Now the main solid component is being removed. And here again, at the end of the procedure, we could see the basilar tip because the tumor was going all the way till the basilar artery, as you can see here. So this is these are the post-op pictures, complete excision of the tumor, and the patient's picture and fourth post-op day. Another case, large cystic tumor with a solid component. This is 2 months follow-up picture of the patient. Then few meningiomas were done by the same approach. This was a small anterior 1/3 falcine meningioma, removed from the same approach. I'll not be going to the video again this time. I can just skip it probably. And follow-up, there was some orbital edema, but it became much better after 4 months, 3-4 months when he came back. Another case, it was a large olfactory groove meningioma. So word of caution, we should not try for every olfactory groove meningioma. Like this, in this lady, we tried this approach. CT showed good excision, but MRI showed, sorry, I'm just going forward. MRI showed a small residual lesion. I don't have the MRI right now, but then this is a post of CT, which shows recently good excision, but the MRI actually showed some small residual. We told the patient to get it operated again, but she refused. She was happy with the surgery. So this is a picture at post-op day 22 on the right side. So how this approach is different from the standard thyroid craniotomy is that you can see the right on the left side. The red shaded area is the thyroid craniotomy, and the green shaded area is the supraorbital craniotomy. The important point here is that the keyhole, which is the lateralmost limit of the supraorbital craniotomy, lies much below the Taylor-Horton lines of the Sylvian fissure. So it's very difficult to actually open the Sylvian fissure through this approach. The only way is to just put some retractors, Langenbeck retractors probably, and pull your muscle down and make the craniotomy slightly bigger so that you can go further down. I don't know if this will work or not. So, okay. So that we can go slightly inferior. And still, even if you do that, you can see the position of the needle there. Your instrument, whatever you use to open the Sylvian fissure, it will be very vertically placed in case of keyhole craniotomy, because the craniotomy is so small compared to cryptogonic craniotomy. So these are the few limitations that I come across whenever I do these cases. So good patient selection is very important for doing this approach. So these points I've already discussed, and you cannot, mostly you should not attempt MC aneurysm for doing this because the temporal lobe is not seen at all. So if you want to do by hero approach, you should not attempt those cases. And ACB drilling is like quite difficult and challenging, which I have not done ever. So probably those cases should also not be attempted if they're required for big IC aneurysms. So to conclude, it is a very good approach for most ACOM aneurysms and precellular lesions, especially those having cystic components. And it provides you a very good direct approach to the anterior skull base over the orbital roof. It's a very quick approach, which gives you a small craniotomy and a good cosmesis. However, a very good case selection, like I've already said, is very important to do these cases. Thank you very much for your kind attention. And I would like to invite you all to the ISMENS Congress that we're having in New Delhi next month, just after Diwali. Thank you.
Yeah, thank you, Dr. Nisant Goel. So if you have any question, one question. Okay, thank you, Dr. Goel. Now I call Dr. Rajendra Shrestha. He'll be presenting on endoscopic versus microscopic transmental pituitary adenoma surgery. So I ask all of the speakers to stick to the point, so of 10 minutes.
Respected Chairperson Ondex, my senior, my dear colleagues, it's my great pleasure to be here and present the endoscopic versus microscopic transmental pituitary adenoma in our center. Regarding history, late 80s and early 90s, Professor Paul and Hursley, they performed the transcranial operation for the pituitary. And then in 1907, Professor Suslov performed the transspinal surgery. In that time, there was morbidity and mortality was high. Professor Cushing and Dandy performed more than 300 transspinal surgery. And then they reduced the mortality around 6-7%. Again, they tried for the transcranial modified transcranial surgery, and they reduced the mortality by 5%. Three young generation neurosurgeons, Hardy, with Goet, and also Doit, mid of the 19th century, they performed the endoscopic endonasal surgery. Since then, we are practicing endoscopic endonasal surgery. In our center, Professor Devkota performed the transspinal surgery in 1989. Introduction: pituitary tumors account 10 to 50% of all primary brain tumors. This is the third most common tumor after glioma and meningioma. Surgical indications is most urgent: pituitary apoplexy, progressive mass effect, failure to prior conservative management or medical management, and need to tissue biopsy. There is surgical contraindication is less, very few, poor general medical condition, profound hypopituitarism, and active sinus infection. There are a lot of surgical approach to do the pituitary surgery. We have extracranial, transcranial, among them endoscopic intranasal surgery is best one. In case of transcranial approach, indication is double severed adenoma with kissing carotid arteries, sphenosinusitis, and dural tear. All of the surgical approach has advantage and disadvantage. In microscopic pituitary surgery, advantage it was very quick operation, more than 110 years all over the world, neurosurgeon practice and try, and that was a true surgery. And for that only need one neurosurgeon. Disadvantage is, sorry, endoscopic pituitary surgeries, he was a pioneer for the endoscopic pituitary surgery. The advantage of this surgery is wider angle of operation, that is panoramic view, nasal part of procedure simple, less traumatic, able to address pathology around the pituitary gland, better nasal outcome. Disadvantage was most costly for institution, not neurosurgeon, bigger exposure in the nose, need postoperative nasal care, skill, training, cadaver workshop, and can blur the visions. In our series, there is 170 number of patients. There was retrospective study. Among them, 67 number of patients was microscopic managed, and 111 patients was endoscopic intranasal approach we did. The middle age group was more common. Male was more common than female, but in the literature, female is common, but I don't explain it. And presenting symptom was headache was more common with visual symptoms, 61%, endocrine deranged, that is 32%, and type of pituitary tumors was non-functioning by 58%, and functioning was 42%. Type of pituitary tumors was among them functioning proctoma is 57 and growth hormone secreting 36%, 3.3 was Cushing disease. In CT MRI, this is a sagittal view, you can see the cellular mass. This is coronal view, this is axial view, you can see. Main aim of the CT MRI is to know the anatomy of the paracellular sinuses first. Second is either pneumatization or not. And third is morphology and curvature of the cellular floor. Fourth, extension of the tumor with relation with the internal carotid arteries and pituitary gland optic apparatus. This is sagittal view, you can see here, sagittal view. Sometimes cellular mass encounter with some kind of other pathology. Yeah, this is we had doubtful during the preoperative management. We did the CT angio, we got the aneurysm, and we did the craniotomy and clipping. In pituitary tumor size, microedema was more common. Most of the cases were 100% was microedema. Radio anatomical classification grade 3 was 58%. Hormonal assays, that was 200 to 7,000 prolactin level was there. And visual charts, bitemporal hemisphere 75%, and preoperatively nasal swab. This is routine investigation we used to send for to reduce the morbidity and mortality postoperatively. No growth was 90%, growth was 10%. Tips for dissection for preparation prior surgery. Looks carefully, CT scan, MRI, understand anatomy, navigation when no landmark, that is recurrent residual tumors. Plan be ready for the complication. Carefully skull base reconstruction is very important for endoscopic intranasal surgery. That was microscopic setup. We have the fluoroscope with microscope. This we did a couple of years before sub-level transmittal surgery. That is becoming history now. We are not using. We are using the endoscopic intranasal surgery. That time we have to localize cellular furrow. We have to use the fluoroscope. Endoscopic approach is panel view. We can see the intercranial fossa to posterior fossa. And then tips of resection is to understand neuroanatomy, appropriate approach, appropriate magnification, tissue handling, minimum invasive, that is, we have to know the surrounding blood vessels, microsurgical skills, that is arachnoid dissection, high-speed drilling. This is endoscopic setup. We have the CT guided navigation and to know the post-operative residual tumor, and also 3D SD monitor. Yeah, we are performing endoscopic intranasal surgery with 3 neurosurgeons working together. It looks like playing video game. Yeah, this is pituitary surgery looks like normal vaginal delivery, but it looks like normal vaginal delivery. But Professor Atul Goel mentioned in his presentation, it was finest delivery. What to do, what not to do, when to stop. That means finest delivery. Reconstruction is very important during the endoscopic intranasal surgery. If there is CSF leak, most of the intranasal surgery, there was CSF leak. So we have to do the reconstruction with the fat, surgicel, foam gel, nasoseptal flap, lumbar drain, and marrow seal for all patients. Overall surgical risk was quite low. DI was in microscopy 28%, endoscopy 50%, CSF rhino was 10%, endoscopy 5%. But operative CSF leak was high in the endoscopy, but we have cellular for reconstruction was good in our context. Extent of surgery in microscopy, total excision 24, subtotal excision 25, and partial excision 70. But endoscopy surgery, it was 65, total excision 35, subtotal, and partial excision was 11. By this, we can say endoscopy is better than microscopy. Post-op imaging, by next day, we used to do CT scan, MRI, next day if needed, otherwise 3 months and 12 months. This is a post-op CT scan. We can see post-op MRI. That was hormonal assay post-operative. Visual chart was 75%, after operation is 100%. Histopathologic examination was pituitary adenoma. Conclusion, endoscopic and microscopic transitional surgery are sound and effective technique, but endoscopic approach provide good access, greater tumor excision, shorten the duration of surgery, and excellent post-operative outcome. This is the best approach for the cellular and paracellular regions. Thank you.
Thank you, Dr. Rajendra, for your nice presentation. Because we are lacking short of time, so no question will be asked. Thank you. Next speaker is Dr. Amit Bahadur Pradhan, and he will speak about outcome of minimally invasive lumbar microdiscectomy.
Chairpersons and senior neurosurgeons and my colleagues. I'm Dr. Amit Pradhan. I'm a faculty in Tirunelveli University Teaching Hospital. So I'll be speaking today on minimally invasive spine surgery, discectomies, lumbar discectomies at our hospital. Yes, so moving on to the first slide now. So the philosophy, as we all know throughout the talks that have been mentioned in this section, is that minimally the philosophy is of MIS is to reduce tissue trauma, it's to reduce the approach-related morbidity, and as a result improve the recovery while still maintaining efficacy of our patients. So the goals of minimally invasive spine surgery is to maximize the patient outcomes in terms of improving the pain, improving neurological condition, improving the quality of life, and shorten recovery and the rehabilitation. So goals of MIS surgery, spine surgery, is to reduce pain from exposure mainly, reduce the infection rate, hematoma, the CSF leak, and the nerve injury, and reduce the risk of injury to surrounding structures mainly. So we can see with open surgeries, we can see the large incision, detachment, so much detachment of muscles from the spinous process, the lamina, muscle retraction resulting in muscle atrophy, scar tissue, which eventually leads to post-operative instability, bleeding, length of hospital stays increased, rehabilitation period increased, infection is also increased, and most importantly, the pain, post-operative pain is increased. You can see in this MRI done for the same condition for L4, L5 laminotomy and discectomies by the open technique. You can see the muscle on the left side because of the atrophy. You can see the MRI changes. While during the same procedure after MIS discectomy, you can see there's hardly any atrophy of the muscles, paraspines. So there are various results. Some they are towards MIS favoring MIS surgery. Some say there's no obvious advantage. So you can see a paper published here. It did a study of 49 patients underwent MIS and 123 patients underwent open surgery. So there was a statistically significant difference identified in the length of hospital stay. The estimated blood loss was less. The post-operative anesthetic care was less. Narcotic use was less, and a reduced need for the admission to the hospital. Most of the centers that have adopted MIS discectomies here are now doing a daycare surgery, admitting the patient in the morning, discharging them by the evening. So while another study here they did in 2016. So they saw that the time taken to return to work and mean hospital stay was shorter in the MIS as compared to the open technique. The mean duration, the incidence of dural tear and recovery was decreased as compared to the open technique. They have also done a long-term functional and clinical outcome study, which did not support the hypothesized advantage of lumbar discectomy over conventional. So there is still a big controversy over the results of this MIS versus open. Someone did a systematic PubMed review, and they showed that there's a similar safety profiles in between the two procedures. However, there's a strong evidence of decreased rate of infection using MIS surgery versus open surgeries. The procedure is not very complicated, little bit of different, as the incision is given a little bit away from the midline, small incision 1.5 centimeters. If you are doing multiple level discectomies, you can either go with a single level incision, open the fascia widely, or go for multiple facial incisions. Initially, the dilator, the first dilator is usually placed initially through the skin and the facial incision. So the most important thing is that the skin incision may be small, but the facial incisions you have to make it generously. So because the most important, when you're putting the serial dilators inside, you should not force the dilators through. It should go in easily. So the first initial dilator it's like a pencil-like thing. You use it as an extension of your finger to feel the spinous process, base of the spinous process, the lamina. You may feel the facet joints, the superior or the inferior end of the lamina. We detach or sweep the muscles away from it after confirmation of the anatomy by looking at the fluoroscopy. So after that, sequential dilators are placed over the initial dilator right down to the lamina, using a twisting motion to make sure that the complete length or the 4 lines are visualized from above. Most importantly, while doing this, we have to ensure that the dilators are kept parallel to the disc space. And if you have any confusion, you have to rearrange the dilators. You have to make it really perpendicular to the disc space here. So after the dilators are placed, the table adapter and the retractor post are placed, and the tubes are held in position. This is the equipments that is generally required with the serial dilators, the adapter and the clamp, and the tubular dilator here. So with a discectomy, after you have placed the dilator, you use the suction tip to palpate the bony anatomy, both superior and inferior aspects of the lamina. You have to coagulate the muscles carefully using a monopolar, long tip monopolar before removing. You cannot pull on the muscles because once it starts bleeding out here, it's a little difficult to control. So a little bit, usually a small piece of muscle, 2 to 3 millimeter over the area of where you're operating is removed, and the whatever is overhanging into the operative space is shrunk with using the cautery. You should not use a pituitary to pull the muscles off. So after the monopolar removes the soft tissue and the bone is identified, the drill is used. The drill is used initially to thin the lamina. You can see the the ligamentum flavum right through the thinned out bone. And after you have confirmed, we don't use a diamond burr hole here because the ligamentum flavum, we believe that it is there to protect the dural injury with the burr hole. So as long as not very rough, you can actually drill right over the ligament flavum out here. And after the ligament flavum is exposed, you can just pick it up with a thin pituitary and make an incision and use a nerve hook retractor, and then use a kerrison to punch the ligament flavum off. Rest of the story is the same as that of the open discectomies. You look out for the nerve root, retract the nerve root, and use a pituitary or thing to extract the disc. So, so after that, you confirm there's an adequate decompression of what you went in for, achieve a good hemostasis. While withdrawing the tubular retractors, make sure that there's no bleeding points, and a multi-layered closure. Usually just close the, we actually don't even close the muscle. We just close the fascia over that, and a subcuticular suture applied on the skin, and a small, maybe a handiplaster or a G-dress over the wound. So this is a few pictures from our mentors who visit us every year, November, teach us the newer techniques. We have this in the coming November as well. So a few challenges with the minimally invasive discectomy is the first step we do after we delve into this MIS surgery. So after that comes the MIS T-lifts and MIS, sometimes even IDEM tumors can be removed with this technique. So so initially it's the little bit of learning curve is always there in this. They initially maybe 10 cases. A little bit of adapting to the small exposure, getting used to the anatomy of that little bit of little circular area that you see. Initially the time takes a little bit longer, more than 2 hours sometimes. And usually the revision surgeries, we usually don't try to do revision surgeries using MIS because I think we put it up for later on when our experience improves. So most frequent complications is the durotomy, like which we have experienced in one case, and another complications are inadequate decompression, inadequate hemostasis. So how to avoid dural tears? You have to pay very careful attention to anatomical planes. You have to you cannot dissect or use your nerve hooks of areas which you cannot see. Do not use the nerve hook or any other things which is out of your visual circle. So if a dural tear happens to occur while doing MIS discectomies, resist the temptation to make it into an open surgery. That is the biggest mistake we can ever do, because after doing that, you are just creating a passage for the CSF to come outside. So when we have also experienced the same thing. We put a small muscle patch over the durotomy site. Somebody wait for some time. Usually it is so small that it often seals off temporarily. And once you have pulled out the tubular retractors, the muscles fall over it, and it's like a good muscle patch. You usually don't get a problem after that. But if you happen to convert into an open, then the real problem starts. So for a successful initial MIS, always suggested to have a good patient selection. Use adequate fluoroscopy, good positioning of your tubular retractors. We always do the lumbar cases before cervical, posterior cervical cases. Do a unilateral, ipsilateral decompression before trying to approach on the contralateral side. And if you have to do bilateral, you try to use from both the sides, approach from both the sides instead of trying to approach from one side, at least initially. So again, don't try to go in for revision discectomies cases initially. And a single level always before the multiple level, and use and try to look for more thinner patients with a thinner, like the area to traverse should be smaller. And initially use the largest tube. We use the 8x22 tube initially, but I think later on we can decrease the diameter of the tube slowly. And sometimes you can, we've never tried this, but you can actually, when doing open, just put the tube in that place. This is what you're going to see if you do an MIS. But actually, you see that this is actually is the same amount of exposure when you go to the operative site during the MIS or in the open, you're just playing with the same area. Actually, it just looks smaller. So you can see the trend of MIS discectomies at our place since November. It has really picked up, and open discectomies are usually left for the recurrent cases or central central discs. So we did a retrospective small case series. All the patients enrolled for MIS discectomies during the last few months. And the factors that were assessed with the duration of the surgery, complication, the VAS score for the leg and the back pain, the ODI at 1 month, and hospital stay and return to work. So we see that in the last 19 cases that were enrolled for MIS discectomies, we had one complication of the dural tear, which, as I just mentioned, did not have any post-operative problems. Most of the operative time is on an average 2 hours. The VAS scores have significantly reduced at the 1 month. The ODI is significantly reduced from 58 to 15, and the hospital stay was on an average 1.5 days. Return to work is 1 month, but on talking to these patients, they are usually more conservative on getting back to work. So that probably does not give a good idea. So in conclusion, it is a steep learning curve, and MIS techniques for spinal decompression, degenerative spine are safe and effective technique. Complications can be minimized by paying attention to the anatomy. Since you are doing under the microscope, you have to pay attention to the little details. And in future, we plan to do a comparative study with the comparative conventional microdiscectomies as we have adequate number of cases. Yes. Thank you. This is our team.
Thank you, Dr. Amit, for your excellent presentation.
Thank you.
Because of short of time, I can't entertain any question. Next speaker is my co-chair, Dr. Bal Gopal Karamcharia, and he'll talk about unintended durotomy during spinal surgery for degenerative spine disease.
Good afternoon. So I'm going to present our retrospective study result on unintended durotomy during spinal surgery for degenerative spine disease. As you know, the dural injury is one of the most dreaded complications of spine surgery, and it has significant morbidity and sometimes mortality also. Reported incidence in spinal surgery varies from around 1% to up to 10%. And there are different risk factors for it, like age of the patient, experience of the surgeon, complexity of surgery, and pathology for which the surgery is being done. So there are different nomenclatures to describe the dural injury, and sometimes these can have different connotations, like a dural tear, unintended durotomy, incidental durotomy, incidental dural tear, or iatrogenic dural injury. For example, iatrogenic dural injury may tend to incriminate the surgeon that he has done something wrong. So as you know, dura surrounds the spinal cord within the vertebral canal, and it separates the epidural space, which contains fat, and the subarachnoid space containing CSF, and its thickness is around 1 millimeter. The outermost layer of the meninges, so it's a fibrous structure and provides the mechanical support to the cord. The CSF leak following the dural injury can present with postural headache in the postoperative period, can present with radicular pain, sometimes with increased neurological deficit, CSF fistula, pseudomeningocele, and will potentially need revision surgery. And it obviously causes increased prolonged hospital stay and can cause meningitis with mortality. So dural tear is usually underreported in the literature. So in primary lumbar surgery, its incidence is around 3 to 5%, and in revision surgery is around 7 to up to 20%. Risk factors, as I said already, are old age, previous epidural injections. Nowadays, a lot of pain physicians doing the pain injections, smoking, previous surgery, higher lumbar level, scoliosis, kyphoscoliosis, and in the cervical area, the most important risk factor is the OPLL. So this slide is important for the junior colleagues. So whenever you have a dural tear, we have to assess the size and need for extension. We should get things ready like micro instruments, sealants, dural substitutes, and small sutures. We must isolate the durotomy and repair it. And after repair, we must assess for tightness of the repair. And we must be vigilant in the post-operative period for any CSF leak. So primary repair is the best option. It can be done for only small durotomies and intended durotomies that we do intentionally. Usually we use 4 vicryl to repair the dura with small needle, and the suture size should be more than the needle size. This is important. And we must cross the ends when taking bites. Duroplasty can be done for large dural defects with closure with dural substitutes. That may be biological or synthetic, that may be autologous or heterologous. We can use the fascia or G-patch, and must be reinforced with the sealant and fat graft to obliterate the dead space. These are different sealants that are available with us. And we usually tend to put the subarachnoid drain to reduce the pressure in the subarachnoid space. Usually we place this for 3 to 5 days with success rate of 85 to 95%. However, it can have its own complications like overdrainage, pneumocephalus, meningitis, and we must give antibiotics for the duration of the subarachnoid drain placement. It's the 10-step closure technique described by Papa Bero. So this mnemonic is Bordeaux MD. So we must remove the bone remove the bone until the whole of the durotomy is seen. We must have a look for interdural look, repose the fibers if there are any fibers coming out from the durotomy. We should do an inside pass if necessary and do the meticulous dural closure. And that should be supported by the outside patch. And our closure strength should be always checked with the Valsalva maneuver. And if there is a large dead space, then it should be covered with the epidural pedicle muscle flap. We must do the multi-layer closure and do the drainage of the CSF if necessary. And the poor factors that lead to poor healing of the dura are the large defects, poor overlying soft tissue coverage, infection, poor nutrition, use of steroids, and elevated CSF pressure. So usually what we do is we try always for the primary closure, and for duroplasty cases we use the fat graft. We always use the lumbar subarachnoid drain, do the multi-layer closure, and put the compression bandage, and keep the patient head down for lumbar cases with prone lateral position and head up for cervical cases for 3 to 5 days. And we remove the drain on 5th day. So this is our retrospective study of degenerative back with Dana Milson. Back. Yeah, so this series only includes the degenerative spine disease, cervical, thoracic, and thoracolumbar. The CSF leaks that were identified intraoperatively or postoperatively because of CSF leak. This is based only on the operation records and clinical notes and discharge sheet. This series includes the cervical spine, 83 cases, in which we had 6 cases of CSF leak. So our dural tear incidence was around 7.22%. And for thoracolumbar cases, we had 136 cases and 8 cases of CSF leak. So with around 5.5% of the incidence, and in total, it's around 6.39%. So intraoperative, only one case of the patient had the postoperative identification. So in summary, as neurosurgeons, we will have dural tear, whether we like it or not. We must anticipate, especially in patients with risk factors, and be prepared for it in every case that we perform. We must be meticulous in closure, and we must be suspicious in postoperative period. Thank you.
Thank you, Dr. Balgopal, for your excellent presentation. We'll take all the questions during tea time. And with this, we end with this session. I thank all the speakers and the audience for their excellent presentation and active participation. Thanks, everybody.
Thank you.
Thank you, doctors, for the talk on very innovative topics. Our next session is called How I Do It. May I humbly request the honor of having Dr. Rajiv Jha and Dr. Rajendra Shrestha to kindly moderate this session. Also, as we are far behind the schedule, I would like to request the respected moderators to entertain the question, to ask the presenters to entertain the question of the audience during the tea break time. Thank you.
Yeah, we are running very late of the time. So my co-chair, Dr. Rajendra Shrestha, please convey the message. Someone. I would like to invite Dr. Atilia Ilmaz, and he's talking on double target DBS technique for tremor treatment.
Dear Mr. Chairman, first of all, I would like to thank to Dr. Basant and Dr. Sudan for their kind invitation. And I would like to congratulate the organization committee for such this successful Congress. It's a pleasure to be here. Namaste and good afternoon. Today, we will talk about the double target in tremor treatments. The VIM, the thalamus, is mostly preferred area for stimulation, actually not stimulation, inhibition of tremor. But in severe tremor, especially like proximal tremor, like Holmes tremor, traumatic Holmes tremor, or other rare seen but severe tremors, you cannot fight against such these severe tremors with VIM stimulation because the internal capsule is directly lateral of the thalamus. And if you go to the higher voltage, you may affect the internal capsule with the result of the side effect. I can talk hours, but I'm waiting the slides. So in such disease, in such circumstances, you can add the posterior subthalamic area as a second target, and you can share the voltage between two targets to fight against the severe tremor types, like a Holmes tremor, like a rare scene types, like a tremor types, like a voice tremor or head tremor. The PSA, the posterior subthalamic area, mostly has the fiber tracts which responsible from the proximal muscles. Because of this, these proximal tremors, the PSA is more effective than VIM. Actually, there is no need to discuss which one is better, the PSA or VIM. We can use both of them together in one electrode.
Excuse me, Dr. Ilmaz. I think we have to wait for your presentation for a while. As your presentation is not there, they are uploading now. So can we do it later? I would like to invite next speaker.
Okay.
Sorry for that.
Okay.
So next speaker, I would like to invite Dr. Basanta Pantha, and he will be talking on amygdalohypocampectomy.
Action rolls. Thank you very much, Mr. Chairman. Today, I would like to talk about the amygdalohypocampectomy, temporal lobectomy, which is the most common surgery that we do for epilepsy surgery. And if you can master this technique, then you can go on to, a more difficult sort of techniques. And this is a 7.5 minute video. The time allocated for me is 10 minutes, so I can have 2.5 minutes for discussion. Can you run the video, please? Please run the video. Please run the video. So this is the positioning where you put the patient in. This is a left-sided surgery, a flat, a question mark incision is done of, usual frontotemporal craniotomy is made a little bit posterior to the usual frontotemporal craniotomy. And this is, usual temporal muscle dissection. And this is important. Here you can see that the zygoma is well exposed, and you go to the base of the temporal lobe as much as possible. Once the brain is exposed, you start doing ECOG, and then the whole of the team is concentrated on the EEG machine. And then we start marking. Like here, I have marked the superior temporal gyrus is very silent on this. So there is no epileptic activity from superior temporal gyrus. So we can just leave it behind. Then we go and do the medial inferior temporal gyrus recording. Like medial temporal, there's a lot of firing from medial temporal. The upper one is the bipolar, the lower one is unipolar. Posterior temporal limit up to where you are going to cut, you need to demarcate like this. So this is the posterior demarcation, which is about 4 centimeter in the left side. And now you go to the base of the temporal lobe in the inferior temporal area. And again, you can see now I am, from the tip of the temporal lobe, I'm cutting, demarcating 4 centimeter. And the surgery, temporal lobectomy for epilepsy surgery should be fine. It should not be a very rough kind of surgery, just like for tumor surgery. So it has to be, since it's a functional surgery, you cannot give additional deficit. So the sylvian vein should be preserved at any cost, and all the dissection and removal of the temporal lobe is done within the arachnoid plane. So all the time you remain within the arachnoid plane of the sylvian fissa. And then first the lateral temporal structures are removed. And just by, suction and dissection. So once you have cut the lateral temporal structure, then you see the base of the, temporal lobe, the tent. And then now you start deskeletizing the hippocampus. The hippocampus is somewhere around here. Somewhere around here. So you deskeletize the hippocampus here and here so that it is, exposed like this in the center. And you have to presume, you have to always mentally calculate where the hippocampus is. Now I have removed all the, brain tissue around the hippocampus, and now I can expose the temporal horn of the, so like this. So you can see that, you should presume that the hippocampus is, now you can just expose it just like this and expose. So this is the hippocampus here, and this is the amygdala, and that is the fissure between the hippocampus and the amygdala. And then we record the hippocampus with a hippocampal head lead, and where you can see a lot of abnormality. A lot of firing is there from the hippocampus. So this is the main source of the seizure. We are confirmed now. Now we know that this patient is going to be cured. And then we revert the lead and put it on the amygdala. And the amygdala is pretty silent here. So actually, if you want to leave behind amygdala, you can leave behind the amygdala. So once you have done this and exactly, you have demarcated where the epilepsy is coming from, and now you can start resecting the hippocampus. So the third step is to record the body and the tail of hippocampus by a special lead which can go into the tail. And then now remove the head and the body of the hippocampus and amygdala in this case. Most of the time, we don't leave amygdala behind, we remove it. So now, to see the completeness, again, the tail is being recorded here, and you can see that it's silent. So now the rest of the hippocampus is removed. You know that there is no more firing from the hippocampus anymore, you know. So once you reach the medial structure, you have to remove the parahippocampal gyrus and the uncus. All this should be removed. And this part you have to be very, very gentle and meticulous because you are pretty close to the brainstem and pretty close to the third nerve and pretty close to posterior communicating artery. So this part, you have to strictly maintain the arachnoid plane all the time and be very, very gentle at this stage and don't go beyond the arachnoid plane. So here you can see the free edge of the tent. And still there is some uncus left. So you should not leave uncus behind because you can still have an unconvolution after temporal lobectomy because of the pressure effect. So you cannot leave it behind. You have to remove everything. So now you can see that the third nerve is being seen on the left upper region, and that's the brainstem that you can see. So this is the time you should stop. But you have to remove everything completely, just like this. Very meticulous. Initially, you can be rough, but once you go deeper, you have to be very, very meticulous. Thank you very much. I have 2 minutes left if you have any question.
Yeah, one minute left. So what is the advantage of this subtemporal over transgyral or transsulcal approach?
So that is selective amygdalohippocambectomy you are talking about. We did few cases of selective amygdalohippocambectomy without removing the lateral structures. And in 2 out of 3 cases, we have recurrence. So I think our study of EEG is still not that better, you know. So we prefer to remove everything rather than doing a selective amygdalohippocambectomy.
Is there any advantage of doing this transcortical instead of doing it transsylvian?
No, it's the same thing. I think Dr.
He's
Raj-
talking about transsulcal, transgyral, but I'm talking about doing it transsylvian.
Yeah, but
not cutting the lateral temporal side.
Since we are removing the lateral structure, we are not doing selective amygdalohippocambectomy. If we are doing selective amygdalohippocambectomy, there are different approaches, like Yasserjil's approach, where you can go and take out the amygdala hippocampus only. But I'm not an advocate of that. And if there is a hippocampal firing, then lateral temporal structure is already gone. And most of the time, we leave the superior temporal gyrus on left side, so speech is not an issue. The only issue is memory. So if you suspect that most of the time the hippocampus that is diseased, there is no memory there, so you can just take it out. But if you are really worried about that, then you should do a water test for memory and then see whether the other side of the temporal lobe support memory or not.
Thank you, Dr. Panta. Now I would like to re-invite Dr. Ilmaz. Probably his presentation is ready now. Welcome again, sir.
Thank you. Yeah, I think everything is ready right now. This is my disclosure. I'm working as a neurosurgeon in a neuromodulation center and I'm doing only neuromodulation surgeries, mostly the DBS. We will speak about the essential tremor, and as you know, the most common movement disorder is an essential tremor, and unfortunately, 50% of the patients have significant disability and loss of workforce. Widely accepted theories, the tremor caused by abnormal activity of basal ganglia, thalamocortical or cerebello-thalamocortical loops. As I said, the brain stimulation, the thalamus is a well-established approach for tremor treatment. But in severe tremor types like Holmes tremor, dystonic tremors, cerebellar tremor, traumatic tremors, it's difficult to manage it by medication or thalamic stimulation. The Holmes tremor is a low frequency and high amplitude type of tremor. Very, very different from the essential tremor. Essential tremor is a high frequency, low amplitude, but the Holmes is a low frequency, but high amplitude tremor. And the Holmes tremor can affect the proximal and distal parts of the extremities, and mostly seen with the lesion of the red nucleus or nigrostriatal or cerebello-thalamic, cerebello-olivar pathways. So recent studies showing a promising about the PSA effect on proximal tremor types. In fact, there are some important things to support this hypothesis, because as I said, the proximal muscles responsible tracts more dispense, more condense in posterior subthalamic area. Such these, is there any pointer? No, okay. Such these tracts more condense than PSA, the posterior subthalamic area. But what is the posterior subthalamic area? The posterior subthalamic area actually is not a nucleus. It's an anatomical area, and it's first defined in 1960 by Wertheimer and his friends. It's covered by red nucleus, subthalamic nucleus, internal capsule, and substantia nigra. And the posterior subthalamic area contents is caudal zona incerta, prelemniscal radiatio, cerebello-thalamic afferent fibers, and mesencephalic pericardial formation. And the caudal zona incerta consists of cerebello-thalamic cortical loop, dentado-thalamic cortical loop. As you see, the old tremor pathways is so condensed like a junction in posterior subthalamic area. Recently, there are increased number of published papers, especially about the PSA stimulation. Also, PSA is located just below the VIM. So in some papers, they are suggesting to use the most bottom contacts for get a most beneficial effect. Actually, they are mentioning about the PSA. The PSA advantage is better than indirect atlas targeting because you can calculate the real PSA, not estimate like an atlas target for VIM. It's far from capsule, and it's a junction point, so effective. But there is no need to discuss which one is better, VIM or PSA, because we can stimulate both of them together with one. The VIM height is approximately 8 millimeters, and the PSA is just below 4 millimeters below of the mid-commissural point. So if we have a 12 millimeters electrodes, it's enough to stimulate both of them with one electrode. It's 3387 Medtronic or Shinray electrode is a 1.5 millimeters distances between two contacts is enough for 12 millimeters electrodes. How we need to target the PSA? First, we need to find the lateral border of the red nucleus and then find the medial border of the STM. The distances between the lateral border of the red nucleus and medial border of the STM, 1/3 medial from the medial border of the STM is a target of PSA. This is the CPP line, which going from the midline of the red nucleus. And then I'm finding the medial border of the STN and lateral border of the red nucleus, calculate the distance, and 1/3 medial is the target. After I decide the target about the PSA, I need to target the VIM by the atlas, of course, but we need to deform the atlas values by the patient's brain. Look, this is the VIM target. And how the VIM? This is the VIM target, but this is the PSA target. If I go, as you see, one a little bit lateral and a little bit posterior, I can pass the VIM when I'm going to PSA. This is the target method. In another planning station, I mean, the PSA is below the VIM. First, target the PSA, and then try to change your trajectory to pass, to go throughout the VIM when you're going to do PSA. You can do this technique in approximately 80 or 90% of the patients. But if the patient's third ventricle is so wide, you need to go too much lateral to pass both of them. In some patients, you cannot do the both of the targeting in one electrode, but most of the patients you can do. What are the advantages of using the double target? When you do the double target, you can share the currency between the two targets. And so instead to go to higher voltage in one electrode in VIM to have a side effect, you can share between the VIM and PSA. And you can prevent the habituation. You can start with VIM, and after several years, you can add the PSA, or vice versa. And you can compare the effect of between these two electrodes. Only PSA, only VIM, but share currency. What is the PSA disadvantage? You cannot use the MER because it's a white matter. And maybe you can use the last point of the thalamus, and maybe you can use the impedances evaluation. This is the head tremor patients. Isolated head tremor is so rare seen pathology. In head tremor, the VIM, the effect of the VIM, you cannot find a lot of papers about it. But this is the postoperative, only 3 days postoperatively, videos of the same patients. He has some dystonic components too. And this is the 4 years later. Still no any tremor, but I'm using the double stimulation for this target. This is another sample. It's not recorded on my center since I'm pioneering too much center in our country, actually in all over the world. It's recorded in another university. We did this surgery in another university. She has a multiple sclerosis disease, and she has a secondary to multiple sclerosis, severe forms tremor. I wish to move forward the video, but there is no mouse because of this. I cannot move it forward. Not to pass, move it forward. Not to pass, move it forward. Okay, we can see when the stimulation on and when the stimulation off the same patient. This is the 1 year later of the surgery. See, this disease, unfortunately, we cannot cure the multiple sclerosis, but we can give the patients a comfortable, more quality life. You cannot deal with this severe tremor only with one target. Our aim is not to support her to drink as hot coffee, but to support her to eat a bread independently. Okay, another patient's videos we have, but it didn't work, unfortunately, when we're testing. It's a traumatic host tremor, unilaterally left side. This is from our hospital operating theater. Now the stimulating on, and after a few seconds, the stimulation will go to the off situation, and you will see the severe Holmes tremor. Actually, the first video was the tremor video, but it didn't work. I don't know in this computer. I don't know what is the problem. Now it's closed, as you see. DBS is an effective treatment, but in proximal tremor, severe tremor, please use the PSA and you can use the both of them together. No need to change. Select one of them. This year we held a cadaver course, and next year in May we will repeat it, and we would like to very happy to see you with this course. Thank you so much.
Thank you. Thank you.
Let me call Nation Chairman Dr. Praveen Shrestha to present his case.
Good afternoon and namaste. Well, I'm going to make this very, very simple presentation and probably relatively shorter also. I'm not going to explain details of surgical techniques. I'm also not going into the details of series and outcomes and all that. But what I'm going to deal with is simple explanation about different materials that are used for the purpose of fusion and fixation of the in the surgical management of the hernia subcervical disc. Well, as you know, so there are several techniques for the cervical disc surgery. ACTF is the most common one. That is what I have been practicing, and probably most of you are also practicing the same with fixation or fusion. Simple ACT is another technique. I don't know how many of us are doing it. I'm not doing it. Similarly, posterior approach, laminectomy or laminoplasty for the multi-level disc herniation leading to severe spinal canal stenosis, and sometimes posterior discectomy for lateral or paralateral cervical disc herniation. And for the sake of fusion and fixation, we use different materials like bone graft, autograft. This has already been old technique in case of cervical discectomy and fusion. So I have almost stopped using bone graft probably many years, 10, 12 years back. Instead, there are several other materials or grafts like plates and screws, bone cement, mesh cage or expandable cage, simple anterior cervical cage, titanium or PICC, standalone cage, titanium PICC, and then artificial disc. Well, these are the different materials. They are available in the market in Nepal, except for the artificial disc. Almost all are available, and many of us have been using one of these several implants for the sake of fusion or fixation in cervical disc surgery. Well, regarding my experience, this is bone graft fusion in case of cervical discectomy. After discectomy, fusion with bone graft, which is rarely done these days. Similar, this is bone cement. Bone cement is very common in Nepal. Many of us have been using this bone cement fixation in case of cervical disc surgery. I also like this technique very much. I like bone cement. I also have very good experience of using this bone cement fixation, more than 100 cases. This is just example of, you can see bone cement fixation. This is another case of bone cement fixation without any spinal motion limitation or any instability after surgery, after discectomy. This is another case, recurrent case in young female. As you can see, there is at the level of 5-6. There is the X-ray. There is the before surgery, and see this lady was already operated several years back by other surgeon, but she had recurrence of disc and recurrence of severe radiculopathy. Not only at that level, even in the one level above, she had lateral disc leading to severe radiculopathy. So in this case also, we did same kind of bone cement fixation at 2 level, and since this was a second surgery, we did fixation with the help of plate and screw as well. And similarly, this is another case. Then till I don't know, till about 10 or 12 years back, there was no titanium case available in Nepal. But later it became available. But that time also there were limited shape and size of the titanium case like that. So in this case, titanium case was a little bit bigger size, and again we have to go for the bone cement instead of this case because of the size disparity. And then in Nepal came this kind of the titanium case with different varieties of size and shapes. This is a traumatic case of 2-level disc herniation. So I had to do a 2-level discectomy and then fusion fixation with the help of this appropriate size of titanium cage and the plates and screw. Then in Nepal came another type of the case, that is standalone case made of titanium again. Again, in this case, we did fixation with the help of titanium standalone cage after the discectomy. Then in Nepalese market came another type of disc. This implant that is again standalone case, but this one is a PIC standalone case. So as you can see, the PIC is radio translucent, so it can be seen in the X-ray, but the screws are titanium. So I have so that you can see the screws in the X-ray. So according to this our experience, what I think is in the market we have been using in our own experience we have been using these various types of implants ranging from bone graft, ranging from bone cement to all different kinds of cases and this standalone case, except for the artificial disc which is not available in Nepal, I think. So all implants and grafts are different from each other. All the implants have plus and minus, pros and cons, merits and demerits. So some are very, very cheap, like bone cement, it hardly costs any money. Whereas this standalone case PIC, it is very expensive, probably costs more than 50,000 rupees for a single piece. So there are lots of disparity between all these implants. And whenever we use these types of implants, then we should inform patient properly regarding all these merits and demerits of these various kinds of implants. So in conclusion, what I'd like to say is wide varieties of metals are available in market. Which one to choose and which one not to choose, I don't know, but it depends on case by case. It depends on your own experience. It depends on your own expertise. Technology is always changing, and we cannot stick to only one technology. And we should catch up with the newer technologies as far as possible. But of course, old techniques are also equally good. Bone graft may still be good in many cases, especially traumatic cases. Bone cement is no doubt very good, but it may have some demerits. The newer technologies are very good, flexible, elastic, more weight-bearing capacities, but very, very expensive. So we have to choose the best among all those. We have to choose case by case. We have to choose the most appropriate one according to the affordability of the patient, according to the case types of disc herniation, and according to your own choice. Thank you. Thank you very much.
Congratulations, Nation Chairman, for the nice presentation. If any query from the audience, please.
Thank you, Dr. Praveen. We'll move to the next speaker. Dr. Yambadur Roka, he will be talking on a televelar approach.
Thank you. Sorry. Good afternoon, everybody. So basically, before we go to the talk itself, you have to understand anatomy with the posterior fossa, because posterior fossa surgery is quite common, and I think almost all of us are doing it. So basically, the port is basically a tent-shaped structure with the base facing forward. You have to understand is like this. The floor is formed by the pons and the medulla, and the roof is by the superior cerebral peduncle along with the superior medial velum, and inferiorly about the inferior medial velum along with the tela choroidea. Go back to first lumbar. No, start. Yeah, okay, fine, thank you. So since the time is short, I'll just go briefly regarding the anatomy also. These are same thing repetition, okay? But superiorly, as you can see, is formed with the superior medial velum, and inferiorly is the tinea corridor, which is the anatomical landmark through which you'll be accessing this surgery. So basically, fourth ventricle tumors are classically opened by either by the midline vermis. That's a classical approach. But that led to a number of cases of mutism and posterior fossa syndrome and neurocognitive deficits. So with that in mind, this new approach was first conceived and described first in cadavers and then practically also by Musri and Roton in 2000. So basically, it's a new type of approach. Unlike the posterior fossa other surgery, which is there for many decades, this has been there only for the last 20 decades. And when we started, in fact, most of the senior doctor surgeons, when they started, it would have been maybe 6 or 7 years old, this approach. So the advantage is that you are basically, what you're doing is you're displacing the tonsils laterally to expose the tela choroidea and the inferior medial velum, through which you'll be approaching and then going across inside and removing the tumor. So this leads to the access to the floor and the body of the ventricle, and there is no involvement of the vermis, and you can do it either by one side or both sides. So as soon as you reach the velum, then you have to go inside, and then you reach the roof of the ventricle, the fastigium, and then including the superlateral recess. And elevate, then slowly you have to elevate the tonsillar further away from the medulla, and then expose the lateral recess. Okay, there has been few studies regarding resection and tonsillar retraction. What is the advantage? But briefly, it is to state that resection is better for lateral recess, and if there is a horizontal angle to the aqueduct. Otherwise, retraction will be same. So this is the anatomical direction, which is first described by Roton in his anatomical, book, which I'm sure many of us are familiar. The important landmark over here, the most important is, of course, the pica, which will be showing us and guiding us along how to go reach the talia choroidae and the other structures. So this is the same, after the elevation of the tonsil, you can see the talia choroidae, the number 7 over there. This is a vein-like structure, very thin structure, which is avascular. You can just cut it across and then go directly inside to the tumor. But this is approach. Basically, the tumor resection part is classically the same. You have to debulk the tumor, take it out, do the hemostasis using by direct coagulation or CUSA, whatever technology you have. But this is what we are talking about, is the access and the approach to the tumor. So once you do that, at the final end, you will see the aqueduct, the colliculi and stimularies. In fact, I'll be showing some pictures where you can see the third ventricle and even the fornix. So the surgical step is basically as per any posterior fossa tumor is supine. If the child is less than 2 years, do not use head pins. Midline, occipital cervical incision. And classically nowadays, I use a V-shaped flap on the top, so that while closure is very easy and there's less chance of CSF leakage. This is the position. I use a YASAG Sugita head clamp in all my cases. So this is the pictorial diagram, and you can see the picture on the lower left side. You can see the V-shaped, the fascia which has been cut in a V-shape. The incision is midline, but fascia you cut in a V-shape. In that sense, you can approximate and close the muscles, and there is very less chance of CSF leakage post-op. There's a resection amount of bone which has to be removed, and compared to the midline classical, craniotomy or craniectomy, whichever you prefer, the incision, the bone size is very small in this case. So this is the classical description which has been given for craniotomy and the dual incision V-shape based at the occipitocervical junction. But if you're using this talovelar approach, you can also go for a curvilinear or a C-shape incision, which is equally good enough. Plus, it has got the advantage that you can close it properly without, easier without CSF leakage post-operatively. So once you incise the dura, that's the time when you bring in the microscope, and then you see the structures on the microscope. Okay, these are the very classical diagrams which you have to go through to understand this. So the vermis on the left side, vermis is always in the midline, so you don't have to do anything to it. As I said, tumor tissue has to be debulked and removed. But what I'll be showing is basically the approach to it. This is a post-op suture. So basically, we have got 13 cases which were done by this approach alone, and not other cases. So most of them are medulloblastomas. This is a classical example. You can see there's a huge tumor over there. And on the case of ependymoma, these are quite plexus papilloma. In fact, there are quite a few number of them. One of them below also. And case illustration, I'll just give through. 2-year male vomiting for 2 months, lethargy, unresponsive to commands. This is the MRI. You can see there's a huge tumor over there, very vascular. So this is a craniotomy. You can, as I said, you can do a small craniotomy, and the classical incision is the Y-shape. But in this case, you can also go for a C-shaped, especially if you are doing for the lower part of the, either the tumor is low lying or lower areas. So this is the view on the dural opening. There's a tonsil. So that's the first thing you will be seeing on the posterior fossa tumor. You will see the tonsil, the cerebellum, the left side, and the vermis. So once you open that, then you go to the next step. You slip the adenoid, remove the CSF, and then you start lifting the tonsil upwards. So once you lift the tonsil upwards, below that you will see the vessels plus the talovelar membrane will be seen. So that membrane has to split open, and that will give you greater visualization and the, path of the pica will be visualized. So you keep on retracting the, elevating the tonsil. As you can see, this is a unilateral approach. Normally you would have gone through the vermis and reached both sides, but this side you have to go, you go to unilateral approach. You see the pica, then trace it upwards. You have to make sure that you don't damage it, protrude or touch it or any instance. Then you keep on elevating the tonsil. Then you will localize the uvular tonsillar space and follow it infilly to the medial tonsillar space. So further, as I said, the anatomy has to be, you have to be very clear with the anatomy. So you have to do repeated studies of the, especially Roton's classical paper and the anatomical description which was given. So this is a diagrammatic view again. The first step, as you see, you have to localize the cerebellar medullary fissure, then elevate the tonsils, then reach the tela choroidae and extend it into the talovelar junction and go all on both sides. Simultaneously, at the same time, you will be seeing the tumor which will be overhanging and it will trying to obstruct your view. In that case, you have to debulk the tumor, because just barely lifting it up won't be accessing to the deeper part of the tumor. So you have to debulk the tumor, remove the superficial lateral part and the deeper part, and keep on going inside. As you remove the tumor, there will be more and more relaxation, and the tonsillar and the velar member will be lifted more and more upwards. The video is not playing yesterday. So once you reach that, you reach the pterygochoroidae, and simultaneously you reach the floor of the fourth ventricle, and you can see the orbix. You keep a cottonoid on the floor of the fourth ventricle. You keep on going upwards. Keep on debulking the tumor, hemostasis, debulking hemostasis, and simultaneously you will have lifted the tonsil so much back upwards. You'll have a very clear view. So this is, you'll have the view of the aqueduct, and once you remove all of the tumor, for one side itself, you'll have access to you would have almost reached, the aqueduct. You'll see the supramedullary medullary velum and the cerebral peduncle. This is looking to you like a roof shaped person. And finally, you can even reach up, since in this case the aqueduct, especially if there's a lot, the aqueduct is like doing endoscopic view. You can, through the aqueduct itself, you can see the fornix, you can see the cortexes of the lateral ventricle and third ventricle also. So basically what you have done is, as I'm repeating again, is you go through the anatomy, you have to go through the anatomy, lift the tonsil, localize the pica, reach the talovelar membrane, remove the talovelar membrane, keep on going deep, keep on debulking also. It's not because, you have to debulk. Keep on debulking. The moment you debulk, you'll have more and more space, and basically you'll be going from above to below. Basically you're going below, but in this case, like in the classical case, you're going more of a, superior to inferior direction. In this case, you're going from below and superiorly. So you'll be remove the tumor, going upwards, remove the tumor, keep on latrating, remove the tela choroidae, so that all of the tumor is removed. And as classically, if you see, you can even go up and see, the upper anatomical features. And there's the baby, and there's this thing. And of course, complications, just briefly, because it's very important for all of us to know. Hydrocephalus and vipation is very important. You have to, shunting is maybe required in 20% of cases, and EBD may be required. Cerebral mutism is also very common, which is very sometimes difficult to explain to the patients, because post-op scan, everything is normal, but the child is not doing. So there will be a lot of questions as to why. Basically, is the injury to the pathways which are connecting the medial and superior cerebral peduncles. So there shouldn't be too much reduction, too much retraction, and there shouldn't be too much cautery to be used. Like doing surgery for craniopharyngioma is all. You should use the minimum of cautery, because most of these medulloblastomas and all, they are suckable tumors. And pneumocephalus also is another thing. There too much vigorous, drainage of the CSF can lead to.
Please conclude your presentation.
And meningocele. So basically, two underwent BP shunt. One had a severely improved. One case had permanent paraparesis at 3 months. There was no cause to be seen because MRI was normal, and 2 delayed after this radiotherapy, chemotherapy. So basically, it's an alternative approach. But once you master it, it becomes the main approach. And displacing the tonsils, expose the tela choroidae and the inferior medullary verum, and but the limitation is the deep rostral attachment, which is uppermost part. That is the sole limitation of this tumor. Otherwise, with this approach, you can remove almost any size of tumor in the posterior fossa. Thank you very much.
No questions.
Thank you.
Our next speaker, Professor Amit Thapa, he will be talking on robotic placement of EVD in a slit ventricle.
Can I have my slides, please? Thank you, chairpersons. Well, I kept this topic because this is a technique by which even a resident or a trainee can put an EVD in a very slit-like ventricle using a robot. It's a new use of a robot which we are recommending, and we have found its advantages. So there is nothing commercial. In fact, this machine which you're using is only for demonstration purpose. Okay, so ventricles or the slit-like ventricles on imaging as basically seen in either severely raised ICP, which may be a result of a traumatic brain injury or malignant infarction, or could be because as a complication of a slit ventricle syndrome, which we all aware of. In this talk, we will be much more focusing upon where we use to measure the ICP. Why? Because it is both diagnostic and therapeutic in these cases. Well, intraventricular placement of an EVD has been considered as a gold standard, not just because it can measure an ICP better, but also it can help you to decrease the ICP whenever the ICP is very much raised. And it is invariably not only in the adults, but also in the kids in various studies. We usually use anatomical landmarks to place an EVD. The benefit of using an IGS or image guidance system is that it improves the accuracy by almost double. And the studies have shown in that, and particularly in those cases where the Evans index is less than 0.36, there is highly significant correlation of an accuracy of EVD placement using an IGS system. On top of the IGS or image guidance, if you use a robot, the benefit is that it's not only a precise location, but also real-time visualization as to where your lead is going in the image, the feedback you get as you're going inside the track, which is monitored, and the robotic movement, which is very precise movement, adds on to it. You can retrace the pathway for any presence of vessel in the pathway. So that's why the chances of intracranial bleed during your blind insertion of EDVD is much more less. And also it assures minimum cortical damage. A similar report has been published by All Indian Institute of Medical Sciences, New Delhi, where they use a ROSA robot for the same thing. In Kathmandu Medical College, we're the first one to use robots. Well, we got the robot for SEEG placement and for the uses, but then we also found that this robot is useful for putting an EVD in a very slit-like ventricles. So the operative steps are enumerated here. I will be going one by one in each of them. First of all, definitely is to understand the need of indication. Like in this case, he was basically a left-sided MCA territory infarction. This patient was aphasic at presentation, and we found that the patient is becoming drowsy. On a repeater scan, we did see that the patient infarcted brain has started swelling. So he was supposed to be put on an ICP monitor so as we can actually avoid the decompensationectomy if in case it can be managed just by mannitol or some other ICP reducing methods. So we embarked on identifying the site of the target of putting an EVD. So the idea is to put EVD in the dilated ventricle. At least 2.5 millimeter will be good enough to put an EVD inside it. And whenever we are using this system, we always go for an probes eye view to see for that we are actually pushing the EVD through the cortical surface rather than any sulcus. And we are trying to avoid any sulcus during the pathway. So that we are not damaging the sulcal vessels as we are going inside the ventricle. Then we register the patient to the machine, and then we like to keep the accuracy to a less than 2 at least. More than 2 is not at all acceptable in these cases. And then we have a set of robotic instrumentation set to tag a robot to the patient's machine. So this is how we drape the patient with a sterile cover, and this is the robot we have. It has been draped in a sterile fashion. This procedure can be done both under local and GA. And in this patient, since we thought that the patient may undergo a decompensationectomy, so to save time, we intubated the patient and went ahead with the procedure. So we actually tagged the robot to the machine now. So the robot is being brought to the place of interest. So you could see those blue buttons onto the robotic head. And one of the tech person is holding the remote. So the tech person is going to switch on the combination of set by which the robot will move to its final position. And when it reaches its final position, the button will go into a in position record so that you see the circle, a dot inside a circle. That means you are now in location in the target. And then since we have already identified the depth, we know how much depth we can go in. Now we use a specialized drill to punch a small pinhole inside the skull so that we can measure the diameter of the skull and can fix the diameter, the depth onto this particular drill head. And then we can actually punch in a small 4 millimeter pinhole into the skull. So this is how it has been done. So we are actually marking that particular depth onto the tool. And then just inside that particular robotic holder, we are punching a hole, and the same drill can actually pierce a hole inside the dura. Now, use of the EVD in the Surgiware company itself, we have two types of EVD which is available: 2.5 millimeter diameter and 3.5 millimeter diameter. You have to be assuring the diameter before you place the EVD, because 3.5 millimeter diameter is a big one. So 2.5 millimeter serves the purpose. And then there are two techniques of placing an EVD. Either you can push in with a shunt passer, which has basically two tracing clients on its head. So in this particular method, since the clients are there on the tracker, you can actually see the pathway where the tracker is actually going on. And meanwhile, we always keep it sure that the dot inside the circle remains. Whenever the robot moves because of the manual handling, this particular thing can get changed. And then we can actually see, so there's the green circle tells us that we are inside the track itself. The red means we have already moved out of the track. So if in case that's to be a case, we have to again realign it. The second technique is to mark the depth of the EVD tip on the machine, on the tube itself. And then once you have marked it, you can immediately go inside that particular track, which you already have defined on the image. And as you go in, you can see that the CSF is gushing out with a force. So this thing has to be done millimeter by millimeter, just like you put an SEEG electrode. So you go very minuscule method and see the CSF is coming out. So we block it because we do not want the CSF to go out. We want to measure the ICP. So one of the assistant will hold the tube as we are removing the robot. And then this particular tube can come out through a tunnel. And then at the same setting, you can measure the ICP, can go ahead with the closure and then fixation of the EVD. So this is a very simple technique, which can be done with a few training by even a junior plus residents or by these very junior consultants on duty, and does not embark a lot of equipments. Since the second method even does not use too much of consumable. So that the cost of consumable is dramatically decreased, only that the cost of initial investment is high to buy a robot. And then additional time which is required to register the patient to the machine is also decreased if in case one keeps on doing this procedure times and again. There are definitely some apprehensions or the risk which may be concerned, like plunging, infection, optical blind outs when the machine is not in front of is not been seen, and then object registration delays and navigation errors. But then these all can be overcome by training and the repeated uses. So to conclude, neurosurgical navigation system improves surgical accuracy. There's a high intraoperative tracking system actually superimposed with the 3D position and orientation of the surgical tool on the preoperative images, helps us to make this robotic system automatically safer, faster, and far less invasive than current surgical procedure. Thank you.
Thank you, Professor Amit Thapa. Now let me call Professor Rajiv Jha to present clipping supraclear aneurysm.
Good afternoon. Slides, please. So the task given to me is regarding how I do it. And the topic given to me was regarding clipping of the supraclinoid aneurysm. Next slide, please. So aneurysm surgery, probably one of the most interesting and challenging surgery. And see, anatomy is necessity for all the surgeries. And same principle applies for any vascular surgeries too. So regarding the ICA anatomy, ICA aneurysm, you have to first know in detail about the anatomy, different segments and different branches of the ICA. You have to clearly know when to drill ACP or when not to. So it all depends upon the knowledge you have acquired prior to surgeries. To have this excellent knowledge, you need to spend time to look the anatomy which you see in angiogram or CT scan or MRI. So these are the basic things required for any aneurysm and supraclinoid aneurysm, you have to look CT scan. You have to see Miller Fisher grading and distribution of the blood or presence of any clot. And MRI has very important role, especially at least in IC aneurysm, because usually the IC aneurysm are the commonest aneurysm, are the simplest to do, and usually they are bigger size compared to the other location. And these are the aneurysm which are usually thrombosed. So you don't appreciate the thrombosed part in angiogram. So MRI is strongly advised to do. And definitely DSA is the gold standard. And by looking at the angiogram, you have to know, and this is the morphology you need to know, like vessel of origin, the size, shape, and size of the neck, size of the dome, and neck-dome ratio, and relationship to the parent and adjacent vessels. See, this anatomy you need to know, because when they are displaced, you have to think that there is something is there, either clot or the size of the aneurysm is big. It's thrombosed. So presence and location of the vasospasm, and as discussed, I said adjacent vessel displacement and presence of other aneurysm. And prior to surgery, if brain is relaxed, you don't need to start osmotherapy. If majority of the time, I mean, all the patients are subarachnoid hemorrhage patients, so the brain is tense. So start with the osmotherapy. With medical treatment, you always start with the medical treatment, osmotherapy with Lasix or mannitol, furosemide, whatever. Keep the head position at 30-degree level, and appropriate anesthetic agents, and ask your anesthesia colleague to hyperventilate the patient. And if all these major fails, then you do the CSF diversion, which can be done either prior to surgery, like putting EVD, or sometimes intraoperatively you put EVD, or you can use lumbar drain. But the lumbar drain, the problem with the lumbar drain is it's a very small diameter, so easily it gets blocked. Or the volume of the CSF you want to drain, you cannot drain. You need a lot of, I mean, sometimes you need hours. So, if needed, you do external ventricular drainage. Next, please. And this is the position for any ICA aneurysm, patient in supine position, and put a shoulder roll ipsilaterally. And this is because just that your normal brain that falls along the gravity. Next, please. And head position for this location aneurysm is around 30 to 45 degree. For ICA, it's 30 to 45 degree rotation, and around 10 to 15 degree extension. Again, the principle is you fall, I mean, all this frontal lobe that falls goes with the gravity. Next, please. And regarding, I showed that the head is fixed, but you have a choice. There is no difference. You can fix it, or you cannot. You may not fix it. It is otherwise to do neuro monitoring like EEG in SSCP, because it has a greater role while you do the temporary clipping. Next, please. And craniotomy selection for all ICA aneurysm, classical terminal is standard. It is standard. So you see, but the extension, I mean, in the incision, you have to preserve superior temporal artery and facial branch. So you start the incision from the inferior edge of the posterior zygomatic arch and cross the frontal hairline. Next, please. Always keep two suction. One, like 5 French, and another is bigger, because this is the most important tool you require for aneurysm surgery if there is intra-op rupture. Next, please. And intraoperatively, as I said, you always try to preserve superior temporal and branches of the facial. Next, please. This is the elevation of this temporal muscularis flap. You see the zygoma is clearly exposed, and as inferior you can go. Next, please. Single borehole at the temporal location, which is the thinnest part, you can do and do the craniotomy. Next, please. So pre-flap craniotomy being performed. Next, please. And you start. This is the most important another step to do any IC aneurysm is drilling going to the skull base. So at the beginning, you can start saving these things with bone nibbler. And next, please, interactive tools. And actually, when this double layer of this dural fold comes, this is the limit where you use bone nibbler or Harrison render or anything. You take a drill, high-speed drill, and start drilling. Make this all these structures as flat as you can. Next, please. Next, please. And how you open the dura, it depends. Somebody, they prefers or literature suggests you open it from the mid portion of the mid portion, but we open from the frontal and we start closing from the temporal side, because the chances of if there is cortical injury, frontal lobe is safe compared to other. Next, please. And prior to open the dura, you please prepare all these instruments, all these applicators, remover, or temporary. Get ready for temporary clip, because sometimes after sudden decompression of the CSF after opening the dura, there is chances of intraoperative rupture of the aneurysm. Next, please. And this is regarding the Sylvian dissection. Please. So I think Sylvian dissection will not spend much time, because this has been briefly discussed in by Dr. Yamrukai in another one of his lecture. So regarding the CSF, how much CSF you drain? Remember, to do nice Sylvian dissection, you should. You don't please suck maximum CSF as you can. You have to keep this Sylvian veins, Sylvian arachnoids, little bit bulged, so that you can do the dissection. And another technique is you take a small cottonoid, and put that cottonoid in the temporal area, so that you make some retraction and you start dissection. Dissection, where to start, whether frontal side or temporal side or medial side or lateral side. There are various theories, but the most important is, one thing is, if you can do you can do this use of ICG and see where the minimal perforators or branches are going. But what's the safest is you start from the Sylvian frontal side. And first you start with the needle, and then continue with the use of scissor and then sometimes micro dissector and scissor. While you go down, it's a dura, again, it's a fold, it's an arachnoid fold, which is very thick. You have to divide it. Unless you divide it, you cannot separate frontal and temporal nicely. Next, please. This is while you reach there, this is how you do the perianeurysmal dissection. So always when you reach down, when you open the opticocarotid cistern, first thing, you go and try to make the spaces for your proximal control. Make the space for your temporary placement of the clip. It is not advised. You try not to put temporary clip unless it required. So you see from in this picture, you can see all these structures which needs to be identified, like bilateral, optic, and chiasm, and internal ICA. There is an aneurysm, and clearly you see M1 and ACA. Everything you can appreciate in this picture. While doing the perianeurysmal dissection, you always then start from the neck. Never go to, or unless you do the permanent clip of the aneurysm, you don't jump to the dome. And after you clip, can you forward? Yeah, this video, little forward. So after you clip, after you put the permanent clip, make sure you see both the blade of the clip clearly. You look for the normal anatomical structures. In paraclinoid, you must see where is the pecum, where is the anterior corridor, and other structures. Next, please. So next video, please. And this is another video, and you can fast forward it. And in this video, again, we have tried to do the clipping of the aneurysm, but after two attempts, we could not put the aneurysm in the neck because probably the aneurysm size was very big. It was so tense, and in this case, we had to apply the temporary clip and then finally the permanent clip. Next, please. I think this is the end. So most important thing doing aneurysm surgery is having calmness, patience, and suction. These are the success to any successful aneurysm clipping. Thank you very much.
I'll be talking about transpedical fixation of cervical spine, which is another armamentarium to fix the spine posteriorly. And there's a lot of fear about injuring the vertebral artery and the nerves. So I'll try to simplify what I feel is one. So transpedicular fixation is something very, very strong fixation where the screw goes right from the pedicle, from the posterior part to the pedicle to the vertebral body and fixes all the three columns. So it's a very, very rigid and strong fixation. And the most important is the identifying and knowing about the anatomy of the pedicles on the both sides. And among the pedicles, it is the relation of the vertebral artery, which is on the medial side. The root goes out. So we know where the safe zone is. Now, if you know about the pedicle of the vertical, the most important part is the angulation of the pedicles is very important, which is 30 to 50 degrees, in contrast to the lumbar and the thoracic, which is almost vertical or very little inclined. So the success of putting a cervical screw is inclining the screws at 30 to 50 degrees. If you fail to incline the screws to this angle, you'll definitely rupture the vertebral artery, you'll definitely injure the cervical root. So this has to be borne in mind. And we have the dimension of the screw. This is almost 7 mm. So putting a screw of 3.5 mm, it should not be a problem if we're using the right direction. This is a positioning where the shoulders are strapped just to expose the C7 root, to put the screws. Now, important points are we need a longer incision, a wider exposure, accurate entry point, angulation of the pedicles we have to bear in mind. And we should always use a fluoroscope, X-ray or navigation guided, never a freehand putting screw. That is really dangerous. Right, the incision is longer because the exposure you have to expose from one lateral end of the lateral mass to the one lateral part of the lateral mass. So this needs, and you have to expose right from the occiput right up to the C7. And you have to scleronize the lateral mass because this procedure depends on identifying the bony marks of the pedicles. So all the soft tissues has to be scleronized. The angle should be appreciated. Now, if you go for the entry point, it is a few millimeters below the superior articular facet and from the edge. So with this entry point identify, if you can, these are the 5 instruments I use. I don't use any mechanical drill. It's only with the hands I use. So as we go, I will be talking about one. And the most important part is the sound which we use to see where we are. Now, once we have identified the entry point, we put first is the identifying and maintaining the angle throughout the procedure. Right. And I prefer to stand on the head of the patient so that I have a control on both the sides. And you have to use both the hands to hold the instruments. You cannot hold it, suction with the one hand and be confident to do that. We need to steady both one. So the alignment of the screws has to be known. Now, again, if you do an X-ray, we have the direction of the screw should be parallel to the end plates. So it will be a cranial one in C2, C3, C4. C4 is almost parallel, and C5, 6 it is little caudal. Now, screw should be, I'll omit one, but this has to be under fluoroscope guidance. I will not recommend anybody doing a freehand. And every time you we first put a mark, then we check with the sound whether we are in the bone or not. So this is a tab which initially we used to make a hole. Then using a drill, the pedicle is almost a centimeter only. So you really don't have to go any further inside. So as long as you can get a 1 centimeter bony tunnel through this procedure, you are in the bone. So after that, I don't use pedicle finder, but sometimes the bone is a little tough, you may have to, but you have to have a control with both the hands before you really can get into the body. Yeah, and the screws I use are usually 3.5 by 22 millimeters. And maintaining the angles, we put the screws. And during putting the screws, we don't have to put any pressure. It's just the rotating the handle. The slide will slowly glide into that space. You don't have to use any force to get into that. And our aim is to put 2/3 of the bottle body and put the screws on both sides, then only put the rods. And we bend the rods so that we reestablish the cervical lordosis. And post-operative color is just to control pain. We don't really encourage doing that. And what I usually recommend is put the most cranial and the caudal one screws first, then follow in between so that you don't have a zigzag screws putting, and you have struggle putting the rod during that time. And fusion is very important. So you may have to drill the pedicle a little and put the rod. So this is the final outcome, probably in these transpedicular screws. Thank you very much.
Good afternoon. Talking on how I did a endoscopic odontoidectomy. The indications of odontoidectomy there are a few indications, but these days most of these indications can be done through a posterior approach and by only fixing the C1, C2 joint. But And regarding the approaches, there's in the early days, the transoral approach was advised, and there are some descriptions of more extensive approaches like transfacial approaches. But both these approaches tend to be very cause more injury to the soft palate and other areas. And more recently, with the development of endoscopic surgeries, extended endonasal approaches has been described for odontoidectomies. So I came across a patient with this odontoid fracture who had there's a fracture of odontoid with displacement of the C1 posteriorly, causing compression of the thecal sac and spinal cord. And on the MR, there were some signal changes in the spinal cord as well, but the patient was neurologically intact. So we decided to go for an endonasal approach for this. So we started with lateralization of the inferior turbinate and excision of the posterior part of the inferior turbinate, then visualization of the posterior nasopharynx, and then made a longitudinal midline cut. And because of the displacement, there was very thick fibrous tissue in front of the bones. So it took quite a while to get up to the bone. And we finally could feel the bones after much dissection. Now we get to see the tip of the anterior arch of C1 and the C2 body. Then we started drilling off the C2 body to get a lower trajectory towards this fractured bone segment. After that, we got some space, then we started drilling off the anterior arch of C1, starting from midline, then gradually drilling off laterally to get more space so that we got better view inside. These further drilling laterally, more drilling, and then we palpated the bone to see the free edge of the C2 body, and then further drill the C2 body down to get more inferior trajectory. Upon doing this, we try to manipulate the fractured bones, but it was very tough and tight. And then we went for a resection of the ligaments that was tethering the bone to the side. And then further drilling was needed to get more space. Here is the view that we got, and this is trying to get more ligaments out to reduce compression. We use different tools for that. And once we saw the dura, we knew that we had done some adequate posterior decompression and the dura was free. There's more further drilling, trying to get to the base of the fractured segment that was there, and more resection of the ligaments at the same time. This was a very long surgery. Then this is where we see the C1, C2 joint on the patient's left side and on the right side, the C1, C2 joints. And we try to check the extent of resection that we did with the intra-op imaging, but the problem, we were not very sure as to how much we had actually done. And we wanted to get a CT scan done, but unfortunately on that day, the CT scanner in our hospital was under maintenance. So we had to just close and we performed a CT scan next day. And we found that there was a big chunk of bone still present there. Fortunately, we didn't treat the patient and put screws posteriorly. Then we took the patient up for surgery again. And we used the same initial approach. And then, so through the same incision, we started drilling more. So the more focus was on the body of the C2. And we used measurement using a small tape. And then once this fracture segment were free, then we started further drilling it off. We tried to pull it out, but it was really stuck to the ligaments and other fibrous tissue that was there. So the idea was to drill it down thin, drill it down, and try to get an eggshell using the eggshell technique and really drill it down so that we could pull it out. There's more drilling to really thin it out. This is a small thinned out bone that we got. And we used this tool to really try to pull it out. And this is the last segment of the bone, that the fracture segment that we pulled out. Then check for any palpate the area for any residual bones, and then packed it off with gel foam. Then in the same day, we flipped the patient down in the prone position, and then went for a C1, C2 fixation. Here is exposure of the C2 ganglion, and we cut the C2 ganglion. Now on the left side, we cut the C2 ganglion there. Now we drill the C1 lateral mass. We were drilling off the C1, C2 joint here, and then we started tap and then put screws in C1. And this is screw placement of screw in the C2 parts. And then put rods and secure the rods to get us from construct. And this was the post-op scan. We had adequate decompression and a good rigid fixation of the patient. And this is the patient that came back to us after 6 months post-op. He was neurologic intact throughout the period. In conclusion, the indications of odontectomy is very limited these days because of C1, C2 fixation, but an endoscopic approach is far more superior to the transoral approaches that have been described previously. Although there's a steep learning curve, this is a very useful technique, very selective cases. Thank you. Questions?
Thank you. Thank you, all the speakers and my co-chair. I think we conclude this session here. Thank you very much.
Thank you, gentlemen. That was quite an interesting talk. Moving on to our last session of the day on neuro-oncology and critical care. I would like to cordially invite Dr. Sushila Jaiswal from SGPG IMS Lucknow, India, and Dr. Bipin Chaurasia on stage to moderate the session.
So good afternoon, everybody. First of all, I would like to thank organizing committee for giving me an opportunity to present this talk on molecular markers in glioma, what a neurosurgeon should know. So the WHO 2016 for the first time has introduced molecular markers in addition to histology. So what are the advantages of molecular markers? These molecular markers are objective rather than subjective, and many molecular subtypes have been recognized under single histological entity. And the diagnosis and prognosis of some of the tumors are better recognized with molecular markers than histology alone. So all these leads to better patient management. So these testing for these molecular markers are not available everywhere. And these molecular markers are introduced as a layered format in integrated diagnosis, that is in form of combined histopathological and molecular diagnosis. So these testing for these molecular markers are not available everywhere. So WHO 2021 has introduced certain terminologies to resolve this issue. That is, the first terminology is not otherwise specified, that is NOS, in which molecular tests are insufficient, not available, not performed, or not successful. It alerts the oncologists that the molecular testing has not been performed. Another terminology is NEC, that is not elsewhere classified, where the proper histology and molecular analysis have been done, but the findings are not fitting into any of the current WHO classification, and it alerts the oncologist that tumor does not conform to WHO diagnosis. And the third change that has been made by WHO 2021 is replacement of the Roman numerals with Arabic numerals to reduce the typographical error. So this is WHO 2021 classification of glioma. And I would be, to respect the type, I would be concentrating on adult type diffuse glioma only. So to understand molecular markers, the proliferation of glial tumors can be divided into diffuse and circumscribed. The diffuse can be divided into adult and pediatric type. Pediatric is again classified into high grade and low grade. So adult diffuse glioma and pediatric high grade gliomas, IDH should be done, while in pediatric low grade glioma and circumscribed glioma, there is no need to do IDH mutation. Although IDH mutation is an early event in gliomogenesis, but this IDH mutation can occur, this gliomogenesis can occur without IDH mutation in the presence of high grade feature. Then it is classified as glioblastoma, IDH wild type, at WHO grade 4. And if IDH mutation occurs along with 1p19q, then this is classified as oligodendroglioma, WHO grade 2 and 3. And IDH, in astrocytoma, if IDH mutation occurs, then it is classified as astrocytoma, WHO grade 2, 3, 4, depending upon histological features of high grade. So in this category, so ATRX mutation and P53 mutations have been found in about 60 to 80% of cases, and this indicates astrocytic lineage. So presence of ATRX mutation indicates astrocytic tumors, while this ATRX and P50, 1p19q co-deletion, these are mutually exclusive, means if one is present, another is absent. So what are the optimal molecular markers which can be done in case of adult diffuse glioma? In astrocytomas and oligoblastomas, one should do IDH, ATRX, P53 mutation, while MGMT mutation is done in high-grade gliomas. While in oligodendrogliomas, IDH mutation and 1p19 deletion should be done. So now coming to these molecular markers one by one. So isocitrate dehydrogenase mutation, it is of two types, IDH1 and IDH2. Among IDH1, R132H is the most common, which can be detected by immunohistochemistry and is seen in 90% of the cases. And rest of the subtypes can be done by sequencing. But in all immunonegative IDH cases, cases, the sample should be subjected for sequencing before calling it as IDH wild type or IDH negative. But WHO says if the patient's age is more than 55 years of age, then there is no need to do sequencing, because the other subtypes in this age group is rarely seen. So what is the importance of IDH mutation? It has a diagnostic value as well as a prognostic value. Diagnostic value in the sense that it helps in differentiating reactive gliosis from glial tumor, provided the tumor is IDH mutant. And it has a prognostic value because patients with IDH mutant glioma survive significantly longer than those with an IDH wild type. So this is our experience of IDH mutation in glioma. So now coming to another marker, that is ADH and ATRX and P53 mutation. Both of these mutations can be detected by IDH. Both of these can be detected by IDH, just like IHC, just like IDH, and loss of ATRX and nuclear P50, nuclear expression of overexpression of P53 indicates astrocytic lineage. So associated lineage, then the oligodendroglioma. So both of these, that is ATRX, which is associated with ATRX astrocytic lineage by correlation of 1p19q is associated with oligodendroglioma. These are mutually exclusive. So what is the importance of ATRX in P53. So this is used to done whether 1p19q is needed or not in case of a oligodendroglioma. Suppose if the patient, if histologically the features are of oligodendroglioma, that is perinuclear clearing and chicken wire appearance, and ATRX is retained and P53 is not overexpressed, it means this is not astrocytoma, so one can avoid doing 1p19q co-deletion. This is our experience of IDH and ATRX P53 in glioma cases. So now coming to third marker, that is co-deletion of 1p19q. Just like IDH, in this IDH mutation and 1p19q co-deletion, both of these are considered as genetic signatures of oligodendroglioma. So what is the importance other than this diagnostic value? It has a predictive value because they are sensitive. These patients respond to chemotherapy and associated with improved survival. And they can be performed by FISH on formalin fixed paraffin embedded tissue. Now coming to another marker, that is CDKN2A-B deletions. So normally this CDKN2 encodes two tumor suppressor proteins, that is P16 and P14 ARF. So normally it causes apoptosis, that is cell death, by involving P53 and MDM2. While if the homozygous deletion occurs, it causes DNA replication, that is cellular proliferation, especially in case of astrocytoma WHO grade 4, and it can be detected by FISH just like 1p19q or FFPE. So what is the role of CDKN2A deletion, 2A and 2B deletion? So presence of a CDKN2A and B deletion in astrocytoma WHO grade 2 and 3, in absence of necrosis and microvascular proliferation, jumps the diagnosis to WHO grade 4. So this is a WHO 2021 classification. I would be concentrating on adult type diffuse glioma. In this category, we have three subtypes. That first is astrocytoma IDH mutant, WHO grade 2, 3, and 4. So now coming to this, so entities removed in this category are diffuse and anaplastic, and astrocytoma IDH wild type WHO grade 2, 3, and 4 is no longer used. The new molecular marker added in this subtype is CDKN2A-B. Example, 35-year-old male patient presented with right frontal mass. On histology, it shows astrocytic tumor with increased cellularity. GFAP is positive, indicating this is a glial tumor. And on immunohistochemistry, it shows IDH1 positivity, while ATRX is lost and P53 is overexpressed. So these two markers indicate that is astrocytic lineage. And Ki67 is less than 1%. So histological diagnosis is astrocytoma IDH mutant, WHO grade 2. Not moving, but the story doesn't end over here. On FISH, this is the CDKN2A is deleted, so the diagnosis become astrocytoma IDH mutant, WHO grade 4. So the layer diagnosis is astrocytoma IDH mutant, CDKN2A homozygous deletion, CNS WHO grade 4. Now another category is oligodendroglioma IDH mutant 1p19q co-deleted grade 2 and 3. So in this category, the entities removed are oligoastrocytomas and anaplastic oligodendroglioma. So coming to an example, 44-year-old female presented with right frontal mass. On histology, it shows typical features of oligodendroglioma, that is perinuclear clearing and chicken wire appearance. On immunohistochemistry, IDH1 mutation is positive, while ATRX is retained and P53 is not overexpressed. It means this is not an astrocytic tumor, and Ki67 is less than 1%. So the histological diagnosis is oligodendroglioma IDH mutant, WHO grade 2. As we have the facility of 1p19q co-deletion, this is not moving. So the 1p19q is co-deleted. So the histological diagnosis is not moving. So oligodendroglioma. So integrated diagnosis is oligodendroglioma IDH mutant 1p19q co-deletion, CNS WHO grade 2. So the third category is glioblastoma IDH wild type WHO grade 4. In this, the terms removed are multiforme and glioblastoma IDH mutant WHO grade 4. And the subtypes which are not to be written in conclusion is giant cells, epithelioid glioblastoma and gliosarcoma. These are to be written in description. Now, to label it as glioblastoma IDH wild type, one should have histological features of microvascular proliferation and or necrosis. And if these are absent, then one should go for molecular markers, that is EGFR amplification and or third promoter mutation and or combined gain of chromosome 7 and loss of chromosome 10. So coming to an example, 62-year-old male patient presented with temporal mass, HNE shows increased cellularity, and it shows on immunohistochemistry IDH negative, that is IDH wild type, but here the patient age is 62-year-old, there is no need to do sequencing. And immunohistochemistry, ATRX is lost and P53 is overexpressed, means this is an astrocytic tumor. So histologically, there is absence of microvascular proliferation or necrosis, and it is wild type. So EGFR amplification as a molecular marker is done, and it showed amplification. So the layer diagnosis becomes glioblastoma IDH wild type EGFR amplification CNS WHO grade 4. So next marker is MGMT promoter methylation. It encodes the DNA repair enzyme. It is to be done in glioblastoma, and it has a prognostic and predictive value, as we have to see whether it is methylated or unmethylated. If it is methylated, these patients respond to temozolomide. If it is unmethylated, they respond to radiotherapy. And it can be done on formalin fixed paraffin embedded tissue by methylated specific PCR. So now coming to touch upon pediatric tumor, the most common pediatric glioma is pilocytic astrocytoma, and the most common molecular marker seen in this category is KIA1549 BRAF fusion, followed by other BRAF fusion, BRAF mutation, and so on. So this BRAF alteration is location specific, means that BRAF fusion is seen in infratentorial region and BRAF mutation in supratentorial region. Other than pilocytic astrocytoma, this BRAF V600E mutation can be seen in other glial tumors like pleomorphic xanthoastrocytoma with aneuploidia, ganglioglioma, and so on. So, for example, 7-year-old male patient presented with cerebellar mass in December 2017, and a radiological diagnosis of pilocytic astrocytoma. Biopsy was done. It showed diffuse astrocytoma, but as radiological diagnosis is pilocytic astrocytoma, and we have the facility of BRAF fusion. We did BRAF fusion, it turned out to be positive. So the final diagnosis given was pilocytic astrocytoma. Follow-up MRI was done in January 2022. The patient, there is no recurrence, and the patient is completely all right. So this is our experience of BRAF fusion. Next slide. Next. So to summarize, optimal molecular markers which can be done in adult astrocytic gliomas are IDH, ATRX, P53, and MGMT, grade 4, and glioblastoma. IDH R132 is the most common mutation which is detected by immunohistochemistry. But if the patient age is more than 55 years, there is no need to do sequencing. ATRX and P53 mutation associated with astrocytic lineage, and 1P19Q and IDH mutation are considered a genetic marker for oligodendroglioma. In case of IDH mutant astrocytoma, the molecular markers of high grade are CDK and 2A and B deletion, while in case of IDH wild type, the molecular markers of aggressiveness are EGFR amplification, loss of chromosome 10, and gain of 7, and third promoter mutation. And GMT promoter methylation is to be done in case of a glioblastoma, because these patients respond to temozolomide. And the most common pediatric tumor is pilocytic astrocytoma, and the most common molecular marker seen in this is BRAF alteration, which is location specific. Thank you.
Thank you, Professor Sushila Jaiswal. Any question from audience? Okay, we will move to our next presenter, Dr. Gopal Sedai. His topic is outcome of surgery for pituitary adenoma or 2-year history. So our next presenter is Dr. Rajiv Jha. His topic is craniopharyngeal post-operative analysis of surgical outcome.
Good afternoon again. Thank you, chairpersons. It looks very disappointing and discouraging to see. So I mean, almost nil participants. The reason why we should not conduct conferences, meetings, seminars in beautiful city like Pokhara. Anyway, even for a single person, you have to speak because at least someone is there to listen to you. So I will not go in detail. I'll go quickly because I know I'm doing my presentation just for the sake of the presentation. Next, please. Okay. This is a 7 years girl who was presented to a physician. She was brought with a complaint of headache. And then probably 5-6 months, she had to visit multiple hospitals just for the headache. Gradually, she started having a problem with the vision and was referred to eye hospital. So after 10, 12, almost a year, somebody advised CT scan and then diagnosed as a case of brain tumor in the supracellular area and then MRI. You can see previous MRI. You can see lesion there in the cellular with supracellular extension. So endoscopic intranasal surgery was done and total tumor excision was done. And this is post-op, she developed hydrocephalus. And look at this baby girl prior to surgery and after the surgery. So the surgery went so beautiful. But the girl, she was, obesity, hunger, thirst, sleepy all the time, almost since after the surgery. Next, please. Another 18 years male who was diagnosed as a case of craniopharyngioma. He presented with visual symptoms and then similar story, operated, almost total excision. And while this boy presented to OPD, again, he had the problem with all these hypothalamic syndromes. Next, please. Third case, still in our ward, she got some fever problem. So we are waiting that complication to go. And so this is third. And next, please. And this is the fourth, another case, 68 years gentleman who presented with inability to walk. And it was because of hydrocephalus. And after all the diagnosis, again, it turned out to be craniopharyngioma. So see, 4 cases in this year only. So I'm presenting a series of 25 cases over 6 years. Next, please. So the incidence believed to be 1 to 2 per million population. But I don't know why these days this diagnosis of the disease incidence are increasing. It consists of 3 to 5% of the primary brain tumors. It has no gender difference, but males in the childhood and females had preponderance among the adults. Next, please. And for adamantium matters, bimodal age distribution and papillary usually 45 says. Next, please. Location common is supracellular area, and then supracellular with intracellular, and then other areas. We had one case of even CP angle craniopharyngioma. Next, please. So 3 cardinal presentation is visual symptoms, and then endocrinopathy, and third is features of real ICP. Next, please. Next, please. Hydrocephalus commonly you see in these patients. So in our series, also 60% of the patients had hydrocephalus, and 20% of them needed some kind of CSF diversion procedure. Next, please. Neurobehavioral abnormality, almost you will find in majority of the cases. Next, please. Hypothalamic symptoms is one of the post-op disastrous complication you will see in case of this craniopharyngioma. Craniopharyngioma, it is benign, but definitely it is worse than any malignant tumor. Next, please. There are a few case reports of the intratumoral hemorrhage. Next, please. And next, please. Regarding transformation to malignancy, there are a few case reports where craniopharyngioma has transformed to malignancy as well. Next, please. And these are the tools to diagnose the disease. Next, please, CT and MRI. And even looking at the imaging, you can differentiate whether it is adamantomatous or mixed papillary. Next, please. X-ray, you will see a lot of calcifications. Next, please. And endocrine dysfunction, usually you will find hypopituitarism. But in our series, all other were hypo, except the level of the prolactin was, I don't know why it was higher. Next, please. There are different classification systems, starting from Hoffman and Colley and Sami and Bini. Next, please. Yes, Hargill and associates. But the most recent one is by Puget and co-workers, where it is related with the relationship to the hypothalamus. So see, there are so many classification systems for this craniopharyngioma, but none of them are popularized. So these classifications are only useful to choose the corridor for the surgery. Next, please. This is endoscopic classification. Next, please. And giant, more than 5 centimeters is giant craniopharyngioma. Next, please. Treatment is observation, surgical therapy, radiation therapy, cyst chemotherapy. Next, please. Back. So the treatment, there are multimodality treatment, but the best treatment depends upon the age, pubertal development, growth, size, and the consistency of the tumor, presence of hydrocephalus, ability and experience of the surgeon, and the ability of the radiation and intracavitary treatment. Next, please. Regarding surgical therapy, there are different ways: cross-total, subtotal, stereotactic cyst aspiration or conventional cyst aspiration. Next, please. There are different corridors to approach craniopharyngioma, midline approaches. Next, please. Anterolateral approaches. Next, please. And interventricular approaches. Next, please. And this is one of the patient and had, I mean, you can see even diagnosed as a case of craniopharyngioma. Next, please. And this is a video. I don't think it is necessary. Next, please. I mean, this is, you can see, you appreciate the craniopharyngioma. You know, the best thing is you always isolate this arachnoid and the thin layer which is surrounding the craniopharyngioma. If you can do it, if you can isolate this thin layer, the outcome will be excellent. If you cannot separate this, then there will be hypothalamic traction injuries. Next, please. You can see both the solid and cystic component. Next, please. Okay, this is after opening the cyst. It has both the cystic and solid. So after spillage, I mean, try to limit this spillage to avoid the aseptic meningitis. Next, please. And this is the solid part being excised. Next, please. Next, please. This is a post-op scan, total excision of the tumor. And this luckily recent, I mean, because today is the 6th POD and he has no problem, no complications yet. Next, please. So it is debatable regarding the extension of excision in case of CP. Next, please. So gross total, subtotal, I mean, all the procedures have their own advantages and disadvantages. Next, please. Subtotal resection has got benefit. I mean, this is the recommended things which are coming up. Next, please. Regarding radiation therapy, subtotal, you must give in all the cases. Next, please. Regarding radiation therapy, there are different ways to irradiate the remaining craniopharyngiomas. Next, please. If it is cystic, just you can put the intercavitary bleomycin or interferon. Next, please. Overall survival, you know, this is a beautiful work. You will see almost 7-8 decades, all these big data are here, all big results are here. And there are only one or two who really could prognosticate overall survival. Next, please. And this is probably without and only with surgery or with combination of adjuvant radiotherapy. Definitely the multiple trials has shown after radiation therapy, adjuvant radiotherapy, surgery is always excellent. Next, please. Treatment of recurrence. If it is asymptomatic, do nothing, wait and watch. If it is symptomatic, if you can operate, go reoperate. If previously radiation has not been given, give radiation therapy. If previously radiation has been given, probably this is one of the worst case. Next, please. In our series, we had two mortalities, and majority of the patients, 1/3 of the patient had diabetes insipidus, and almost 40% has pan-hypopituitarism. Next, please. Thank you.
Thank you, Professor Rajiv Jha, for your excellent talk. We are short of time. We will invite our next speaker, Amol Raheja, which topic is transcranial surgery for supracellular lesion, operative nonsense, and relevation of anterior clinic.
Thank you, respected chairperson and dear colleagues. At the outset, I would like to thank the organizers for this kind opportunity to present on the operative nuances and the relevance of anterior clinoidectomy, which is the key to access the middle cranial fossa lesions, primarily the supracellular area, and for the transcranial approach. And also special thanks to the technical team, Samir and his team, to fixing a PhD in my position. I have some couple of videos, so just want to do it in time. So just mixing it up. Here are the slides up there. All right, thank you. All right, so I'll be presenting briefly about this topic, which probably many youngsters and the neurosurgeons in the initial phase of their life need to really understand and work on the basics. It's nothing very hi-fi, but it's really very basic and helps to achieve a good outcome in these patients. So the anterior clinoid process, looking at the basic anatomy, it's nothing but a medial extension of the lesser wing of sphenoid. Has two roots, the anterior and the posterior root. Anterior root essentially forms the optic canal roof, and the posterior root is the optic strut. So what anterior clinoid process does is it's essentially a gateway of access to the middle cranial fossa in the supracellular area. And the dural folds below the clinoid process tethers the cranial nerve second, the optic nerve, and the carotid close to each other, and limits the working corridor between the octave-carotid corridor. So many patients have lesions in the retrochiasmatic corridor where the chiasm is prefixed, and then you have to use an octave-carotid corridor. And if the corridor is very narrow because of the tethering of these dural folds, then you can actually cause more iatrogenic damage to either the carotid or the optic nerve while handling them. So the idea is very simple. So what you do is start with the optic canal deroofing and do it more than 180 degrees of drilling, and then anterior clinoidectomy, core it out, cavitate it. You can do it intradurally or extradurally as per your preference. And then once you divide the distal dural ring, which is medially the falciform ligament, then it gives you at least about 0.5 centimeter to 1 centimeter more space between the carotid and the optic nerve. And the optic nerve is really free to work around it and without causing any trauma to it. You can also remove more of the strut and even release the proximal dural ring to access the carotid cave aneurysms and paraclinic aneurysms. So just a brief operative video. This is a cadaver dissection. Initially, one has to practice on the cadavers to understand the basic anatomy. So just a brief video on that. So first you have to master the cavernous sinus dissection, you have to know the basic steps. The first is to release the meningoorbital band, and then using a combination of sharp and blunt dissection, work on the lateral wall of the cavernous sinus and expose the face of the pyramid of the clinoid process. Unless you do that, you'll be working in a hole and you're likely to damage more on the clinoid process and the optic nerve while drilling it. So you have to expose at least from 4 V1 and V2 till that area, so as to have an adequate access to the lateral aspect of the clinoid process for a safe drilling. Now this step requires a combination of sharp and blunt dissection. And you need to use hemostatic agents like flow seal or Surgiflow should be handy while doing this procedure. Now, once the once the adequate exposure is done, you core it out, you drill it with a combination of cutting and the diamond drill over the clarinet process, and again try to remove the anterior and the posterior root. And once it is eggshell thin, you can actually just pluck it out just like any other tooth extraction. And also in many of these cases, you need to be ready with taking an abdominal fat, because there is high likelihood that there is a sphenoid sinus opening or posterior ethmoids can open the medial aspect, which may require plugging at the end of the procedure. So this is so at the end, you can just pluck out the clarinet process and gives you a much wider area of exposure. Now, once you perform the extradural part of the clarinectomy, we prefer extradural clarinectomy in most of our cases, whether it's aneurysm or tumor case. And then you perform a very wide Sylvan-Fisher splitting to unlock the frontal lobe from the temporal lobe. The idea is that the retraction should be minimal on the frontal lobe while trying to access the suprasellar area, and also removing this arachnoid and the pile adhesions widely can help you do practically a retractor-less surgery and help you have a more favorable outcome. You can expose from ipsilateral A1, ACOM, and contralateral A1 complex as well. Next step is to perform this release of the falciform ligament in this, so that you can actually widen. You can see the optocarotid corridor widening significantly, and that is the key. If you work in a tight corridor and if you try to manipulate the nerve which is impinging against the bony canal, you are actually likely to cause more damage to the nerve while handling it around it. And this is release of the proximal ring in case required, usually not required for most of the neoplastic cases. Now, this is an operative video. This was a giant pituitary adenoma. Patient came with headache and vomiting and visual loss, which was progressive. And the patient came to us during the initial phase of the pandemic. So we didn't do a transfemoral surgery for this patient, subjected the patient to a transcranial approach. We did a cranial craniotomy, and like I showed in the cadaveric videos, we start with the meningorbital band division with a combination of sharp dissection initially, and then we can follow with blunt dissection to expose the V1 and followed by V2. So you can use a number one, you can use a pencil, other proton set dissectors or micro dissectors, whichever are available, so as to have adequate wide exposure of the anterior face of the clarinet process. And then from V1 you go towards the V2, again using the same principles. Then you perform the extradural anterior clarinectomy and optic canal deroofing, as I was showing in the cadaveric videos. And continuous irrigation is the key in these cases to prevent any thermal injury to the optic nerve, which is on the underside of your drill. And you use preferably a diamond drill at this stage, because a cutting drill can actually pierce through your optic nerve as well as the carotids. So once you have, so you can remove the clarinet process like shown here, and you do a wide opening of the optic canal roof. So it should be more than 180 degrees. Some people say you can go almost up to 270 degrees around it, so that you can handle the optic nerve, and it's much safer for the nerve. Then after that you start with the Sylvan-Fisher dissection. Again, you have to carefully dissect the Sylvan-Fisher widely, and the thick arachnoid layer and the pia needs to be well separated. The multiple layers of the arachnoid, the anatomy need not be explained here in this operative video. But the idea is to completely unlock the two lobes from each other, so that you can access the suprasellar area. You can access the IC bifurcation without even need of a tractor. So once you're done with the Sylvan-Fisher dissection, you can see that the IC bifurcation is almost coming even without placement of the retractor. And then you delineate the optic nerve and the tumor interface. After doing that, the next step, as I told in the cadaveric dissection video, is that to release the falciform ligament to about 8 to 10 millimeters, and that gives you a wide enough access in the optic carotid region, especially for lesions where the chiasm is prefixed and the significant bulk is behind it, like for craniopharyngiomas, meningiomas, etc. So you can see the adequate amount of about a centimeter of falciform ligament is released, and you can see the optocarotid corridor is significantly widened. And then you, just like any other surgical principle, you start to decompress it gradually and then create a plane between the tumor capsule and the vital structures wherever they are coming into your field. So luckily for this patient, actually we did a transcranial approach because the tumor consistency was heterogeneous. A part of it was a bit fibrous and some of it was soft. So maybe the endonasal approach might not have actually removed, enable us to remove a significant suppressor part as well. So again, you can see that we're working around the nerves, and there is no undue retraction. So you have to maintain the arachnoid plane, do a careful dissection of the arachnoid, gradual peeling of the arachnoid, so that you can lift up the tumor away from the structures. You don't press on the structure or the vital structures, you just mobilize the tumor around the vital structures. That is the key. You work around the ipsilateral optic nerve, the carotid, the contralateral optic nerves, gradually keep on dissecting it, and after mobilizing it and debulking it. So again, we're dissecting, debulking, the same principle goes on. So again, the tumor capsule mobilization is being done here. Once the adequate bulk is resected, and you can identify by a simple trick while using CUSA or sucker, if the posterior wall starts to flap, that's usually a sign that there is adequate decompression has been done and the tumor capsule can be mobilized quite safely. So you can actually pretty much go right up to the hypothalamus, even at near the foramen of Monroe, if the lesion is going all the way up, and can optimally mobilize it. Next, the lesion again needs to be mobilized from the ipsilateral carotid and working in the optocarotid corridor. You can see this is a cranial nerve third on the lateral aspect. The cavernous sinus was looking a little bulky, so I also explored that, but there was no along the Dowling's triangle, but there was no tumor found there. So next, the attention was diverted towards the diaphragm celli, which was coagulated, and the part of the infradiaphragmatic part of the tumor was also resected, whichever could be accessed easily. Or the tumor was firm, so we didn't really chase it all the way from the cellar. And the cellar part of the tumor, which was left after the surgery, was taken care by the second stage surgery after a few months with an endonasal approach. So you can dissect and expose till the basilar artery, all the cranial nerves can be well seen. And you can see this, all the suppressor part is out. This is a post-op scan after the first surgery. Thank you.
Thank you, Dr. Amol, for your nice talk.
Now I invite Dr. Bibish Kral to present advantages of using sonoscopy in neurosurgical ICU.
Good afternoon, everybody. Today I'll be talking about whether sonoscopy makes any influence in the neurosurgical ICU, and in what ways can we use USC or sonoscopy to make the patient care better. Okay, firstly, bedside ultrasonography or sonoscopy is a cost-effective, non-invasive procedure which provides real-time information, and it's more specific in diagnostic and therapeutic utilities. The point of care ultrasound, also called POCUS, which is a synonym for bedside ultrasonography or sonoscopy, everything. It has proven to be a superior imaging option in emergency as well as critical care settings. However, this is not routinely being used in neurosurgical ICU as there is a steep learning curve associated with it. Various USC courses were started in Kathmandu Medical College, with the first one in 2017. And with this, this was the first USC course that was started. With this in mind, With this in mind, our protocol of the USC was designed for the neurosurgical ICU. The objective of the study was to know the indication and methods used for bedside sonoscopy procedures, how these procedures are done, and to provide a general description of these bedside procedures in neurosurgery ICU settings. The methods, this was a prospective single cohort observational study, which was done in the patients admitted in KMCTS for 1 year. And the USC, we can see this USC is a dedicated one for the neurosurgery ICU. And this was used for multiple purposes for various neurosurgical conditions management. The modalities used by the sonoscopy was in primary resuscitation, as well as in daily secondary surveys, including optic nerve diameter measurement, transfontanel evaluation, transcranial Doppler, screening for DVTs, and transcranial defect ultrasound, as well as it was used to place central venous lines, difficult cannulation, pleural, as well as transfontanel tapping as well. This is a bedside sonoscopy form. All the patients who were admitted in the ICU, we filled the form for this. This is the first part of the form. We started with ONST, transcranial Doppler, DVT scan, transfontanel. Similarly, the lung USC, IVC size, transcranial defect in decompressive craniectomy, EFAST, evaluation of shock, evaluation of hypoxia, if the patient receives CPR, the assistant for that, or other sonoscopy guided procedures. This we never feel we filled only whatever was required in the patient and not the whole thing. So whatever modalities we did, we filled in the form. The rest was not done. So our technique, firstly, the optic nerve sheath diameter. We used a linear probe to put it in the patient's eye, and from there we measure optic nerve sheath diameter 3 mm behind the globe, perpendicular to the optic nerve axis. Mason et al. Has told that if the ONST is more than 5 mm, the ICP being more than 20 mm, has a sensitivity of 94% with a specificity of 98%. So that's a significant amount. So ONST reflecting ICP is a good indicator. Similarly, for the transfontanel evaluation, we used transfontanel evaluation in neonates to monitor for hydrocephalus. In the first video, we can see we can see the dilated ventricle as well in case of congenital hydrocephalus. Similarly, we also used for measuring the size of frontal horn, and if we do it serially, we can see whether there is the decrease or increase in the size of the ventricle, so we can compare that as well. The other one is transcranial Doppler. We did this through a thin temporal window for patients who underwent aneurysm clipping, and we looked for vasospasm, and then a Lindergaard ratio is then calculated, and we check for whether the patient has vasospasm or not. The other one is transcranial defect ultrasound. When a patient undergoes a hemicraniectomy, it provides a very big window for the screening of the brain, and it's more better than doing a CT and MRI because you can there's a big window for that, and we can monitor for if there is a diffuse brain swelling, as we can see in the first picture. We can again measure the size of the ventricle in serial monitoring. And okay, this is also through a transcranial defect ultrasound. We can see the third ventricle and the lateral ventricles are very dilated, and we can also appreciate some separations in between the ventricles as well. Take back the okay, sonoscopy was used for lung as well. We used the flap point, as we can see in the picture. We used we used 3 points for the lung sonoscopy, and we measured. We checked for whether the patient had pneumothorax and collection or not, and mostly we checked for lung sliding. And in the lung sliding, in the motion mode, if there's a CISO sign, it's a normal one. And in case of pneumothorax, if the patient has a barcode sign, we can detect that as well. Okay, and for the deep vein thrombosis as well, we checked only for the popliteal vein and the femoral vein, even though the proper DVT scan is more than this, but in case of neurosurgery ICU settings, if we find any significant findings in this, we repeated the DVD screening with a radiologist. Okay, so coming to the result, altogether there were 240 patients admitted in neurosurgery ICU, and various sonoscopy modality was used as mentioned. So as already mentioned, ONST was measured with patients who had intracranial pathologies. Transcondylar evaluation and tapping was done in patients who underwent meningomycin repair. TCD for aneurysm clipping, DVT patients for prolonged patients who were in ICU. Transcranial defect ultrasound in 30 patients. Ultrasound lungs were done in 45, and so on. Okay, the age of the patient varied from 3 days to 87 years, and most around 63% of them were male. The modalities used was only 27% of the patient we used one modality out of all the mentioned one, and in the rest we used more than one modalities in a single patient. Okay, after we found we did a sonoscopy, we found if there was a significant finding or not. Whenever we found a significant finding, and for example, if we found the ONST was more than 6 mm, we repeated the CT. Similarly, for transcondylar evaluation, if there was hydrocephalus, tapping was also done. Transcranial ultrasound, if you could detect a vasospasm, CT was done to confirm those. Similarly, all the procedures were done like that, and in all together there were 62 patients who got intervened after a significant finding after we did the sonoscopy. Okay, this is a chi-square table. In this, there were altogether 129 patients in whom we found a significant finding in the sonoscopy. However, when we repeated it, only 62% had a significant finding, so we changed the outcome in that. Similarly, in 16 patients, there were no any significant finding in the sonoscopy. However, when the CT or definitive management was done, it was changed in 16 patients. So altogether, in this as well, we can see the p-value is less than 0.01, so it's significant. Okay, now coming to the challenges, there was an initial lag in adopting the technique because there is a learning curve. But however, by teaching a learning modality, the team developed confidence and accuracy, and the time taken to perform the procedure was also reduced significantly. Okay, so what are the benefits of sonoscopy? The sonoscopy is nowadays considered as the 5th pillar of physical examination. It is used for assessing progress of the disease and response to a specific treatment. It can be done bedside. Patient mobilization is not needed. It's a non-invasive ionizing radiation is absent. It is easily reproducible and records can be kept. So these are the benefits. So to conclude, routine systemic use of sonoscopy does make difference for the rapid diagnosis and prompt management of patients. It's helpful in performing various procedures in neurosurgery ICU, and it's helpful to decrease the complication associated with various procedures performing neurosurgery ICU as well. And it should be incorporated into critical care training. Thank you.
Thank you, Dr. Bigvesh Bakral. Now I invite Dr. Binod Raj Bhandari to present out. Now I invite Dr. Binod Raj Bhandari to Sudan. Okay. Dr. Sudan Dhakal to present functional MRI, tractography, and intra-op neuro monitoring in glioma surgery, literature review, and go over it.
Good evening, everyone. I don't know it's loss or gain to speak at the end of the session or end of the day. Can I have the slides, please? So I'm going to talk on the use of functional MRI and tractography in glioma surgery. Though the use of these things has been there for quite a long time elsewhere, we have been trying to make it more regular in our practice, especially when dealing with interaxial tumor. Next one. So as all of us know, these gliomas are primary infiltrative brain tumors, and there has been so many work done on this field to improve the survival, the quality of life in patients with glioma. However, there is no significant change in the survival. There is no significant survival benefit despite of all these things. The previous one, please. Previous one. So when we decide to operate on some any glioma patient, we have a tendency to achieve the gross total resection, maximum resection, let's say, and then when maximum, if we could achieve maximum resection, it is positively correlated with the survival things. And gross total resection of tumor, it not only reduces the relapse, but it also increases the effectiveness of subsequent chemotherapy most of these patients will subject to. So glioma surgery is not something like just taking out the tumor. It is something like preserving the function of the surrounding brain around also. So there are like techniques and technologies that we have acquired over the times and has been developed over the times, which will help us to modify the glioma, to modify our previous surgical practices so that we could achieve a maximum possible resection without giving further deficits. So preoperative workup, MRI brain, this is a very basic tool in diagnosis of brain tumor these days. MRI spectroscopy, though it was there for quite a long time, the clinical use is there for for a couple of decades, where not only it differentiates from low grade to high grade, but sometimes it differentiates from neoplastic with non-neoplastic also. Functional MRI, relatively new armamentarium in the glioma surgery, where we can detect the focus, the functionally active foci, and then we can plan our surgery accordingly. We will discuss in our few slides later on. DTI is a relatively new technology, which with the principle that the glioma is not a focal disease, it is a diffuse disease of the cerebral cortex of the brain. So, and it not only involves the cortex, but it white matter, gray matter. It also involves the white matter fibers. So, and we will talk about it later also. And resting state fMRI, if we talk about the dominant hemisphere, emotions, cognition, and all, the resting state MRI is fMRI is help. And to maximize the resection without giving deficit, intraoperative neuromonitoring is the another tool. Motor evoked potentials, SSCP, visual evoked potential, and direct cortical and subcortical stimulation along with brainstem evoked response. These are the things that we have been using routinely. So this is just the outline of how this neuromonitoring system works. This is the sensory path. This is motor path. It's not working. Right? Yeah, in sensory path, we give a stimulus in periphery, and then we record this the response at the cerebral cortex with the lead, and in the motor, we stimulate the cerebral cortex or the subcortical region, and then we record the stimulus response in the respective motor groups. Disruption at any point of this pathway will give rise to some changes in the monitoring system, thereby thereby warning the surgeon to take some kind of precautions. Let's move on to some representative cases. This is very simple, looks like high-grade glioma under high-grade glioma, but the location is like motor cortex, so it's difficult. We did a functional MRI, and we could see that the foot area, it has been displaced medially, and then the hand area, it has been moved superiorly, not moved, actually it is there in superiorly and laterally of the tumor, leaving us a very small zone to enter into the tumor. So this is another functional MRI where this Broca's area has been depicted is at the lower end of the tumor. So while excising that part of the tumor, we should take precautions, and in select cases, we use awake craniotomy also to avoid that area, injury to that area. This is functional MRI depicting the hand area. It clearly gives us, we have to make our entry as anterior as possible, because posteriorly, if we go posterior, there's hand area, so probably will give more deficit to the patient. Yeah, this is another MRI depicting the foot area in relation with the lesion, so that we can make our entry, avoiding that injury to that area. Yeah, the vernix area, it has been gone anterior in relation to the lesion, so we should make a posterior entry at this in a lesion like this. Yeah, the thing that we have been discussing till now is something called the localizationist view of the cerebral organization. However, the brain does not function in that way. The brain functions in relation with various centers in the brain, and they coin a term called horological interpretation, and that explains the brain function in terms of parallel processing performed by distributed groups of connected synchronized neurons. This is very important to realize, rather than individual centers. So individual centers, they are not autonomous in the brain. It is basically a brain network that functions and gives us the output. And scientists propose that surgical neuro-oncology should not be conceived as a focal surgery because we consider glioma as a generalized disease of the brain. This is very significant paper which tells about gliomas, and after functional brain networks and more the disruption, the worse the cognitive status. That is quite obvious. And it is not a focal disease. We have discussed this earlier. This is network-related disease in which the connectome, the new concept in neurosurgery, appears to contain molecular signatures for clinically relevant functionality. So similar function, the network of the brain that is being involved, they have got some kind of molecular signatures, and glioma tend to follow that signature. Yeah, so when we talk about this tractography, this is the basics of tractography, the association fibers, the projection, and the commissural fibers. Fibers within the lobe connecting different parts of the same lobe, association fibers, connecting cerebral cortex with various parts of the central nervous system, projection fibers, and the fibers connecting similar regions of two hemispheres, the commissural fibers. So these are the basics of tractography that we are going to talk about. Yeah, so this is a picture of the pontine glioma where we obtain the tractography. The tracks has been pushed posteriorly.